Good morning, everyone. Thanks so much for being here. We have several folks online as well. I really appreciate, you're taking the time in this cold weather to attend the Winter Institute. My name is Regina LaBelle. I know many of you, but some I do not. And I want to take this moment to introduce Professor Michelle Goodwin, who is the director of the O'Neill Institute. And is the Linda and Timothy O'Neill Professor of Constitutional Law and Global Health Policy. If you've seen Professor Goodwin's, any of her writings, she's really a leader in healthcare, bioethics, and civil liberties, a member of the American Law Institute and a fellow of the American Bar Foundation, among her many other accomplishments. So with that, I will turn it over to Professor Goodwin.
Thank you so much. Thank you. And can we give a round of applause to Regina and Jelly? They've done in pulling us all together. So I have some written remarks and then just a little bit off the cuff that won't keep you too long. So let me start off by welcoming you again here on this very cold and nippy day here. I was just sharing with Tom outside there that it reminds me of the time in which I lived in the Twin Cities. I spent 10 years there at the law school and medical school, and this weekend rivaled a Minnesota day. My husband and I went out and I thought, oh, where it just really chills you. So welcome in the space of that. And I think that with every kind of challenge, including the kind of bitterness of cold, comes an opportunity. So hopefully it kills off some mosquitoes, some Lyme disease and other things like that. So good morning and welcome here. On behalf of Georgetown University and the O'Neill Institute, I'm really so pleased to welcome you to this very important Winter Institute focused on addiction and beyond. It is truly a star-studded group of individuals who are joining us today throughout the day to share important wisdom. It couldn't be more urgent and timely that we focus on the matters of drug policy, addiction in the United States, and that we begin to break down stereotypes. My work in this domain goes back some time. It's not the depth of area as Regina and Shelley. It's from a different angle, actually. And it's actually personal and it's professional. One aspect of the work that I do is in civil liberties and civil rights. And part of that brings me to matters that affect the lives of women. And far too often we overlook how women experience certain tragedies of life. And addiction is certainly one of those areas, and it connects to incarceration as well. So in my work on reproductive health, rights, and justice, for some time, I've looked at the fact that the United States incarcerates more people than any other country in the world, and it incarcerates more women than any other country in the world. And much of that is associated with drug use, that level of incarceration. And it includes women who come into the system because they've actually sought medical care, a real divide of systems, if you will, that if you are low income and you've needed medical help during your pregnancy, likely you've seen doctors through that lens, public health services. And the trend that's taken place in the United States that's dated back to the 1990s has unfortunately been where if you are a woman of color, particularly Black, you're 10 times more likely to have child protective services and law enforcement called upon you if you answer that question in the positive, and that question being, have you used? What have you used? And what's ironic about all of this is that honesty began the path leading Black women to incarceration, and in some really horrific kinds of ways, being shackled and chained during giving birth, being dragged out of hospitals in bloodied gowns, giving birth on concrete floors of prisons and also in prison toilets. Very different than their white counterparts. Whose challenges during pregnancy treated with prescription medications, given love and support. Now, it's certainly not the case that white women haven't been pushed into these forms of incarceration and surveillance. In fact, they have. What I've often said is that Black women were simply the canaries in the coal mine, suffered through that period of time in the United States where we called them bad moms, crack moms, and their babies, crack babies. All of that stereotyping and stigmatization leading to women taking plea deals of 10, 15, 20 years, even when their babies were born healthy, but just simply low birth weight. One of the things that I found ironic 20 years ago is that at the time researching this, as these women in such pain being separated from their children being put in systems of foster care, which are not great in the United States. And the justification at the time, much being, well, what we can connect this to, because at this time, Roe v. Wade was still the law of the land. If any of these women wanted to terminate their pregnancies through an abortion, they very well could have. But what I found very interesting, and again, it tells stories about wealth and disconnect, was that the rise of assisted reproductive technologies. And with the rise of assisted reproductive technologies, the best chance that people could have at having children born through those technologies was about 35%. That's still the case. And very often when the chance was multiplied, it would be with twins or triplets or quadruplets being born. And as I looked at that, on one hand, these women being incarcerated because they had babies that were 5 pounds born, 5 pounds born, 6 pounds. And yet with assisted reproductive technologies, 1 pound, 2 pound, and just saw that tale of two different cities. All right, well, that's some of the professional look and the arc of time. One of our failures, I think, at that time was reproductive health and rights organizations coming to the aid and defending the interest of women who were drug users, drug dependent. Because if they had, perhaps Roe would actually be still the law of the land today. But those women were largely discarded. They weren't the kind of poster children for reproductive rights. And it's a very interesting thing to see the way in which law works, because those women, as someone once told me, were essentially the roadkill of the American reproductive rights movement. But even more so, I think it's a real tragedy that we fail to pay attention to their lives and give support. But also share one other point and then go to my script here, which is that these issues are personal for me too. Just a few years ago, a dear uncle of mine who was a civil rights leader passed away. He had been with the NAACP in the early part of his youth, leading their national youth program, which ultimately led to the voting rights age being reduced. A lot of people don't know that. They sort of think that voting rights was always 18. It wasn't. It was 21 and then reduced as a result of the civil rights movement. It was very important. But he later became a psychologist and social worker. And so much of the passion for that was because he was gay and in the closet, a person born in the 1920s, Black in the United States, deep in the closet. But the reason why he turned to this is because being in the closet, what he saw during throughout the course of his life, but in particular in the 1980s with the rise of HIV and AIDS, and the way in which people who have been so vulnerable in our society, gay men of color, turning to the use of drugs in some instances to just deal with the pain of societal pushback. And so it became his life's mission, privately, quietly, to try to help folks who suffer through drug addiction and use, because that's what he saw. So anyway, it comes to me in a variety of ways. And I celebrate you, Shelley, and you, Regina, for devoting your careers, telling truth, honesty stories, in your case, Shelley, about what this all looks like. And it's so important that we come together. So now a bit about today and the program. All right. This event is a convergence of the legal, policy, advocacy, and academic landscapes with a singular vital focus, and that is education, so critically important. Over the next 2 days, the point of this is to aim to prepare both the emerging generation of addiction policy leaders and current legal practitioners with the necessary tools and knowledge to navigate one of the most complex and multifaceted challenges that we have in the United States and then also globally. The legal system has long rested on the front lines of addiction crisis, but for decades it has operated in disconnect with bodies of scientific evidence, the lived experience of individuals, and the systemic drivers of addiction. It is through events such as this very important Winter Institute that we bring essential knowledge and understanding to light. And I'm so happy to see students here in the room. So it's critically important that you're here. So grateful for that. It requires advocacy for laws that operate on this evidence and at a time in which evidence is being challenged, quite frankly. On the ground, it requires careful community organizing that reaches the wide array of individuals impacted by addiction. And probably for so many of us, beyond what is professional, we are only 1 step or 2 steps removed from someone in our lives who has struggled with addiction. Education across all of these areas is essential to the emerging generation that will go on to shape policies of tomorrow, ensuring that each step forward we take is informed across disciplines. These core components, science, education, and community, echoes Georgetown's tenet of cura personalis, which is care of the whole person, a principle that is necessary in addressing the complexities of addiction. And I will say that we're really proud at Georgetown that this work is being done. We are excited to welcome both our in-person and our virtual attendees, the advocates, attorneys, and students who will shape the future of public health. And over the next 2 days, this program will feature experts across fields with sessions focused on the foundations of addiction, treatment frameworks, legal issues in recovery, drug scheduling, and criminal justice systems. Guiding these discussions will be federal and state policymakers, municipal leaders, researchers, leaders in advocacy, and experts in community-based work. I thank you all for joining us for this Winter Institute. And we look forward to the conversations held here that will shape more informed, compassionate, and effective addiction policy and law. I'll turn it back over to you, Regina. Thank you all.
Thank you, Professor Goodwin, for kicking us off. And, this is a pretty core group of folks who are here. So I hope you take time during breaks to get to know one another if you don't already. Meet our students, all of whom will be looking for jobs in May. And we hope that you hire them. So what I want to do now is introduce our next speaker, who is Dr. Emily Einstein. Emily Einstein is also a professor in our Master of Science in Addiction Policy and Practice, which as of next year will be in this building. The School of Health is moving to Capitol Campus. This building is brand new. It's adjacent to the Law Center, but this entire piece is part of Georgetown's expansion to kind of take over Capitol Hill, I guess. So Dr. Einstein was with the National Institute of Drug Abuse for a long time. She is now with the American Society of Addiction Medicine, where her title is Senior Director of Quality and Science. She previously served as Chief of Science Policy at NIDA, which is where we met her. She teaches Introduction to Neurobiology, which is in our a fall course. in the master's program, which when we talk to the students when they enter, that they have to take what's basically a brain science class, they all kind of get really nervous, but she makes it very accessible. I always tell them as a lawyer, teach it like you're teaching it to me with very little science background. And that's what she has done successfully now for 3 years. So with that, I will turn it over to Dr. Einstein. And there is a remote that you can use for your slides. Oh, cool.
I think I have it, yeah.
Okay, great.
Hello, nice to see everyone this morning. Let me see if this, okay, excellent.
Is there a way to show them on both sides?
Whoa. I will get that when I'm finished. Yeah, it would be great if I could see it on both sides, but for now, I'll get started. I have no financial disclosures. As Regina mentioned, I am an adjunct professor at Georgetown, and my current position is Senior Director of Quality and Science at the American Society of Addiction Medicine. I did spend a decade at NIDA, and my background is in the basic science of opioid reward. So my career started at a very cellular level, and I'm getting closer and closer to the patient. And I would like to thank my colleagues at NIDA for providing me with some of these slides. So I'm going to start out with the point that substance use is incredibly common. So in the past year, over a third of Americans consumed alcohol. Many Americans consume other substances. And also, this is just an example of sports betting numbers, but sports betting, now that it's been legalized, is increasingly common as well, and it's become a multi-billion-dollar sector of the American economy. This slide is showing you the proportion of people who use a substance who have a substance use disorder. So this is just to point out that the majority of individuals who use a substance don't develop a substance use disorder. And the more available a substance is, the larger the proportion of individuals who will have an addiction to that substance. So that is to say that addictions are very similar to other psychiatric disorders. Unfortunately, substance use is so stigmatized that addiction is treated incredibly differently than other disorders. For example, depression. All of the human experience is familiar with feeling sad, but depression is when despair and sadness interfere with your day-to-day functioning. Addictions are very similar. They're just incredibly stigmatized. So substance use can be something that people engage with occasionally. Alcohol consumption, for example, is incredibly common, and it's something that people use to bond with one another. But when alcohol consumption interferes with someone's day-to-day life, that's when addiction is taking place. So addiction is a treatable and chronic medical condition. It involves complex interaction among brain circuits, genetics, and the environment. And people with addiction use substances in a compulsive way despite negative consequences. So it's important to note that prevention and treatment of addiction are similarly effective as prevention and treatment of other chronic disorders. My remote stopped working. Any suggestions?
At the screen. Clicker stop.
Huh?
The screen's not actually the receiver, so there's a place where.
Worst case, I can pull it up on my computer.
Was on Megan enough.
I can advance.
Yeah.
Oh, great. Next slide, please. Thanks for your patience.
Of course.
At home, when I clap, the lights, it works the right.
Okay, so diagnostic terms. Addiction is usually used to refer to the most severe form of a substance use disorder. So substance use disorder is the diagnostic term found in the DSM. And I've listed out here the substances for which a substance use disorder is recognized within that diagnostic manual. Gambling disorder is the only behavioral addiction that is within that diagnostic manual, but sort of anecdotally, we all know that other behaviors can also manifest as addictions. So internet gaming disorder is listed in that manual as something that needs more research. But many other kinds of compulsive behaviors present clinically, and addiction professionals treat them every day. So examples include compulsive social media use, compulsive sex, and compulsive food consumption that is usually related to the consumption of ultra-processed foods. Next slide.
Oh, there we go.
All right, so substance use disorder has these diagnostic criteria which appear within the DSM, and they fall under these 4 categories: impulse control and impaired control over the substance use is a large category for diagnosing a substance use disorder. Social impairment is also important. So if a person's substance use is impacting the relationships in their lives or their capacity to fulfill their obligations for work and school, that's diagnostic criteria. Risky use is something that indicates a potential substance use disorder. And then also the physiological symptoms of tolerance, which means someone needs to take more of the substance in order to have the same effect, and withdrawal, which means the person's body is used to having the substance on board, and there have been physiological changes. So if the substance is no longer present, the person experiences aversive symptoms. So for a substance use disorder, a mild substance use disorder will have 2 to 3 of these symptoms, a moderate one will have 4 to 5, and a severe substance use disorder manifests with 6 or more symptoms. So on the next slide, I have the symptoms that are within the DSM for gambling disorder. And it follows a similar structure, just without the risky use. So impaired control over the gambling, if the gambling impacts a person's day-to-day life, if they're unable to carry out their obligations because of the gambling. And then there's a version of tolerance and withdrawal that also manifests with gambling disorder. So if someone needs to use more and more money in order to feel the same effect, or they get restless when they're not gambling. So that's kind of like a withdrawal version that's present for this behavior. Something that's important is that you need to rule out the possibility that this is a manic episode. For people who have bipolar disorder, gambling might be an element of having a manic episode. So you need to be sure it's not that in order to diagnose a gambling disorder. For a mild gambling disorder, there are 4 to 5 symptoms, moderate 6 to 7, and severe is 8 or more. Next slide. I don't need to hold this if it doesn't. So addictions are considered a developmental disorder. Most people who use substances are going to try the substance for the first time during their adolescence. And at the bottom of this figure, you can see brain development over time. So what that's demonstrating basically is that the prefrontal cortex of the brain develops last. And so that's in the mid-20s when the prefrontal cortex is finished developing. So the earlier a person is exposed to substances, the more likely they are to develop an addiction. So about 50% of the risk for addiction is going to be genetic, and then 50% of that risk is environmental. Next slide. The brain dopamine system has been identified as the most important signaling element of the brain that underlies addiction. So in the 90s, dopamine was really marketed as like the pleasure chemical, and I think that's sort of still kind of ubiquitous in popular understanding of dopamine. That's not exactly what it is. So it does not underlie the high of a drug. The drug high is mediated by these things called hedonic hotspots and endogenous opioids, endogenous cannabinoids, a variety of different chemicals. What dopamine does is flags for the brain, this behavior should be repeated. And so if you use drugs, that dopamine is released into your striatum. If you use drugs repeatedly, then your whole brain circuitry adjusts to reinforce the fact that you want to continue that drug-taking behavior. So the next couple of slides, I will show you some of the dopamine markers in the brain. So you can see on this slide, dopamine transporters are labeled, and then dopamine receptors, and the metabolism of the brain is labeled. And then the next slide, you can see that there's an adjustment over time if somebody repeatedly takes a drug. So up top, cocaine, methamphetamine, alcohol, heroin, repeated exposure to these substances changes the protein expression in the brain, and it changes the way these circuits are interconnected. So on the next slide, you can see the variety of brain circuits that are involved in the development of addiction. So clearly, reward is very important, and that dopamine release that tells the brain to continue that drug-taking behavior. Learning and memory centers of the brain are involved, motivation and drive, and then executive function and inhibitory control that are mediated by that last part of the brain to develop. Those elements get weaker when addiction develops. So this circuitry becomes disrupted as the brain is continually exposed to a substance. Next slide. So this is kind of another view of the brain, but this is the addiction cycle and the neurocircuitry involved. So that prefrontal cortex area is involved in the preoccupation and the binge intoxication. Oh, sorry, no. Preoccupation is in the amygdala area. So emotion and fear, and then preoccupation, and then binge intoxication are the cycles that a person goes through. So binge intoxication occurs when they take the substance. Withdrawal occurs when their system has become used to having that substance on board and the substance is no longer there. And then after withdrawal, the person becomes preoccupied with the idea of taking the drug. So that's the neurocircuitry that is involved in the addiction cycle over time. Next slide. So there are opportunities for intervention sort of across the span of drug use. Prevention is incredibly important, and ideally people would delay their exposure to a substance as long as possible. Prevention is also an opportunity to strengthen skills that prevent drug use, but also help with other psychiatric conditions. Harm reduction is very important, very stigmatized, but it's really important to keep people as healthy as possible until they're ready to seek treatment. Treatment is clearly an excellent opportunity to keep people as healthy as possible and move them towards recovery. And then recovery is also a period of time that needs support and needs more investment than we currently get. So I'll start with talking about prevention. I think you can move 2 slides forward. So there's also a variety of opportunities to prevent the harms of drug use. The first is universal prevention. So this is prevention interventions that are offered to the whole population, regardless of their situation. Then there's the opportunity to intervene when someone is perceived to have greater risk. So this would be interventions for, say, children of people who have substance use disorder, because their risk would be higher. And then finally, there's an opportunity for prevention when someone is taking a substance but hasn't yet developed addiction. So all 3 of these points are times when intervention could be really helpful. Next slide. Oh, and I think you can, oh, yeah, that's good. So prevention interventions are going to decrease a person's risk factors and enhance their protective factors. So risk factors include neighborhood deprivation, violence, availability of substances, and protective factors include strong relationships, engagement in extracurricular activities for kids, and strong neighborhood environments as well. Next slide. So universal drug use prevention interventions have been demonstrated to not only impact substance use rates in the people who receive them, but there's also evidence that there are intergenerational effects. So if we were to invest in universal prevention, it would be a game changer for the levels of addiction and probably also other psychiatric disorders. I think, unfortunately, societally, we just are not attuned to distal effects of things. So if we invested now, we might see it in 20 to 30 years, but that's a really difficult thing to get policy support for. Next slide. Okay, harm reduction is something that continues to be very stigmatized for drug use. It's a little bit frustrating because harm reduction is super accepted in other areas of life. So like wearing a seatbelt is harm reduction, wearing a bike helmet is harm reduction. But because we stigmatize people who use drugs, harm reduction interventions do not have the same sort of support when they're around drug use. So decades of research support the fact that syringe services programs reduce the transmission of HIV and hepatitis C, and also that naloxone provision saves lives. So neither of these approaches increases drug use. That's kind of one of the arguments against them, is that, oh, if you give people their syringes, then they're going to inject drugs. No, they're already doing that. We are preventing HIV spread. So the graph at the bottom is a modeling study that was done around the HIV outbreak that occurred in Indiana in 2015. So you may be familiar with this, but there was a drug developed called Opana that when it was crushed and put into a liquid, it made a gel-like matrix. And the drug developers had good intentions. They thought that this would prevent people from injecting it. Unfortunately, it just meant that it was viscous enough that people would inject it multiple times and therefore share syringes more. So it caused an HIV outbreak. Unfortunately, syringe services were stigmatized in Indiana at that time, and they were very late to the game. So this modeling study, that little red blip on the side, shows you the number of undiagnosed HIV cases that would have occurred had the syringe services programs been in place. The red to the right is how many actually occurred. And then the same with the light gray. That is cumulative cases. That small light gray is if syringe services programs had been in place. And then the larger one is what actually occurred. So there are absolutely real world consequences to the stigma around harm reduction for drug use. Next slide. So naloxone distribution is also a harm reduction mechanism. It's kind of fantastic that there is something that exists that you can immediately reverse that toxicity of an opioid overdose. A couple of years ago, you might have seen the FDA approved over-the-counter naloxone. So for all of us who can afford the $40, we should be carrying it at all times. And there are community organizations that are dedicated to helping people who don't have that money to access naloxone. Next slide. So novel harm reduction approaches are being piloted. Obviously, we are in an environment where there's less support for these than there have been previously. Overdose prevention centers have been piloted in other countries for many decades. Right now, New York City has 2 overdose prevention centers. These are places where people can use drugs with people on the premises to reverse overdose. Naloxone is a wonderful tool. It is very aversive for people when they have an overdose to be brought back with naloxone because it can precipitate withdrawal. So at overdose prevention centers, people can give oxygen and then also give support for doing laundry and getting people's hair done and just improving sort of the human dignity of people who use drugs. Kiosk supply distribution is another approach for some communities, and they'll have safer drug use supplies and condoms and things in a kiosk that people can access. So there's not the sort of potential for stigma of engaging with a provider. Mobile units offering buprenorphine are also a good approach. Harm reduction in general can be an environment to keep people comfortable, and then they can maybe get a little closer to being willing to seek treatment. And then also test strips are an opportunity for people to test their supply so they understand what's in it. Fentanyl is pretty ubiquitous for people who use opioids, but it's also sometimes a contaminant of cocaine, for example, so people can test their cocaine to see if there's fentanyl in there. Xylazine has been a contaminant in the fentanyl supply, and then medetomidine is emerging as a stronger version of xylazine that is also contaminating the drug supply, and there are medetomidine distributors. Next slide. All right, so for treatment, next slide. This is just a depressing statistic. According to the 2024 NISDA, 12.3% of Americans with an SUD in the past year sought any treatment. So I think this is among the most salient points of addiction treatment to me, is that people are not willing to engage with it. So we can do whatever is within our power to improve addiction treatment, but this is the gap that really needs to be addressed in order for people to be willing to engage with it at all. Next
Could you
slide.
distinguish between a received and sought a little bit?
Oh, yes, great point. And this is received for sure. So within that population, slightly more will have sought it. And then this survey does ask, why did you not end up getting care? And so some people will say, I didn't think I needed it. Some people will say insurance didn't cover it. There are a large variety of reasons that people seek care and don't receive it. But yeah, this is just the receipt number.
So one more follow-up on that.
Mhm.
Of the slide you showed earlier of people with, use versus an actual use disorder, which percentages are that off of? The smaller number of actually people with the diagnosed SUD or the larger?
Exactly, the
Okay.
smaller number. Only 12.3% of that smaller number. And one thing that's useful about that survey is it isn't diagnosed. The people who fill out the survey will say what symptoms they have. So very frequently, they won't have been diagnosed by the medical system, but they will have the disorder. So as far as treatment is concerned, there are only FDA-approved medications for opioid use disorder, alcohol use disorder, and tobacco cessation. So these are the drugs that are currently approved. There are multiple formulations of some of these drugs, and there's a robust research pipeline trying to make more addiction medications available. A point of contention is that at the moment, with the exception of alcohol use disorder, FDA approval of other medications for addiction treatment relies on abstinence only as the metric, which not only is not necessarily the best marker of health, but it's also not always a patient's goal to be completely abstinent. So that's an area of development that the FDA is interested in changing, but not yet. So the majority of addictions, if there aren't medications available, are going to be treated with these behavioral addiction treatments. So it includes things like CBT, which people might be familiar with for the treatment of anxiety, for example, EMDR, which is also helpful for PTSD. And then I'm going to highlight contingency management, because that is the best possible treatment for stimulant use disorders. So cocaine and methamphetamine, there's no medication to treat them, but contingency management has been demonstrated to be very effective. So on the next slide, I'll describe that a little bit. And there's been a recent policy change where the cap of incentive amounts provided under federal programs has been raised finally to an evidence-based amount. So the hope is that contingency management will become more available. The VA is a system where it's currently really well used, but the idea of contingency management is that you get an immediate reward for a concrete demonstration of a goal behavior. So most frequently, that's going to be a drug test is negative, and you receive an incentive as a result of that. And it's working on the same circuitry that underlies addiction. So it's raising the salience of not taking the drug compared to addiction, where the salience of taking the drug is paramount. So the standard of addiction care is set by my current organization, the American Society for Addiction Medicine. A very large proportion of Americans are covered under systems that mandate the use of these criteria. So next slide. That volume that I showed the picture of is for community care for adults, and additional volumes we're working on include treatment for adolescents and transition-aged adults, treatment within the correctional setting, which is a really important point of contact for people who use drugs, and then also treatment for behavioral addictions, which is, as I mentioned earlier, kind of a nascent space right now. And so we're going to give some structure to that. So assessments that are important are the level of care assessment, which is collecting enough information to recommend a person to a specific level of care that addresses their addiction needs, and then also if they have pressing biomedical needs or co-occurring psychiatric condition needs. The treatment planning assessment is a comprehensive biopsychosocial assessment. I think on the next slide, I'm going to show you the domains of that. And then reassessment is important so that a person can move up in care if their condition worsens, or they can move down in levels of care that are less stringent if they're doing well. Next slide. So these are the subdimensions. The ones that appear in blue are the ones that are going to play a role in the level of care that someone is recommended. And then the ones in black are taken into consideration for the level of care a person actually receives. And I think just what I would highlight here is that person-centered care is the priority. And someone might be recommended a certain level of care if they are not comfortable receiving it, if the kind of structure of their life doesn't allow for it, if they have childcare needs. the clinician needs to work with them to give them a level of care that they are willing to engage in. And I think that harkens back to that number of 12.3% of people who seek treatment. For people to seek treatment, it needs to make sense for their lives. Next slide. So there are all sorts of potential barriers to care, as mentioned, and as assessed by that survey. There are resource constraints. People need to parent. If you don't have transportation, that's a real problem. So methadone, for example, is only offered in the context of an opioid treatment program, so a methadone clinic. If you don't have transportation to get to the clinic, you can't take methadone. There are obviously employment responsibility. If someone's uncomfortable receiving care in a certain context, then that might lead them to not engage with care. And then there are also external requirements. So this is something that we are working through with that criminal justice volume. Care should be patient-centered when it's in a carceral setting, just like by definition, that's not patient-centered. They don't get to make choices necessarily according to what they would most prefer. Next slide. So there are many challenges to treatment and overdose currently, and I think the shifting drug supply is among the most salient issues at the moment. Fentanyl dominates the opioid market now. It makes treatment more difficult, and all of the treatments that we've developed for opioid use disorder were developed for prescription opioid use disorder or heroin use disorder, and fentanyl is much more potent. Therefore, treatment needs may be different, but policies are still set based on the former drug supply. Methamphetamine use is increasing, methamphetamine and opioids together. There are no medications for treatment of methamphetamine use disorder. So that's why contingency management, yes.
Methamphetamine use, is there any data on that regionally or just nationally?
Yeah, totally. And I haven't looked at it regionally recently. Like, so historically, it was much more common in the West, sort of like methamphetamine in the Western United States, cocaine more in the Eastern United States. I'm sure that has shifted. NFLIS, NFLIS, that's like the DEA seizure data source. So you can look in there, and I know that they break it down regionally in their data for sure. Yeah, so with methamphetamine and cocaine, no medications are approved. Polysubstance use is incredibly common. It's really the rule and not the exception. And then the contaminants have really increased. So xylazine emerged, I don't know, maybe 4 years ago or so, and it's associated with very severe wounds and severe sedation. And now, as I mentioned, medetomidine has emerged as well. It's interesting. I used to work for Nora at NIDA, and when xylazine emerged, she asked my team, why hasn't medetomidine popped up? And our thought at the time was it was too expensive, but I think the actual reason was they hadn't thought of it yet, maybe. But yeah.
On the polysubstance use, do we have any indication as to whether that's out of a take what's available approach or a desire to mix it up on behalf of the user?
Yes, and yeah. So I think people with an addiction will take whatever is sort of subjectively rewarding. But then also when you interview people, sometimes they'll take an opioid to go to sleep. They'll take meth so that they can go to work. The specific subjective effects of drugs are also salient. And then I'll also point out that smoking is incredibly common, and we don't focus on it as much because it's not intoxicating, but probably more people who have addiction will die because of smoking over the long term. It's just less acute. Okay, next slide.
So when you say there's no FDA approved medication, that means there's no medication, or is there research on that medication and it just hasn't been approved?
Exactly, yeah. And people use things off label. So an addiction physician might prescribe someone Adderall for their methamphetamine addiction because it's FDA approved for something else. And something that the FDA is interested in, FDA has the capacity to add an indication to something that's a generic. So if there's enough evidence to indicate that it would be helpful for addiction, then FDA can add an indication. And so they've expressed that recently as a priority for them. But it has to be a generic. So as I'm going to mention in a couple slides, there are compounds that are approved for other things that are very promising, but if they're proprietary, then the company has to seek that indication.
Can you make a comment about the geographical differences regarding medetomidine, for instance? So in Philadelphia, like 90% of the drug supply apparently has methamphetamine. In Maine, we had in 2025, one case in August. Now, you think we're gonna see it increase, or, and I realize that's really not your expertise necessarily, but just a comment on that if you would.
Yeah, and I think that is unclear to me. It seems like the pattern has been, so with fentanyl, it came down through Canada around 2013, started on the East Coast, moved west. Xylazine also is now as far as California. So based on those historical patterns, I would imagine that metamethadone might have a similar progression. I also wonder, like, it's so aversive that what is the benefit for it? But based on these other substances, like xylazine, for example, it's so aversive, causes people to be so sedated, it causes these horrible wounds, but it still has permeated the country. So that would be my guess, but hard to say.
I think in xylazine too, as I understand it as a lawyer and a layperson, it extends the high. So fentanyl acts very quickly.
Exactly.
So if they can lay that out, I mean, it's, and xylazine has, I mean, we're, I mean, at 10%, for instance. But all these contaminants are, they're actually keeping people alive. And because our fentanyl's dropped from 80% to 57%, for instance.
Exactly.
So undoubtedly, that's had an impact on our improving mortality, but it's really not, on the other hand, it's not good for people.
Exactly. But I think that's a really great point, that these sedatives do lower the risk of fentanyl overdose. And therefore, I guess as a supply element, if your customer base is staying alive, then that's a reason for it to spread. So,
Emily, could you say something about GLP-1s in terms of not, of off-label? They're becoming in the press.
Yes.
Are you getting to that? Never mind.
no, it's a great point. So I just wanted to touch on, I think, the two treatment modalities that are the most promising. So neuromodulation is one of them. And neuromodulation needs to be less invasive for it to get good uptake. So deep brain stimulation is implanting electrodes and stimulating deep in the brain. That has shown excellent results, and it's incredibly invasive. So these techniques that are sort of outside of the skull are more promising for long-term results. But I think what's so important about both neuromodulation and the GLP-1s is that they're substance agnostic. So the FDA-approved medications that I showed are working on that same neurotransmitter system that the drug works on, but that's just going to be the one substance. So if someone has an opioid addiction and a behavioral addiction, the methadone is going to treat the opioid addiction. But things like neuromodulation and like GLP-1s work on appetitive behaviors overall. And so they can be really game-changing for people who have multiple disorders. So the next slide is going to, I think, highlight GLP-1s. Yes, so you can see from this slide that GLP-1s modulate that dopamine release that I spoke about earlier that underlies addiction for all substances. So they were developed to work on repetitive food behaviors, but it turns out that that circuitry is important for addiction as well. And then, as you've probably seen in the press, people had anecdotal reports that they were taking these for food and they're like, well, I don't want to drink alcohol anymore. So now they're being very rigorously studied with the hope of adding an indication to the GLP-1s. And my understanding is that both of the companies, Eli Lilly and whoever the other one is, I think both of them have, Nordisk, indicated interest in adding an addiction indication to GLP-1s. So, next slide. So they are a promising compound to potentially treat multiple addictions. There are clinical trials underway. At the moment for opioid use disorder, they're being studied as an adjunct to existing medications for opioid use disorder because it would not be ethical to not provide people with that gold standard of care. But there is real optimism in the field. And I don't have a good understanding at the moment of whether addiction professionals are prescribing these off-label.
They are.
They are? Interesting. Yeah, because there was an issue with availability for a long time, but yeah. And the point I will get to in later slides, but might as well mention here, is that the landscape of drug use changes so rapidly that it just outpaces outcomes. So prescribers are going to be innovating, communities are innovating with harm reduction, because it's just not something we can keep up with the rigorous research that we might prefer. Next slide. Thanks, sorry. So stigma around addiction is an enormous issue that interferes with people seeking treatment. It interferes with people talking about it. And it's a really tricky issue because substance use of illicit substances is illegal. So it's sort of stigmatized in policy, but the stigma around addiction is something that contributes again to that statistic of only 12.3% of people are going to seek treatment.
Question from the chat. What are your recommendations for how states can improve access to treatment?
States improving access to treatment. I think funding is incredibly important. I think the biggest issue is not one that states can address. So the fact that methadone is only available through OTPs, there's legislation that's been cooking for a long time to allow for addiction providers to prescribe it outside of OTPs. That would be incredibly important. So something I want to emphasize is that return to use is a normal part of recovery, but that is something that is not always appreciated in policy. So there are still treatment programs that will kick someone out for using drugs again, even though this is a chronic condition and using drugs is expected. So recurrence rates for SUD are similar to other chronic conditions, such as diabetes and hypertension. And a return to use is just an element that needs to be assessed in those variety of assessments that I described earlier in order to modify a treatment plan. There's somebody who can continue on their road to recovery. Next slide. So also definitely want to emphasize that recovery is possible. So addiction is a brain disease, but this brain disease model is something that people struggle with sometimes because it feels like it's not possible to recover. But like other chronic conditions, absolutely recovery is possible. And these images demonstrate the recovery on a protein level over time of someone who has been using meth, and then 14 months after they've been abstinent, you can see the receptor level returning to a normal state. Next slide. This is a fascinating study with, clearly it's with animals, but it demonstrated that social interaction is preferred over methamphetamine use. So for animals who have been exposed to methamphetamine, if they're given the option of hanging out with a buddy or taking methamphetamine, they will hang out with a buddy. And so if that is delayed, then that effect goes away. If it is paired with a shock, then that effect goes away. But at baseline, the animal prefers social interaction. So I think this is also translatable to the human condition in that the social strengths that are involved in prevention interventions, for example, are incredibly powerful. And also, it's important to note that many Americans report being in recovery. So you can see it's like 74% of people who reported ever having a substance use disorder report recovering from it. So since it's such a stigmatized condition, I think people can sometimes feel sort of fatalistic around it, but recovery is very possible and pretty prevalent. Next slide. So this is the drug overdose curve, which, good news, it's finally starting to decrease, but I wanted to just show the different influence of different drugs over time. So early on, heroin was driving overdose deaths, followed by crack cocaine. The prescription opioid crisis got a ton of attention, but that was supplanted by heroin in about 2010. And then synthetic opioids have been driving overdose deaths in the recent past. Next slide. So as we've discussed throughout today, the substance use landscape is changing. There's much more methamphetamine reported, lots of xylazine, and then as we've discussed, methamphetamine as well. So the drug landscape is shifting incredibly rapidly. And while research is doing its best to assess things as they stand and to develop new interventions, it just simply cannot keep up. Next slide. So as I've mentioned, practice outpaces research. So on this side is this palm card that's been developed by physicians in Philadelphia to give out to people who use drugs. Have you heard of medetomidine? And then on the back, it has various symptoms that you would need to seek care. So it's driving awareness, and physicians are figuring out protocols to treat it on the fly, basically. And then on the right is a clinical consideration that was developed by ASAM because fentanyl is so pervasive. And as I mentioned previously, all of the treatments were developed for prescription opioids or for heroin. And so treatment of fentanyl is a specific situation that clinicians are just figuring out how to deal with. Summary, addiction is the product of complex biological, developmental, and social aspects. Drug use in the US is evolving incredibly rapidly and requires a real-time response. Prevention is incredibly essential. Unfortunately, the effects of prevention interventions are pretty distal, so it's hard for us to prioritize them, but it would be such a game changer if we had effective universal prevention in the US. And then reducing stigma and fortifying support for evidence-based treatment is going to be needed in order for us to improve addiction care over time. So that is all I have. Happy to answer any questions.
The treatment community has been forever dedicated primarily to abstinence-based treatment.
Absolutely.
There is progressiveness happening in the field. There are those who say that the docs are have abstinence under attack. Words like that. I don't agree. That's I'm parodying someone else. But abstinence is a good thing. If something's killing you, maybe stop using it. But it's much more complicated than that. We've got to figure out a way maybe to close this gap between abstinence-based rigidity, recognizing that it's good, and also honoring patient, can't treat dead, right? And how do we work on bringing these things together?
Yeah, I think we need to break down the rigid thinking because, of course, abstinence is going to be healthier for our body, but if someone's mind is not engaged, if they don't feel respected as a human being, they're not going to engage in care. And so I do think listening to people who use drugs is incredibly important and not done as much as it should be. We convened a panel recently of people who have received opioid use disorder treatment, and the level of stigma and sort of persecution they feel in treatment settings is so high. And I think clinicians, it would be helpful to rein in paternalistic sort of attitudes and to see people as individuals. But yeah, it's hard to change the system.
So just following up on that, we say all the time that this is the only disease where if you're symptomatic in your illness, you don't get treatment, you get asked to leave, right?
Exactly.
So that is one of the things that we talk about all the time. And so we've also taught generations of people how to lie, right? Like if I raise my hand and ask for help, I'm gonna lose my kids, my car, my house, my family, my job, and all of those things. And until we stop doing that, we don't say when you get your hypertension under control, I will give you a hypertensive. Like that, it doesn't happen. But as soon as somebody, instead of leaning in, and that's half the problem with why we have 12.3 people only seeking treatment, because it's incredibly paternalistic, created 50 years ago or more for alcoholic white men. And we're trying to fit the social media moms, women, people of color into this narrow definition where there's only one goal, right?
Exactly. Yeah.
And if you are sick, we ask you to leave. When your cancer comes back, when you get rid of your cancer on your own, we'll give you that chemo.
So, yeah. And it's wild how much more stigmatized it is than other psychiatric conditions as well.
Concur.
Yeah. And I am sort of hopeful with novel technologies. I think that population of people who's unwilling to engage with treatment, potentially technologies are going to be able to give them resources that the system is not able to provide because of attitudes like this.
Physicians say recurrence. Most people say relapse, right?
Yeah.
The language is a big piece of it.
Absolutely. And I think we're in an environment where changing language is not as prioritized as it has been.
And that was where my point is, why we talk about recovery rather than remission. Remission is something that physicians in the medical world understands. Recovery is something that's coming from it's from 12-step kind of program conversation.
Exactly. And I think that's one of the issues with the addiction treatment system in general, is that it was stood up sort of out of need and within communities. And so it hasn't been approached the same way as other medical conditions, and that needs to change in order for people to get fixed.
Remission is something that we can, we've got questionnaires, we've got, biopsychosocial sort of questionnaires that we can easily identify that recovery is not as easily.
We do have a question online.
So does ASAP have any information about whether addiction professionals are prescribing GLP-1s, since it was mentioned earlier?
I don't think we've assessed our membership about that, but the leadership at ASIM is very interested in sort of keeping track of the evidence so that when it reaches a point where a clinical consideration could be developed, we will absolutely develop it as soon as possible. But yeah, I would be interested to survey the clinicians.
Time for about 2 more questions. Peter.
Just a quick word on the recovery remission discussion. I mean, they are fundamentally different concepts. Remission is that you either have no longer have symptoms, or the number of symptoms fall below a specified diagnostic threshold. So it's defined as a negative. Versus recovery is defined more broadly. In terms of, yes, there's a disproportionate influence of the 12-step traditions on the concept of recovery and its origin, but you see a much broader recovery community that embraces all pathways. And I think that's the critical thing that we need to build on, not my way or the highway, or not abstinence has to be the goal, which can lead to higher mortality. We know that right away. So I just think we need to try and, let's say, bring the pieces together, because there are tensions, but I think there's a lot of commonality underlying that.
I think that's such a great point, that we do need to have a more medical approach, but we can't get rid of the things that are useful to people.
Yeah,
So the concept
strength-based,
of
building
recovery,
community.
exactly.
Yeah.
Yeah, so maybe clinicians need to define it as remission for medical purposes, while
Sure.
recovery is more person-centered.
I mean, I think whether we believe in abstinence or smart recovery or remission or whatever, the goal we all have, no matter if you're a lawyer, you're a doctor, we want to save lives, right? That's our basis. So we should find the bridges to actually get and do that. If harm reduction works, well, let's do harm reduction. If abstinence works for my friend Jacob, let my friend Jacob be abstinence, like, let everyone, let's hope out people get what they need.
Exactly, that's why
Let's not make it a one
person-centered
use
care
harm.
is so important.
I feel harm reduction does help a lot. Coming from Colombia, we have an NGO called Échale Cabeza. And they've done such a beautiful work of like drug testing, not only psilocybin and fentanyl, but in general. You'll be at a bar or festival in Bogota, and they'll have a stand where you'll take any drug. You'll have a pill, you'll take your Molly. They'll drug test it right there for you, and they'll give you information regarding whether you want to use it. They'll tell you, this is the way to use it so you won't kill yourself.
Exactly.
But they'll teach you, please do not use it. And their focus is mostly on youth prevention. And other thing they do is they've got alerts. So let's say they found a lot of pills that have methadone. They'll put it on the social media. They'll take it to the global media. So everybody in Bogota knows, okay, let's not use this pill.
Exactly. There's a
have-
culture of silence around drug use in the US that is really detrimental. to
We
people's
don't have that in Colombia. In Colombia, you can do alert and tell everybody, yo, this pill has a lot of, I don't know, you're gonna do ecstasy and this pill has fentanyl. We'll just put it on the social media and everybody will know. Here, you don't want people to get the information. And I don't know why that happens here in the US. It's weird to me.
health. Problematic culture.
Yeah,
for sure.
yeah.
Thank you so much. And have more discussion time. Our next presentation, then we'll have a little bit of a break before our treatment panel. Our next presentation is from Lily Spear, who is a member of Hoya Dope. Hoya Dope is a med student program at Georgetown Medical Center. They distribute naloxone all over the District of Columbia. And so I will leave it to you. Thanks.
Good morning, everyone. It's really an honor and a privilege to be here today. So I'm going to be going over the use of naloxone, commonly known as Narcan, in opioid overdose reversal. So we had some statistics quickly, but I know that you just had a fantastic presentation on those and kind of talking about the social disparities that lead to the overdose prevalence, especially in DC. This is going to be more so how to use and administer naloxone as well as when to. So we're going to really talk about 5 key steps on how to recognize an overdose and how to respond properly. This is through the DC Department of Behavioral Health. So at the end, there is a quick quiz where you'll be able to get a certificate, which has certified you as a trained in naloxone administration. Next slide, please. Thank you. So we're going over briefly what is naloxone. So naloxone is a safe medication that can reverse the effects of an opioid overdose. It has 0 effects if opioids are not present, which is why we do really recommend administering it, even if you're unsure if the individual had been experiencing an opioid overdose from an opioid. It's safe to administer during pregnancy, and it's the same dose. It's just going to be 1 nasal spray. I have one brief example, which I'll show you. This just 1 spray into the nose, which we'll get more into details. Again, I really want to emphasize that there are no harmful side effects to administering to someone who is not either taking an opioid or has no opioid in their system, and is completely safe during pregnancy. So really emphasizing when in doubt, and always administer naloxone because it's extremely important. DC, we use the Narcan brand simply because it is the nasal spray. So there are other types of naloxone, which are through intramuscular injections, which require needles. That requires additional training as well as disposal in a designated biohazard container, whereas naloxone Narcan spray can be disposed of in a regular use trash can. Next slide, please. So how does naloxone work? So previous slides would be talking about how the main symptom of an overdose is the respiratory depression. So we know that opioids can cause a lot of different symptoms in a patient. A lot of people use it for that euphoric effect. But the main thing that we're concerned about when it comes to the overdose is with the respiratory depression. And so opioids work by binding to the opioid receptor in your brain, and that can lead to decreased respirations in the body. Naloxone works by coming in and knocking off that opioid on the opioid receptor and replacing it. So it restores the breathing. It takes effect within 2 minutes, and it lasts for about 90 minutes. So an important point that we want to talk about today is that when administering naloxone, it does have a half-life of about 60 to 90 minutes, meaning in that time, it will be removed from the receptor and eliminated from the body. Opioids have a half-life about 4 to 6 hours. So there is potential for administering naloxone and then having the 90 minutes pass, the drug is metabolized, and the opioid is still present in the body. So it can come back and bind to that receptor. So we're going to be talking about the steps that we want to address when addressing an opioid overdose. And one of the main things is calling for medical attention because of this risk of that person going back into an overdose state. Next slide, please. Next slide, please. All right, so these are the 5 main steps that I want you to take away from this presentation. So assessing for an opioid overdose, calling 911, again, getting that medical response on the way, administering naloxone, and then steps 4 or 5 are only if needed or if comfortable. So that will be performing rescue breathing, which we'll briefly go over, and then putting an individual in the recovery position. Next slide, please. So recognizing the signs of an overdose. This is really important because not everyone who is using an opioid is overdosing, right? So we know that there are classic signs and symptoms of someone that may be using an opioid. However, we want to really distinguish them. The difference is in an overdose. So the main signs that we really want to look for are they won't wake up. They have a difficult breathing. It's like a gurgling, snoring sound, or you can look for what's cyanosis or like discoloration on the fingernails, the toes, the lips. It will look different in different skin tones, but just looking for that discoloration, that's indicating that that person is not getting enough oxygen in their body. If one of these symptoms are present, then you do want to administer that naloxone because that means that we'd rather do that instead, because there's no side effects with the naloxone administration. If the person is responsive, though, we do not want to administer the naloxone because that doesn't mean that they're necessarily overdosing. You want to monitor them just to see if they potentially go into that unconscious state, or at least make sure they're with someone, or call 911 if other medical attention is needed. But again, these are really the signs that we want to look for. You can also see tiny pupils and cold, clammy skin. But again, if that person is responsive, you don't necessarily need to administer the naloxone. We'll get into more of the details, but naloxone for someone who is using an opioid will immediately put them into opioid withdrawal, which is an incredibly uncomfortable experience for the individual. So if it's not necessarily needed at that point in time, we don't want to administer it. But again, no side effects, rather administer it than not. Next slide, please. Okay, so how to safely assess. So this is going to be really quick. And the cardinal rule of assessing is making sure you are also safe in the situation. You do not want to put yourself in harm's way, and having additional response needed for yourself. So you could be assessing for those signs very quickly. Again, this should take 5 to 10 seconds. If you're with other people, you designate someone, that's step 2, to call 911 to make sure that that medical attention is on the way. Call their name if you know it. If you walk up to a scene and someone is unresponsive, you can always check their pulse, because there can be something else going on. If you feel a pulse, then definitely administer that naloxone. If you don't, you can still administer it, but then different procedures may occur, like CPR. If they are someone that you don't know, you can say, I'm going to Narcan you. Some people often know what Narcan is, again, because it instantly puts you in that opioid withdrawal, which is incredibly uncomfortable. So that may stimulate someone to respond. We recommend also assessing someone physically, again, if they're unconscious. We'll talk about it in later slides, but we do not want to shake, hit, or do anything. We recommend a sternal rub. So if you take your knuckles like this and feel right here, then find that little notch in between your clavicle and go down right here to your sternum, and even just gently go like this. You can feel how uncomfortable it is. So if you're pressing down hard, it should stimulate a response. So that's the way that we recommend assessing, because it doesn't cause any physical permanent damage to the individual. Next slide, please. So again, calling 911. This is often some examples that we have for an individual who may not want to necessarily say what's going on during an opioid overdose. They don't want to implicate the person or themselves. So the main point that we really want to emphasize, though, is that the person is not breathing, or they are not getting enough oxygen to their brain. And that's why we need that medical response, because the longer the individual is not getting oxygen to their brain, the longer risk for permanent effects or death. So that's really what we want to emphasize. Again, talking back into that half-life of the naloxone, it will wear off before the opioid is eliminated from the body. So we really want to get them to that medical attention to make sure that they're being addressed and monitored, as well as they can help with dealing with the withdrawal symptoms. Next slide, please. So again, administer the naloxone. This is what it's going to look like. Looks like an allergy spray. Do not prime it like you would with an allergy spray. That is the only dose that is in it. So you just want to spray one time in one nostril. If able, you're going to have the individual tilt their head up, place it in the nose so it's up towards the top, and then administer the naloxone. Again, this is one spray, so do not prime it because that will use the dose, and is also only one nostril. So you're going to administer that dose. Each box of Narcan comes with 2, and so you're going to monitor the individual for about 2 to 3 minutes. If there's no change in response, if they do not wake up, you are going to administer that second dose. If you remember what nostril you happen to have put it in, do the other one. If you don't, that is okay as well. That is not a problem. We often get a question about, if you administer 2 doses and there is not any response, you administer more. You can, but hopefully at that point in time, you called medical attention and they're there, because if they're not waking up from that second dose, there may be something else going on that requires different medical attention. So definitely always administering 2 or having 2 with you. Next slide, please. And then the goal is to restore that breathing. So it's that person will get rid of that gargling sound. Their respirations seem normal. They're going to wake up. Again, it might not be like how you imagine, just back and completely with it. It's going to be a little bit sedated. They may not be able to sit up, move, or talk, but if you can see that excessive responsiveness, maybe blinking or like slow moving and things like that, that means that the naloxone is working. But we really want to focus on that breathing, so that really intense sound, or you can see if someone is in respiratory distress, struggling to breathe. We do want to still administer that second dose, even if you're unsure if the individual is conscious or not. It's just better safe than sorry. Next slide, please. Rescue breathing is essential. So this is only if you're comfortable or if you have a CPR face shield. Oftentimes people do not want to necessarily go mouth to mouth with someone they do not know, and that's completely okay. This is more so just to help the individual get that oxygen into their body. We want to emphasize, if you've checked their pulse, we often recommend underneath the neck or on the wrist. If you check their pulse and they do have a pulse, do not perform CPR. CPR is only for those chest compressions to get the blood pumping. And so performing chest compressions when someone has a pulse, oftentimes in the event of an opioid overdose, will cause potentially unnecessary harm, because if you're doing CPR correctly, you are probably breaking the individual's ribs just to make sure that you're pumping that blood. They don't need the assistance. The major issue here is getting enough oxygen. So performing that rescue breathing if you are able. Next slide, please. And then this is the recovery position. So we talked about when the individual wakes up, they may not seem like fully awake like we would expect them to be. So they oftentimes cannot sit up on their own. If that is the case, we want to put them in this recovery position. This is to make sure that if the individual were to aspirate or to vomit, it wouldn't go back down and cause them to choke. So really leaning them on their side, propping them up by using their hands and their legs, if you can see here, taking the top leg and leaning it over, kind of like to stabilize them, and as well as using their hands. Again, this is only if the person really cannot sit up on their own, but this is really essential as well, just because we don't want any other things to happen. Next slide, please. Next slide, please. We don't have time for that. Okay, so overdose aftercare, like I've said, this will immediately put someone into withdrawal if there are opioids present in their body. One thing that I really want to make of note, even if you come up to a situation, it might be a group of people and they said they haven't taken any opioids. I think we've discussed about fentanyl this morning. It is laced oftentimes in other recreational drugs. So we really want to still administer it no matter what, because it could be present and the individual or the individuals just do not know that it's there. So if they have opioids in their system, like I said, it's extremely uncomfortable. Chills, fever-like symptoms, flu-like symptoms, but there are no harmful side effects. It may seem like the person is, going through a medical emergency, but it's not the case. It's just the withdrawal. And then calling that medical attention will also help them be able to relieve those withdrawal symptoms. And then again, just really want to emphasize it's safe to administer during pregnancy and regardless of the age of the individual. Next slide, please. Yes.
Say one thing.
Yeah.
One other side effect is the person I have seen be angry.
Yeah.
And so that wasn't listed on there.
Yeah. So we, from the DC Department of Health, we don't necessarily want to, the individual may be angry and come up, but there is kind of a stigma against administering naloxone and have someone wake up and swinging, and that kind of has deterred people from administering it. So it's not necessarily a direct side effect of that opioid withdrawal. It may be because they're feeling horrible and they're also very confused. So that's completely correct. We do have a slide talking about when to talk about recovery, and it is not the time after administering naloxone. I'm sure you are all aware, but that person has just been a lot and it's confusing. So we do not want to talk about it then, exactly for that reason, because it's extremely uncomfortable and upsetting for the person. They may not know where they are. They may not know what have happened because they accidentally slipped into an overdose. So that is exactly correct. But again, we don't necessarily want to perpetuate that just because that deters people from administering it. So this usually moves, which is really fun, but again, it's like coming on and binding onto the opioid receptor, so it really knocks it off. I kind of already emphasized this point that the reason we want to call medical attention is because the naloxone can break down into 30 to 90 minutes, while the opioids can last for hours in a person's body. We call the medical attention, we hope that they take it, but of course it is their right to refuse it. They do not have to take it. We do encourage then, if you're able to stay with the person, if you know them, then doing that and having more naloxone, or, asking them not to use again and things like that. But obviously they do have the right to deny that medical care. Next slide, please. So these are a few things that commonly some people may think to do. This is just really want to emphasize. Again, we do not want to shake, cause physical harm. As we saw, the opioid is bound to the opioid receptor in the brain. Once it gets into the blood, it's at the brain and it's bound to that receptor, and there's no shaking or knocking it off. It is also not like alcohol. Once it's in the blood, it is there. Inducing vomiting will do nothing besides cause potential harm to the individual. Again, we don't want to put them in a bath or shower to like shock them or wake them up. This is really scary to do that just because if they're in a bath, they are in that respiratory depression state and are at risk for drowning. And then no putting ice or anything that won't shock or wake them up. And we also don't want to do anything to further suppress respiration. Next slide, please. This is also a common thing that people are very concerned about, touching fentanyl. So we just want to stay calm. There are a lot of circulating videos online of first responders kind of becoming into an overdose after interacting with fentanyl. It is not from touching it. It has to be through a mucosal body surface. So just washing your hands will take care of the issue in the event that you've touched it. And do not touch your face, your eyes, your nose, your ears. Any way that it can get into your bloodstream is how it can cause those potential symptoms. But it's not just from touching it purely alone. So just washing your hands, avoid touching your face. Responding to an overdose has never caused a responder to overdose. And then oftentimes people will get panic symptoms after touching it, which is very fair. And then they will associate that with experiencing an overdose. So just knowing that that is not the same. Next slide, please. And then again, like I've said, this is a really difficult experience for the individual, but also for yourself. It can be really jarring. Like you said, someone waking up, they're very confused. You're putting them in this withdrawal state. They are maybe vomiting, having diarrhea, crampy, do not feel well. So you just really want to make sure you take care of yourself as well as the individual. Putting someone through this, you may feel guilty about that. However, you're always doing the right thing by saving a life. So just really emphasizing that. Again, here are some more resources, which I'm sure you all have access to. And then again, just talking about drug treatment resources and recovery is not the time after naloxone administration. Next slide, please. And then proper storage, we just really recommend don't put it in the freezer or really the fridge because it will cause the medication to condense and it won't be able to be aerolized when you spray it. If you're keeping it in your car, we do ask to avoid direct sunlight. So keeping it in a bag or things like that. And then there is a expiration date on the naloxone. However, it is safe to administer the naloxone past the expiration date, and it's better to administer that than nothing. The DC Department of Health will do an exchange. If you come in with a box of expired Narcan, they will give you a new one. But again, administering the expiration date is okay. It may be slightly less effective, but again, it's better than nothing. And then you can just dispose it in a regular garbage can afterwards. Again, if you're using that needle version, it needs to be in a biohazard, but that's why we're giving out the aerolized one. Next slide, please. Any questions? No? Okay. What time? I have like a few more slides, but it's more on like laws. So we can just go through this quickly. Next slide, please. So I'm sure all of you are familiar with the DC laws associated with overdose and naloxone. So one being the Good Samaritan law, and then the second being the opioid overdose awareness law. So the Good Samaritan law, and it is similar to Maryland and Virginia, is acting in a medical situation will prevent the individual or the individual experiencing the medical crisis to have charges related to the, what's going on. So that usually is any drugs, drug paraphernalia, also covered by the opioid overdose law. And then, also underage drinking or providing alcohol to underage individuals. We have had some questions about, does this cover undocumented immigrants? And that's a really important topic in our country today. So it should, obviously, there's difficult situations going on. A undocumented immigrant should be covered by the Good Samaritan law if they are acting in good faith or needing medical care. However, one of the laws only protect against the crimes that are like drug possession, drug paraphernalia, underage drinking, things of that nature. If there is evidence of another crime going on, the individual may be persecuted at that time. So it's kind of a hard situation to deal with, but they should be able to be protected by this law. Next slide, please. So then this is in DC, layperson. So you guys are not considered lay people anymore because you've had this official training. However, if you were to give someone the Narcan that you get today and give it to someone in DC, they are able to carry it around and administer it. Next slide, please. And then where to get naloxone, DC Department of Health. Next slide. So this is where you can get it for free in DC. They do have a delivery system. So if you do text a number, which will be on the next screen, I believe, you can have it delivered. The only thing, thank you, is that it has to be an address in DC. So you do not have to technically live in DC. You could get it delivered here. I wouldn't recommend that, but having the address be in DC, you're able to get it. Or we have many other partner organizations with DC Department of Health where you can also get the naloxone. Next slide, please. Okay, thank you all for your attention. I really appreciate it. There is a quiz for you to get your certificate to no longer be a layperson if you would like to do that now. Some of the questions can be a little bit challenging and we did not necessarily go over all of the details in the presentation this morning. So if you have any questions, please raise your hand. I'll be happy to come over and answer them for you. I think some of them are about the demographics that we see in DC. So just briefly going over that, the opioid overdose, we see that predominantly affecting middle-aged African-American male individuals. However, we want to emphasize that that's just what we're seeing in DC and not to have that form of a preconceived notion of what someone experiencing an opioid overdose will look like. Obviously, we know that's due to the healthcare disparities that we see in DC, especially between different wards, with wards 7 and 8 having the highest prevalence of opioid overdose deaths and fatalities. Great, thank you. Any questions?
It's maybe kind of dumb, but regarding the opioid overdose laws, those only apply if someone calls 911, right? Like if you're walking and the police stop you and you have a kid, then they can arrest you, or does having the kid is legal in all senses?
Oh, so having in DC, having any drug paraphernalia is legal. But not the drug, but having anything that may be
like having
associated
needles,
with
pipes, whatever.
that is legal
In
to
any
have.
case, not
In
only,
any case,
not only
not
if I call 911.
exactly.
Okay, cool.
But then especially in that situation, so we like to tell people that. So if they're in a situation where there may be drug paraphernalia around and they don't necessarily want to call, they're not only protected by the Good Samaritan, but also by that second law.
Okay. Thank you.
All right, thanks so much. So once you do, if you would like naloxone, once you take the quiz, Lily has some. We're going to, and thanks so much. It's great to have you here. We're going to take a 10-minute break desk. So you have that, and you'll have the CLE credits in abundance. So I'm really pleased to talk about now with our next panel to talk about treatment. And, you know, each one of these panelists and panels have been chosen specifically because we've worked with folks for a long time now, and we understand the really good work they're doing in this area. And you hear a lot about treatment. You hear a lot about treatment regulations and the challenges involved in getting quality treatment. And I think these three folks are really exemplars of the good work that's being done in this area. First I'm going to introduce Dee Calvert, who's the director of the Massachusetts Bureau of Substance Addiction Services. I'm sorry about the pats, not
I
really.
know.
And see how I can go off. My son was predicting that they were going to lose though, but I think we all knew.
I was. I kind of knew too.
She served as a clinical director and social worker in the Massachusetts substance use disorder system for over 2 decades, and she's a teaching associate at Boston University School of Social Work and Public Health. Dee Calvert. Mark Ventrell is CEO of the National Association of Addiction Treatment Providers. He leads national advocacy for evidence-based addiction care. He's an attorney and former treatment executive, and he has also served as an advisor to the U.S. Department of Health and Human Services and authored 2 textbooks on law and social justice. And then last but not least is Rob Kent, who formerly served as general counsel with me, with the White House Office of National Drug Control Policy, where he advanced policy for methadone and buprenorphine access. He has served similarly as the general counsel in New York State's Office of Addiction Services and Support, and is currently the president of Kent Strategic Advisors, and also is a proud graduate of Syracuse University. So Rob, you'll kick us off. Thanks.
Great. Hello, everybody.
Hello.
I don't need my slides, by the way, but I don't need them. But if you want to put them up. And when I went to law school, they didn't teach PowerPoint.
They didn't have laptops or
Right.
computers.
Right. When I started working with the computer. You can go, you can move forward. And I apologize because it's outdated. I did update. And then some of it, for some reason, when you try to merge PowerPoints, especially if you're a lawyer, it's an abject failure. So how does the federal government get involved? First and foremost, and we've seen this a lot recently, and I think we're going to see more of it. They fund a lot of the work. I mean, the states really control most of the law, most of the policy, but the feds through funding can control what the states do. Like when you apply for a mortgage and they tell you you have to go to their lawyer and you say, I don't want to. And they say, well, there's a bank up the street. You can go borrow from them. So you don't get a lot of choice. So when I wrote this in early January to meet the mark, we didn't know, but we do know now. So federal policy. As I'm sure most of you know, when the president's budget went up to Congress in 25, they wanted to take the 3 largest funding sources in behavioral health, the block grant for substance use, the block grant for mental health, and the state opioid response funding, merge them into one grant, reduce it by $500 million, and without much beyond that, how it would be used. And so my career has been focused in addiction work. And so no disrespect to the mental health folks, but when you mix the money together, the mental health folks gobble it up and then some. So bad idea. It did not happen. They kept the grants. So Congress did pass a bill in January. It's law. Kept the grant separate. So basically level funding. So the block grant is about $2 billion for well, it's now subters. We changed that when we were in the White House. It stayed level. There's a little bit of an increase. So folks understand. So as Regina mentioned, I came at this work federally as having been the GC at a state agency. So, and I didn't say this to Regina, but the people who interviewed me say, so I know all the places you screw everything up for the state. So if you still want to hire me, I'm happy to do the work. But the block grant, in some states, that is the only funding that supports addiction treatment. There's some states, forget Medicaid expansion, some don't allow Medicaid billing for addiction services. So it's a huge grant. Good that it was increased a little bit, good that it was maintained separately. just for context, in New York, they get over $100 million a year, and most of their funding is spent on residential addiction treatment. So without it, you know, there'd be a huge dent. And folks spoke as well. So policy driving. So part of why there's any funding for prevention, which is the forgotten stepchild of the addiction care system, is the federal block grant requires a 20% set aside for prevention services. And in most places, even in New York almost, that's most of the funding spent on prevention services in the addiction world. SOR grant, and by the way, and I don't know if folks know this, but there's been complaints forever that the formulas used to distribute the SUD block grant don't favor certain colored states or favored other colored states. I don't get into the politics of it. You can figure out where I'm going. When they set up SOR, by the way, SOR started at the end of Obama. It was a state targeted response. Thankfully, it was maintained in the first Trump administration. It was relabeled. It's continued. The formula is driven more on overdoses, so it did tend to favor states that were red in color. But the blue states, so New York, I said, gets $100 million. In SUD block grant, they get about 56 to 60 million in SOR. Targeted to opioids initially, they've added stimulants at this point. But as I said, some states do not invest any general tax levy. They don't allow Medicaid billing. So this money is critical. And so they kept that, they increased it a little, but it's still at about the same level, $1.6 billion. Now, one of the issues I want to raise, and Regina and I raised it before we ended up together at ONDCP, we still keep talking about it, is the Purdue bankruptcy. The federal government settled their claims with the Purdue family and Sacklers. Well, the Purdue company, Sackler family, and incredibly mitigated what they could have claimed. Reason being, if they had claimed what they thought they were entitled to based on their actions, it would have ate up all the money. So there's, I think, $200 to $300 million. And just so folks understand, without some congressional action, that money goes into the general treasury. It'll be dedicated. You hear these words, dedicated, all them, you know, it's an offset, by the way. When a government tells you there's a lockbox or the funding's dedicated, well, the first problem is they hand out too many keys to the box. And secondly, they cannot withstand what they wrote in future legislation. So there is an advocacy piece here that if Congress takes no action, that money goes in the general treasury, and we can hope some of it might end up in the addiction system, but I wouldn't hold my breath. There's another component too, relating to the opioid settlements that the states and local governments have received. There's a whole bunch to be said. I've written about it myself, with New York in particular, about its sort of tobacco settlements redo. So, but there is a concept that the feds, and again, Regina and I push this concept, it's still out there, but part of the state claims and the local government claims is that services, unnecessary services were provided because of the actions of the defendants. Some of those involve Medicaid recipients, meaning the feds paid 50% of the share of the cost of the service. So there's been this debate that we were involved in, it's still not resolved. Is it a mandate to recoup for fraud, waste, and abuse, which this would fit that category, or is it discretionary? And some of us advocated that it is discretionary, but it could be used as a leverage point to ensure that the states and local governments are using it in a way that the federal government sees fit. Now, no one's bought that argument yet, but I still think it's out there to be made. And certainly with regard to the Purdue bankruptcy funds, it would be a massive shame if, what is it, Regina, $200 to $300 million? If that was just put in the general treasury. Because like I said, it's an offset at best. They'll say they used it, yeah, because they backed out other money to pay for services and other things. So just something to think about. Next slide. Yeah, some of the language in here is obviously doesn't look like what. I looked at it this weekend, I'm like, okay. But another way that the feds impact policy in the law is the feds control the controlled substance schedules. And so within that, is that how you access methadone, buprenorphine, whether fentanyl's scheduled, whether fentanyl-related substances are scheduled, you know, and then the thing that the world seems obsessed with, marijuana, and where that should be scheduled. By the way, on this piece, and I'm not saying with full detail, but some of us in the room believe that there already is authority to prescribe methadone for substance use disorder. The current law, current rules. Obviously, me saying it the way I'm saying it, we did not succeed in that argument with certain parts of the federal government, but there's an argument to be made that it could be prescribed, at least by OTPs. So that's an argument, I guess, that's academic still at this point. Telehealth and the MAD Act. So as everyone knows, right, you can access buprenorphine and methadone for pain or other conditions, just like any other prescribed substance, except if you're using it to treat the person with a substance use disorder. Ultimate form of stigma in my head. So pre-Biden administration, COVID, right, the ability to telephonically prescribe buprenorphine, we continued it. There's still an opioid public health emergency in existence. It started in the Trump administration. We carried it forward in the Biden administration, and it's still being, because it runs out. I think it's every 90 days. So it's still continued. And that laid the groundwork initially, right? COVID, we didn't want folks being around each other. So telephonic initiation, which by the way, what we saw and heard was it maybe didn't reduce the number of overdoses, but it certainly contained it in the middle of a crazy public health emergency. So, telephonic initiation is still continued. The DEA, on December 31st, continued a law that expired on December 31st. Well, a rule, I should say. But it's, they said within the regulatory documents they filed, at least the way I read it, they probably won't extend it again. And they had put out a rule in previous years to create what I call the son of X waiver, the special registration. That's likely the route that's going to go. You're going to need some type of registration with the DEA. Now they've made improvements to the rule, but that will probably be the rule, in my opinion. I don't think they'll extend it as is, where there isn't an additional requirement. I think you'll have to go that route. So if you're working with prescribers, you ought to be looking at what comes and how you're going to get that special registration. Again, there's admittedly some flexibility, but that controls how people access a medication that is essential. How does another area is in Medicaid? As much as some states don't allow Medicaid to cover addiction services, many do. And HR 1 will have an impact. Now, to be honest, I think the impact is more about the every 6-month recertification, given the nature of the folks that we care about and try to help, more so than it is the work requirements. Because the work requirements, by the way, in order to stay eligible, you have to be working for food stamps and for Medicaid. But if you're in treatment, you're exempt from the work requirement. And this is actually an area that I'm going to keep exploring, and I hope others do. well, why don't we look to invest some of the money that people keep talking about at the federal level in helping folks be prepared and employed when they leave treatment? By the way, there's another section in HR 1 that fits substance use disorder in a category of medically frail, but it says nothing else. And so it's going to be subject to interpretation by folks. So I'm not holding my breath myself that it's going to be helpful, but it is an avenue to explore if we need to. But folks in our care, for those who run treatment or work with treatment providers, will be exempt from the work requirements while they're in treatment. And it's even their interpretation is going to matter. MOUD in carceral settings, I'm really proud of the work that we did in the Biden administration. But understand something here as we're talking, especially to the lawyers or future lawyers. We did things like require Bureau of Prisons to offer treatment behind the walls. We encouraged and pushed states. And there's a lot of it going on, not nearly enough. But that didn't start through rulemaking or lawmaking. It started because lawyers litigated. And I'm unaware of any case where a lawyer sued on behalf of a client who was in treatment, lost. They made good arguments. There's solid legal theory in law and in Constitution. So, and I think that's an important point for folks to understand. Having worked in government for a long time, there are a lot of people in government who make the decisions, who know nothing about our work, don't like our work, don't want to be helpful. So sometimes you're going to have to use the courtroom versus, the Congress Hall or the Senate or Assembly Hall in the state. So just keep that in the back of your mind. You also should use it, and I don't mean to preach here, so I apologize if I am, but we have to talk to people who don't agree with us. There's no other way. And don't take the social media trap. Posting stuff, it's gonna bite you in the you-know-what along the way. Find common ground. And if you can't find the common ground, every so often in November, there's elections. So make a choice, make a decision. But there are a lot of folks who don't want to be helpful. Sometimes they have to be litigated into being helpful. And I don't spend a lot of time trying to win people's hearts and minds. There's not enough time. There's so much stuff we need to do. Get them there when you can force them legally because they have to do what you want them to do. They'll figure out, hey, they were right. What do you know, right? But so, and on the OTP side, we made a ton of progress. The methadone rules that came out in the last few years, it's like 30 years worth of upgrades. They were needed along the whole 30 years, but it took 30 years to get them there. But we did. It makes it significantly easier. Would MOTA be better? I don't know. Like we did the MAD Act, it didn't appreciably increase the number of folks writing scripts for buprenorphine. I think it's deeper than changing policy. We got to do a lot more work, And the doctor's presentation was great. ASAM needs to talk to the AMA and every other specialty who works with our folks. They treat all of our folks. They don't treat the addiction that our folks struggle with. So, and mobile methadone, I'll give you a quick story because I was a New York regulator. That's when DEA didn't return my phone calls or emails. There were 2 years where they did, and I enjoyed that tremendously. We're in New York. We want to do mobile methadone. We want to use SOR money, by the way, to buy vans to do mobile methadone. And we said, hey, right across the river in New Jersey, they're doing mobile methadone. So the response I got was, well, we don't like that they're doing it, so we're not going to let you do it. Well, when the right people get into office and into positions, suddenly mobile methadone becomes possible. And now states are trying to take advantage of that, right? And we all know treatment programs can't build a place everywhere one person or two people need treatment. It doesn't work economically. This government doesn't fund that kind of work. So if they can, and they can't get to you because they might live in remote places, so go to them and then have it in a van and return. So laws and regulations, the federal government does play a role, a particular role with relation to opioid use disorder. The other thing I would say with funding and the law, right? And we all know, because I had clients a couple weeks ago call me, I just got notice at midnight, my contract was terminated. And so what did I tell them to do? I didn't tell them to go post on social media. I also told them to be calm when they walk through the front door of their treatment facility and even scare the hell out of their staff. It's already hard enough to find staff willing to do this work. But what happened? Told them. So this one particular client had a small contract. It housed 4 men and found them jobs and kept them from using substances because they were housed and employed. They were going to lose that money. The rent was due in February, right? So they and thousands of other people across this country, what did they do? I said, call your congresspeople, which you ought to know them anyways, by the way, and tell them what the impact is. Don't tell them how terrible this is. We all know that, right? So explain to them the impact on your program. And the beauty of it is people did that all over the country. Within hours, there were hundreds of members on a sign-on letter. And by the way, without getting too specific, that didn't come from SAMHSA, it didn't come from HHS, it came from a different 3-letter word. And so, and it's not gonna, I would love to tell you it's the end, it's not. But what that showed is when people do what we ask them to do, what we suggest they do, talk to your members of Congress. Because one thing we know after the opioid epidemic, whether people like our stuff or not, can't wrap up. Okay, so very quickly, let people know the impact of these things. We sent a message, right? Now the world's taking credit for it, whatever, I don't care. We all know what we did, but it's important that we use the law, use advocacy, and talk to people we don't necessarily agree with, because we have no choice. We've made progress, way more stuff to do. And what I would strongly encourage everybody, as much as you learn in these places and go to other conferences where we're all together and we all agree, you got to go other places where people don't agree. And we got to try to convince them, whether it's using the law, whatever it might be, using advocacy. So Regina cut me off. She used to do that a lot when we were together.
Regina, I'd like to yield 2 minutes of my session so that Rob can say something about the Witt case.
Yes. So I mentioned litigation. So in New York State, we changed all the rules. We eliminated prior authorization. We eliminated concurrent stay reviews. We mandated access to all the meds. Feeling great, proud, and I realized 51% of the insurance policies in our state weren't impacted by this. They were protected by ERISA, self-funded. So whip-de-doo, what do we do, right? There's a case in California, Witt versus, surprise, surprise, United Behavioral, right? Can you believe it? And if someone's in the room from there, I mean what I just said. So, read the case, go back and read some of the materials. And I know Marvin's group has been involved in the litigation. It's egregious. I mean, it was totally, absolutely financial decisions drove policy clinical judgment. No doubt about it. Their own doctors said that under oath. That case is still out there. Why it matters is because up to now, there's been no pathway under the federal ERISA law to say enough is enough. If you go here, you're breaking that law. And so think about what I just said. 51% of the policies in New York weren't protected by New York law. They would be protected by this. So I think it's critical. Pay attention to that case, because if you do work in this space or you work with the providers who say haven't been paid proper rates for 5 years, not that I represent anybody in that case, but it matters. So like I said, Sometimes litigation matter. That's a really important case. And so stay tuned on that one and stay involved. So thank you.
Question from the audience.
Yeah.
When X waiver was eliminated, buprenorphine prescribing did not go up despite the insistence that ASAM that it would, and NIDA's vocal was furious and had no answer. Do you know why it didn't go up?
Yeah, and we didn't get resources to go educate prescribers, and we didn't go talk to the prescribers who don't do this work. So, and that's why I say we got to talk to folks who don't believe in what we do, don't understand what we do, don't understand what our clients do. So spending time trying to educate, because as I said, it's the truth. I've talked to many doctors. I don't want to prescribe those medications. So I usually say, well, what's the last 10 meds you prescribed to patients? They're usually way more dangerous than the ones I'm talking about. And they acknowledge that, but it's going to the local county medical society meetings. It's going everywhere and explaining to them how helpful this is. I'll give you a quick story. I'm sorry. I'm a lawyer, right?
I shouldn't have yielded to
Your mistake. No, but so I met with a bunch of ER docs. We were really pushing bupe initiation and EDs in New York. And we were meeting with them. They ran treatment programs. The bottom line is they all didn't talk to each other because why does medicine talk to each other, right? So the ED docs were already doing bupe initiation. And so we're in a meeting and the OASIS treatment providers in the same room. And the ED doc said, I'm doing it. It helps. It calms them down. We can figure out what to do. But they said, we don't know what happens to these folks. It'd be nice to know what happens to these folks. So that understand that, right? People want to know what they do matters, that there's value in it, especially docs, right? So and medical professionals, just like everyone else. So we got them to talk to each other. They broke the barrier between the basement and the 5th floor of the building. And it mattered because they were doing it, but they didn't. Do people get better? Do they find recovery, right? Do they go do the amazing things we know they're capable of doing? The answer was yes. So now they talk to each other, but understand, right? It's all human. We're all human. And we didn't do that stuff. We haven't done enough of it. That's what I'm saying with the MOTA. If we don't do that stuff, that's not going to have any impact, any significant change either.
All right, nicely done.
Sir.
Can we get my slides up there? I do better when I stand up. So the current administration is going to save us. Yeah, I'm a smart ass. So you saw the recent executive order that came, the Great American Recovery Act. The executive order doesn't say too much. It says things that we already know that are actually the purview of OMDCP anyway. But I talked to Robert this morning and he talked me out of being so cynical. He tried to talk me out of being so cynical. And then following that, the secretary announced that there will be $100 million for the Street Act. So what's going to happen with all that? I don't know. Nobody knows. Actually, nobody knows. This is very undefined stuff, but I don't ideologically fit within all of the things that are happening there, but I'm going to work really hard to try to get on that commission and influence them. And that's what we have to do. So I just wanted to applaud you for talking about trying to get out of our tribalism to some extent. Okay, if I had to only say one thing and then sit down, it would be this. Addiction is an economic proposition. Right. It's about the money, stupid. I'm not calling you stupid, but it's an economic proposition, and that's where everything starts and ends. With that, I'm going to talk about what the treatment landscape looks like. Regina, I'm the CEO of the National Treatment Association. We're the National Professional Membership Association of Treaters and Treatment Providers, Professional Society, a trade association. It's difficult to tell you what the landscape of addiction treatment in America is because it's so vast and it's so varied and it's so evolving. But there are some strong commonalities. We know what good treatment looks like. We know what good treatment still needs to look like more. And I'm going to try to present some of that information. So I was once mentored by a famous psychiatrist And he said, Marvin, where you stand depends on where you sit. I've always liked that. It brings me home. People are ideological. We are ideological. It's okay to be ideological. It only becomes a problem when it interrupts our reception of the facts, right? So with all of this stuff, there is a North Star, and that is, what's the evidence? Follow the science. What's the evidence? We can produce evidence that 12-step methodology, 12-step facilitation is effective. Right? It's not the only effective thing. It's not for everybody. It's not the go-to, but Dr. Kelly from Harvard's research on 12-step facilitation, it's a Cochrane study, is phenomenal. And it indicates that among the many pathways which we have to embrace, there is even evidence within a very old system, the 12-step program, that it works, where it works and for whom it works. This field is particularly ideologically based, more so than any field I've ever worked in, and I've worked in a few. And it's a problem, right? I mentioned it in question to Dr. Einstein, is like, how do we bridge this gap between this rigid abstinence-based only, or this rigid, you guys are some kind of God weirdos and it's all about the science. Neither of those things is accurate. There's this really important place in the middle. So please understand that that's if you work in this area, it's gonna hit you in the face everywhere you go, right? And you have to be prepared to take a deep breath and follow the North Star. What works? What's the evidence? So NATAP is the National Membership Society for Treatment Providers. So it is the institution, a Hazelden and Betty Ford Foundation, for example. That's our member. We have about 1,000 treatment locations around the country, and they are dedicated to providing addiction treatment. Once upon a time, that really looked like one thing, right? It's the 28-day Minnesota model, right? What people think of as rehab, whatever that means, but that's not what treatment looks like anymore. It's much more vast. It's much more effective than that. So I'm going to talk about that. But when we think about NATAP, I want you to know where I sit, right? So I represent the the treatment field. I'm going to come from it from that perspective. Treatment works. We save thousands and thousands of lives every day. And so we have to stay focused on creating treatment that works and again, not becoming polarized. So ASAM, the American Society of Addiction Medicine, Dr. Einstein's organization, super important. Those are the docs. They created board certification. A doc can be board certified in addiction medicine. The Bible for placement of a patient in addiction treatment is the ASAM criteria. We wrote the ASAM, and NATAP initially wrote the ASAM criteria in the 1970s and 80s, realized it would be best suited in the hands of the scientists, the physicians, and we delivered it to ASAM. And so we continue to work together and influence those guidelines. That's an example of science and the treatment community really working close together. So that's NATAP. We're the treatment providers. FORCE is our Foundation for Recovery Science and Education, right? Follow the science, follow the evidence. This is our outcomes research program. All of this is available, by the way, at our NATAP site. There's lots of information there. The AID is the Addiction Industry Directory. That's our Addiction Industry Directory. It is essentially a listing of our members. And I'm going to talk about directories and what became a national directory crisis at some point that I had to testify in Congress about. And then we have the only PAC in Washington that is dedicated specifically to substance use disorder, the NATAP PAC, Political Action Committee. So those are the pieces of our puzzle. The thing about addiction, I don't know how to read this, is that it's medicine that didn't start in medicine. Unlike traditional medical disciplines, treatment arises out of a social criminal model of care. So medicine starts in medicine. Diabetes is a medical disorder. It develops, it grows, and it improves. That's not where addiction medicine comes from. Addiction medicine comes from a social criminal model. In the 19th century, pretty much jails and sanitariums. That's treatment. But a major development happens in 1939 with the founding of Alcoholics Anonymous. Alcoholics Anonymous is not treatment. It's a social program, but it's a good social program. And it is probably the genesis of creating what will become a medical model of treatment. That changes. In the 1950s, Alcoholics Anonymous kind of moves indoors, right? It moves out of the church basement and into private institutional settings. It's not called Alcoholics Anonymous, but essentially it is institutionalized 12-step work. Well, that's good. This is progress. Then finally, in the 1970s, we really see the professionalization of addiction treatment and what becomes the Minnesota model. So we bring people into a residential setting. It was pretty much a 28-day model. Do you know how the 28-day model came about? The founders at Hazleton got a couple of insurance executives to say 28 days is okay. We'll pay for 28 days, right? Well, all right. Well, but there's value in it. 4 weeks of treatment is really good. It's just one thing, but it's really good. So then we bring in psychology, psychiatry, and a degree of pharmacology and medical science. Until today, when we are moved, I say we exist now in the 2000s as a medical model. We're becoming a medical model. There's a great, it is a scientific medical proposition. We deal with the disease, but to say that we are settled well within the healthcare universe as one of the modalities of healthcare is not accurate. We're still stuck out here and trying to work our way in, but we're getting closer and closer and closer. Just an example. I always like to put this slide up. So I talked about a period of time when sanitariums and criminal activity. This is in Minnesota, one of the first treatment programs, if you will, and it was the Wilmer Inebriate Farm. Where'd you go to treatment? The Wilmer Inebriate Farm, right? But it progressed to the Wilmer State Hospital for Inebriates. See, we're getting better with language all the time. All right. So Emily went over this beautifully, but I want to make sure that we're settled on this. We have to be able to define what this condition is, and this is settled. Right? There's no argument about this. There shouldn't be an argument about this. Addiction is a chronic, treatable brain disease centered in the brain with physical, psychological, social, and spiritual manifestations. Everybody doesn't put in spiritual. I put in spiritual. That's a whole other session. Yeah, let's just leave it there right now. So in the business, we call it the biopsychosocial model, right? So any response to the disease has to address biopsychosocial spiritual components. The crisis has been around for a long time. It's unabated. There's progress in terms of the illness existing, right? We have seen a little bit of progress in terms of opioid overdose deaths. And that's due to harm reduction. There's no question about that. But this is big. 50 million people in this country age 12 or over meet the criteria for a substance use disorder, right? 30 million people have diabetes. A lot of people have diabetes, right? We're pretty focused on that. GLP-1s were created for that. So this is a healthcare emergency. It's as big as anything we've got, bigger than all the cancers, all the people living with cancer. All right, so this is a major, if not the major, American healthcare disorder. So in order to fit within healthcare, it needs to have a disease classification. It does. It's brain science. And it needs to have a payment source, right? And it does. It's called managed care. We kind of skip over the fact, we just sort of accept it now that our healthcare system is a managed care system. So what now? I don't know what that was. Okay. So in terms of moving our way into healthcare, there are two critical pieces of legislation that came into effect that does do this. The first is the Affordable Care Act, right? And it lists mental health and substance use disorder as components of the 10 essential healthcare benefits. In order for us to move this thing forward, we have to continue to keep SUD as one of the 10 essential healthcare benefits. And then we have this other thing, signed into law by President George W. Bush, called the Mental Health Parity and Addiction Equity Act, which we refer to as parity. It is the law of the land. It says that if you cover a substance use disorder treatment as an insurer, you must process it, cover it under the same set of principles, claims principles as you do for any other disorder. It's totally unenforced. Congress won't enforce it. The Biden administration issued a final rule toward the end of that administration, and it was working its way toward the possibility of actually creating enforcement mechanisms. But the insurance lobby is a little bit more powerful than the addiction lobby. So it sits there unenforced. The Witt case is about that. I can tell you, talking to our treatment providers, that parity is violated every day. Our approach to this from the Treatment Provider Association is we have to have good relationships with the payers, right? We work with all the payers. We have to have working relationships. We want to come together to promote coverage, but at the same time, we have to hold their feet to the fire, and sometimes you have to sue people. And so, you know, I have a precarious relationship with the treatment executives, but some of them are fabulous. The problem with the healthcare reimbursement model is it's all based on claims data, right? Claims data is important. It shows whether you went back to the hospital, right? But they're not wellness measures, right? What we really need to base coverage on is what produces wellness. We talk about measurement-based care. That's the sort of thing that we need to be talking about in terms of successful treatment. But unless addiction is an economic proposition. So we're working with the payers to get them to the place where they will look at wellness measures. And that's why we have the Foundation for Recovery Science and Education. And we're beginning to produce those wellness measures. It's really hard to study outcomes. And that's why it's taken us and the field so long to do it. Anyway, those two pieces of legislation give us theoretically what we need to be well suited within addiction, within healthcare. But as I say, they are threatened or not enforced. I was doing so good with the clicker. All right, I need your advancement. Oh, there it is. Okay, the treatment landscape. Once upon a time, NATAP was founded in 1978. This is an illustration. This is a demonstrative exhibit, Your Honor. It's not actually entirely accurate, but this is what treatment looked like, right? Every one of these little dots is a treatment provider. All over the country, you had these little Minnesota model, usually 501c3 not-for-profits, providing treatment based on a 12-step structure, but beyond that. And that existed up well into the 80s. Managed care happens in the 80s, and everything changes with managed care. So managed care was created, by the way, in case people have forgotten, by the Nixon administration in response to Ted Kennedy's approach to nationalized health care. You know, the country went crazy with the leftists trying to do this, and so managed care came in to save dollars and produce a more effective system. It does save dollars. It did save dollars. But I, together with my doctor, don't decide what care I get. I, together with my physician, ask the people at United whether they will please pay for my treatment.
Yeah.
And sometimes they do, and sometimes they don't, and sometimes they pay for part of it. That's how healthcare works. I mean, it's real duh, but we don't think about it enough. One of my predecessors at NATAP many years ago suggested in a public setting that we should consider promoting a one-payer nationalized system, and he barely got out of the room alive, right? So that's not happening. But what we need to do is continue to get managed care to do what it's intended to do. Okay, so the treatment world gets flipped on its head and grows into what you see now. This is an actual illustration of NATAP's membership. These are these guys, right? And these circles represent the size of the organizations that have come into play. This is actually, this entity has very different operational systems and interests than this. We still represent this whole piece, and we're doing the best we can to keep the field together, but it continues to consolidate. This is what happens in an economy like this. And we even have sessions in our conference now on mergers and acquisitions. So once upon a time, it looked like that. Now it looks like this. And as I like to say to our members, the bubbles are getting bigger, folks. The bubbles are getting bigger. They're going to continue to get bigger. And yes, one day we're going to have about 5 of these. Trying to stall it as long as we can. All right. Taming the Wild West. This is, Regina, what do I got? Like 5 minutes. I only have 25 minutes of material. No, it's good. Does that include the time I gave up? All right. Let's say early 2010s to 2015, something peculiar begins to happen in our field because it appears you can make money in it now. Historically, profit margins in addiction treatment programs are very small. Like 4% is a huge goal for an addiction treatment program. That's not how most of American business would see that. But now we've got a payment source, we've got parity, we've got greater awareness. Stigma is still horrible, but less so. People, movie stars are talking about it at least. So what happens is, and then the opioid epidemic hits and brings in a lot of aggressive entrepreneurs and what we came to call bad actors, right? And we have a field that is very vulnerable. It lacks regulation compared to most industry, and it also isn't clear what best practices should look like. So think about this. I testified in Congress about this ethics crisis as it came to be known, and asked Congress to institute more regulation on our field. No trade association executive has ever said to Congress, could you regulate us a little bit more, please? But it's the only way to save the good guys, right? We have to take all these measures to combat these bad actors that come into play. So what emerges out of this is just horrible. I mean, it's just horrible. By 2015, right, that caused us to write our ethics code, we were seeing body brokering across the nation. Body brokering means a treatment program, an unethical, horrible, bad treatment program is paying somebody to bring them bodies. So there's a whole lot wrong with that. First of all, it's illegal. But the other piece is, if you're going to treat a disease, the first thing you need to do is diagnose and assess the disease. How do we provide good treatment? We go to the ASAM criteria and other medical tools and assess the patient for what they need. Addiction exists on this massive continuum. On one end is a brain disease where the person's probably going to just die tomorrow. On the other end is a substance use disorder where drinking a little too much is causing you a problem in your life. And you should probably quit drinking or moderate your drinking, right? That's a disorder, and it's all throughout here. So people in these situations are not being assessed at all. They're being kidnapped essentially. I mean, I don't know if you've read the horror stories, but I was involved in a case where 2 body brokers took 2 women from the Midwest to Florida, got them further addicted to opioids and prostituted them. That was happening. So there's a horrible thing happening. And then the other piece of this is treatment sucks. Treatment providers are unethical. There's a huge problem with treatment. Well, most providers don't do that. It was a minority of providers, but it was horrible stuff. Where it mostly occurred, though, was simply internet deception, right? So these are my old slides. Didn't get my new slides in here, but that's okay. So trying to think about how to link this up. Basically, think about this. How do you find a pediatrician for your child? You talk to other doctors, you talk to your primary healthcare provider, maybe you talk to other people. How do you find addiction treatment? Google, right? You Google rehab, which doesn't mean anything. right? We have good treatment programs out there that use the term rehab, so I'm not, I prefer that they didn't, but you search for rehab and you will get beautiful beaches, pool. You can keep your cell phone, and even this one, if you believe it, sheet thread count, high 3. You know, these are not medical interventions. These are not evidence-based practices, and this is what people are finding because they want to look for something called rehab. And so, what ultimately has to happen is we need a really aggressive response, and I'm proud to say that our organization led this. We, together with others, got Google to shut down AdWords. Right? They've never done this in the history of Google. It was AdWords for addiction treatment were the most expensive AdWords on the market. They gave up billions of dollars. And here's how they did it. We went to Google and said, look what's happening. This is horrible. People are dying because they don't know how to look for treatment and there's deception online. You need to do something about this. And they said, sorry, we built a playground and you guys don't play on it ethically, so that's not our problem. So we went to the New York Times, and the Times of London, and together with a lot of others, it was a beautiful expose on the harm being caused by internet deception by these bad actors. And Google called and asked us if we would come together with others to the campus and come up with a plan. And we said, we'll do that as soon as you stop selling AdWords. You got to cut it off. I was going to go anyway, but they cut it off. Now I knew they were going to reinstitute it. So we and others went to Google. We wrote a code of ethics. It has a section on treatment, management, diversity, less popular these days, but we're sticking with it. Facilities and marketing. And the marketing piece is where we find most of it. In order to be a NATAP member, which is a voluntary association, you have to follow this code. You have to agree to be removed if you don't follow this code. And we have an enforcement process whereby anybody can complain, file a formal complaint. We have a whole due process system in place to look at centers. And we threw out, so the first thing we decided to do is we have to get smaller to get better. In order to have a strong moral position, we need to do the right thing. And we threw out 100 members and $100,000 in dues. A couple of them have come back, having now instituted these plans. But if you don't belong to NATAP, we only have jurisdiction, as it were, over our members, right? We find it, if we find a member is non-compliant, we try to get them to become compliant or remove them. But the rest of the field is not bound by them. I would encourage, but many programs say they follow the NATAP Code of Ethics. And the implementation mechanisms that were built by Google and the federal government follow our code pretty strictly. Recovery.com, who's in the room, is following it. There's a whole thing about directories, which I'd like to talk to you about at some point. We had a real problem with directories, but they were fraudulent directories. That's not true across the board at all anymore. So we'd love to see this promulgated in all treatment programs. 1,000 treatment facilities, NATAP has about 1,000 treatment facilities around the country. If you do a SAMHSA directory, a SAMHSA locator search for addiction treatment, so we're 1,000, right? How many treatment programs do you suppose exist in some way? If listed as an entity that provides some form of addiction treatment. 30,000.
Wow.
Good job, Nikki. 30,000. What are they? Some of them aren't licensed. Most of them are not accredited. Right? You don't go to a hospital that's not accredited. So NATAP members must follow this code. They must be licensed for all services in all locations, and they must be accredited for all services in all locations. And so should any treatment provider. But the public doesn't know that because they're not searching for healthcare. They're searching for rehab. The last thing, and then I'll quit, is there was an image on here. It's pretty. It's the cover of the book. So this was sort of shocking. I said to our board, I don't think anybody has ever written down what the core competencies of operating an addiction treatment program are. So if you were to say, what do you have to do in an addiction treatment program? No one had articulated it. So we wrote the quality assurance guidebook. Our members are also bound by it. And it lists the 12. We didn't try to mimic the 12 steps. It just happened to be 12. And we drafted the 12 core competencies of addiction treatment and 56 guidelines within that. So we have attempted to place upon the field or promulgate within the field an ethics code and operational best practices. They apply to no one technically other than our members. The movement to create, I want our organization to grow. A member of Congress asked me in the hearing in which I testified, couldn't we just have everybody be a NATAP member? I was like, God, my salary would go up, everything. No, I mean, that's not legislation that you can have. I'd love that to happen, but what I'd love more is just for the general population of treatment providers to adopt these kinds of principles. And thank you.
One question from the audience. How can NATAP argue for stronger confidentiality for patients so they don't have to be afraid of seeking treatment?
Well, there's I got an hour. Patient confidentiality within treatment is the law. So I'm not sure what the questioner wants to know exactly. 42 CFR and HIPAA control those two control confidentiality within addiction treatment programs, but your identity within addiction treatment programs is entirely confidential. So I got to say this. Here's the other, and that's good, and we got to have that. We want people to feel free to go to treatment. But if it wasn't so stigmatized, you wouldn't have to say that. You would say, I have a sickness, I have a substance use disorder, I have a disease, I need to go take care of it. I have diabetes, I need to go take care of it. But it's not how it works. So we have these confidentiality laws, and they were there for a very good reason. But if you have diabetes and you move across the country, or you go to your cancer doctor, or you go to your, orthopedist, all he has to do or she has to do is pick up the phone and all your records are there because all the systems talk to each other. All the systems talk to each other. And in that way, we can have continuity of care. You know, Kennedy was talking about continuity of care. Well, it's true. I mean, we do need to have that. So right now, electronic medical records do not connect substance use disorder with any other part of healthcare. And there's a real debate about what that should look like. The field is divided between confidentiality and this type of integration. So that's the best answer I've got.
I don't think the clicker is working unless you need to set it up for me.
Yeah.
Oh, here we go. Thank you. You're all lucky. I'm a middle child of 6 and I talk really fast. Otherwise, I wasn't going to get any food. So I'm going to try and distill everything that you guys just heard into how is this all working within a state. So good morning. I'm Deirdre Calvert. I do go by Dee, and I am the director of the Department of Public Health's Bureau of Substance Addiction Services in Massachusetts. I worked in the field before I came to state 7 years ago, running these programs. So have a real understanding of what we're talking about. I'm also a person in long-term recovery, and I just want to make sure that that's out there. And I'm really grateful for Regina asking me to come here. So next slide. So at BSAS, we're guided by, and I have notes, sorry, I have too much to say and I'll forget it. At BSAS, we are guided by our mission to support accessible, effective, and culturally responsive prevention, intervention, treatment, harm reduction, and recovery support systems, programs, and practices. And last year, that brought us some heartening news. Both the CDC and state data showed that in 2024, opioid-related overdose deaths in Massachusetts fell to its lowest level since 2013. That was 36.3% decrease in Massachusetts. Yes, this was one of the highest in the country. This decrease was seen across all races and ethnicities. This is a testament to those who continue to work tirelessly across our Commonwealth and to address the crisis, including our substance use providers. And while this news is encouraging, we know that inequities in both opioid-related deaths and those in treatment access rates still exist. disproportionately affecting BIPOC individuals and those from historically marginalized communities. And today we're going to spend some time reviewing Massachusetts' approach to regulating substance use disorder treatment. And it's critical that we begin by acknowledging these disparities and that we will remain committed to addressing them. I invite all of you to keep these considerations in mind as I discuss BSAS's role in regulating the treatment system in Massachusetts, as well as some of the adaptations we have made and the challenges that remain amid an ever-evolving and local national landscape. Next slide, please. So who are we? Let's do the basics. As the federally designated single state authority for substance use, BSAS develops, implements, and oversees prevention, treatment, harm reduction, and recovery support services throughout the Commonwealth. We provide training and technical assistance to the workforce and promote non-punitive approaches to substance use. And in doing this, we strive for a robust system of voluntary care and healing, centered engagement, and work to dismantle harmful legacies of criminalization of substance use. Next slide. BSAS does not provide any direct substance use treatment services. Rather, it licenses the treatment programs and contracts with agencies and vendors to deliver those services. Currently, BSAS licenses and regulates over 500 programs across the Commonwealth, which together serve youth, young adults, and pregnant people, adults, and families. We also license about 1,700 alcohol and drug counselors. And outside of licensed treatment programs, we fund harm reduction, low threshold housing, and peer recovery support centers. Next slide. Thanks. So we follow the ASAM level of care. The Massachusetts continuum aligns with the ASAM level of care, ranging from outpatient and office-based treatment to hospital level acute, our level 4.0. Massachusetts does support a no wrong door approach to treatment, which allows an individual to access treatment at any point on the continuum if it's deemed clinically appropriate. We also contract with providers as the payer of last resort, which means we pay for the tab for all SUD services for those individuals who are uninsured or underinsured pursuant to our state regulations, our state statute. We will talk a little bit more about how that's going to be impacted under the big crappy bill that was just passed. I can't call it what it is. I'm sorry.
Do any other states do what you do?
Not as well, no.
No, but I mean, in terms
That's
of
why I'm
funding.
here. In terms of funding?
Yeah,
Yeah.
the statement you just made about you're covering all those costs. I'm not
There
aware.
are some states that absolutely do payer of last resort. Our payer of last resort, though, is also, if you look at our civil commitments, right? So if we have somebody who is unfortunately civilly committed in Massachusetts for up to 90 days, and there's a big problem with that, which I will talk about, they may be covered by their insurance for 2 weeks. But for that delta of days between 2 weeks and day 60, BSAS picks that up even though they have insurance, and it's a higher rate of reimbursement. Yeah, so a lot of these programs want to do this and hold people for longer. We, unfortunately, I want to talk about all the wonderful things that Massachusetts does and all of the amazing ways that we've able to kind of worked around systems. One of the things that we are still struggling with, because it's not our statute, it's DMH's statute. I work for DPH, is the civil commitment. So we have very few levers to change that, and we are only second to Florida in terms of commitments, and we're the only state that actually commits people to carceral settings. So we'll just put those bad things over here, and we'll talk about that in a second. Let's talk about the good stuff. All right. Did I already have you change it to slide 6? No, yeah, next slide, please. All right. So BSAS's oversight and regulatory authority is established throughout Massachusetts general law. BSAS regulations outline standards for SUD treatment, including minimum staffing levels, requirements around individualized treatment, access to medication, patient rights, and discharge planning and aftercare support. To ensure compliance with these relevant laws and regulations, we conduct on-site investigations, compliance investigations of all of our treatment systems. This process involves reviewing program policies, documentation of patient care, and evaluation of the program's physical environment. They also must have clear internal policies for receiving and addressing the grievances that actually have been talked about today, and inform patients of their right to contact BSAS with any complaints. And our complaint line also supports immediate access to translation services. Complaints may be filed by patients, residents, programs, other staff, case managers, family members, friends, or any member of the public via dedicated confidential phone and fax line. We investigate all complaints and follow up with the programs as needed. If the investigation identifies regulatory violations, we write deficiency correction orders, which is called a DCO. And we also, within our regulations, have the power to fine these programs if they do not adhere to the DCO. So we can fine them up to $1,000 a day for each day they're out of compliance. So if they don't like what we're saying, we will fine them. That's been the most effective. Because getting people to change. Yeah.
It's the opposite of contingency management.
We try.
Imagine contingency.
Well, you know what? It's interesting. It's interesting how that changed when we changed that in there, that we could actually find agencies, you know, and, you know, for agencies who said, oh, we accept Mass Health is our Medicaid, Mass Health patients, but what they don't do, they tell them to call back at 3, or they put them on a waiting list and stuff like that. We find out that happens. Guess what? You're going to get fined $1,000 a day until that happens. Yeah. We're not nice. Yeah, programs must respond with a plan of correction as well as evidence that the violation has been corrected. That said, not all complaints meet the BSAS criteria for follow-up, and they may fall out of our scope or lack patient consent for us to follow up. We regulate our authority over the licensed alcohol and drug counselors, which includes 3 levels of licensure. So we automatically do that. We also are in charge of our CORI second level review, and those are for individuals who have been in carceral settings with a felony Table A conviction, which could include murder or armed robbery. And there's some criteria that they have to meet, but we have a criteria that's set in Massachusetts statute that we absolutely follow, and we have placed over 60 people per year apply for this regulatory waiver, and then can be placed in our programs, which is phenomenal. And I'm happy to talk about that. So next slide. So the changing drug supply, which we've talked a lot about earlier today, BSAS's efforts to regulate and ensure quality of care also requires taking into account how the needs of people who use drugs and people with substance use disorder change over time. Most recently, this has included attention to changes in the unregulated drug supply. In Massachusetts, fentanyl continues to drive our opioid overdose deaths, with fentanyl present in 89% of overdose deaths in 2024. We're also seeing that increase in prevalence of xylazine, medetomidine, and BTMPS in our drug supply. In addition, stimulant-related overdose deaths have increased dramatically since 2013, with stimulants present in over 60% of our overdose deaths. BSAS also monitors trends in patient enrollment. And from 2011 to 2025, enrollments with alcohol as the primary substance have remained relatively stable, but represent an increasing proportion of all enrollments to our withdrawal management system, which is what we used to call detox. Broadly, BSAS is hearing from providers that many people seeking treatment for a range of co-occurring medical and mental health needs, including the complex and chronic medical care and severe wounds, which we are not able to care for under the rate of reimbursement as it is. Taken together, these trends underscore the need for regulatory and programmatic flexibility to meet these evolving needs of people who use drugs. Next slide, please. With attention to these trends, BSAS has made stride in regulatory and other realms to ensure Massachusetts SUD treatment systems is adapting appropriately. So 2022, that's when we added that category for fining, but we did a whole modernization of regulatory language. We required access to MOUD in all settings, better defining the scope of servicing and creating flexibility in service model deliveries to support meeting patient needs, including a provision for special project licenses, which allows innovative approaches to treatment. These revisions also included requirement for direct referral, coordination of care of patients, and other service settings. We are also drafting regulation to create a licensure pathway for recovery coaches, including consistent set of eligibility requirements for the license and consistent practice expectations for coaches. In addition, these regulations governing alcohol and drug counselors is also being reviewed. And we have also modernized that language and clarifying on the educational requirements. In recent years, Massachusetts has made progress in expanding methadone access across the state, which has included an updated regulatory guidance. I am a former methadone a program director from many, many years ago in the 90s. And I used to say up until 2024, you could blindfold me and drop me back in that clinic and it would be exactly the same. Nothing had changed, nothing. Things have changed. So since 2019, OTPs in Massachusetts have grown from 44 to 55 community-based OTPs, 5 mobile OTPs across the state. In alignment with the recent 24 and 25 federal updates, we have issued guidance to provide support for more flexibility in methadone delivery, specifically around screenings, telehealth exam, and take-homes. A moment on take-homes. Before, in 2020, before COVID, we have 25,000-ish patients in methadone treatment. Less than 6% were getting some sort of take-home up to one day. That was pretty typical. We now have over 85% of all methadone patients are getting some form of take-home from 1 day to 28 days because of the changes that we were allowed to do. That is phenomenal. There is not one patient that I've ever had that says, God, I really hope I can go on Christmas Day and pick up my dose. I really hope that July 4th, there's a really long line sitting outside and getting hot so I can pick up my dose. Nobody's saying that. So this is absolutely phenomenal. We also approve MOUD in programs in prisons and jails pursuant to our regulatory authority and with 25 penal facilities representing the vast majority of penal facilities in the state are now offering MOUD. The two that aren't are Martha's Vineyard and the Nantucket because the numbers are too small. So we're trying to figure out how to get those are called Dukes County, how to get methadone and methadone access where people don't have to get on a ferry and get over to like Woods Hole. Supporting flexible models of care, BSAS also promotes and funds flexible models to support outpatient care in response to trends in substance use. Recognizing that inpatient treatment might not be a good fit for all, BSAS is providing funding enhancements for MOUD to support outpatient care, including the mobile vans, medication units, the kiosks, the reuse of recovery coaches, outreach workers. And this aligns with the pattern we're seeing in enrollments. BSAS enrollments in WMS, our withdrawal management system or detox, indicates that opioids as the primary substance has decreased from 71% in 2024 to 37% in 2024, while admission to outpatient medication programs has increased since 2019. Our EMS data in 2024 shows that 85 out of the ambulance drop-offs, 85,000 unique individuals were taken to the hospital because of alcohol-related issues. Same year, 10,000 people were taken because of opiate-related, and we're not spending nearly enough time around alcohol-related and alcohol-related deaths, we had 1,303 overdose deaths in Massachusetts in 2024, which was down from like 2,600 the year before. Like I said, we had the 36% decrease. We had just 1,600 alcohol-related deaths. Those were just the acute deaths. That's not even the chronic deaths that we're not talking about.
Yeah.
So we just don't talk about that enough. So we also want to talk about a little bit about stimulants. We have a phenomenal stimulant use disorder program. We've started working with Boston Medical Program to start. START is the Stimulant Treatment and Recovery Team, which is an outpatient treatment program centered around stimulant use. We have now 5 programs in Massachusetts, which engages a team of multidisciplinary providers in the contingency management program. And to address all the social determinants of health that can contribute to negative health outcomes, BSAS began funding low threshold housing first. I like to say that word because people have said it's now a dirty word. Housing first that does not require abstinence to access since 2021. Since then, we have placed permanently over 650 people in housing that does not have abstinence requirements. Through BSAS's new Office of Community Health and Community Health and Equity, BSAS launched the Redefining Community Wellness Grants to center BIPOC voices in grant making, so to enable programs to build or expand substance use services, address the social determinants of health, and build their capacity. Grant funding and capacity builders were provided to 25 organizations through the span of 2025. We've also supported positive change through legislation, including removing the requirement for automatic reporting of infants with prenatal substance exposure. While there was a critical need to screen for substance use during pregnancy, Massachusetts legal requirements long required providers to universally report parenting individuals who using substance or taking medications for addiction treatment to child welfare and neglect. 95% of those were sustained, and the child was minimally removed for 3 days. So we now have a dual reporting system, and alongside numerous partners and including our child welfare agencies, the reporting laws have been updated, allowing mandated reporters to use their clinical judgment regarding the presence of true safety concerns. Next slide. I'm almost done. Told you I talk fast. All right. Keeping in mind what our Bureau has seen as the current needs of persons with SUD, BSAS faces a number of challenges in trying to regulate and ensure quality of care. So there's inequity in treatment delivery and access, which we've heard a little bit about today. Despite investments in our continuum of care, we know gaps in services still exist that make it difficult for some people to access care. SUD treatment services are not staffed or reimbursed to meet all of the needs in the complex wound and medical and mental health care, making it difficult for individuals to receive comprehensive low barrier care in one setting. In addition to an SUD shortage workforce of mass, DPH has found that the workforce does not reflect BIPOC communities racially, culturally, or linguistically, which further compounds the histories of mistrust in the health systems and reduces access to treatment and stigma against those who use substances. Additional challenges, insurance-based systems that reward denied care and undervalues prevention. We have out-of-state programs that skirt regulations. We have venture capitalists that do a little bit of that body brokering that was talked about. And then the proliferation of telehealth from out-of-state individuals. Sober homes also present a challenge for us. They are private residences, and due to federal and state anti-discrimination and fair housing laws, BSAS regulatory reach is limited. While sober homes can choose to become BSAS certified, those who don't aren't held to any substance use standards. There continues to also be punitive and discriminatory laws, policies, and practices that negatively affect those with individuals. As I said, our involuntary treatment for SUD laws practice enables high rate of commitments in Massachusetts. Just for another example, if you are civilly committed for mental health in Massachusetts, it's called a Section 12, you are taken to a hospital where you are, if you are found by an independent practitioner, so I'm a licensed social worker, I think Marv has some mental health issues, he goes in an ambulance, that's all true. I've only known him 20 minutes, but it's true. He goes in an ambulance and an independent doctor or practitioner will decide, and they decide, and he goes for 72 business hours. Robert,
On the other hand,
Robert's got some problems with addiction, right? I am a licensed social worker and addiction counselor. I can't do anything for him, but I call the police, and the police come and they get a warrant and they find Robert wherever he is, and they handcuff him and they shackle him and they put him in the back of a cop car, and then they take him to court, and he's sick. He hasn't drank these drugs now in several hours, and he's sitting there with somebody who makes an opinion on whether or not he needs to go to treatment. And then we've got programs that are public health run, or he could go if he has an open charge. Let's say didn't have his driver's license one day and he's got a $50 charge that he can't figure out. He now goes to one of the carceral settings, and he will be there for up to 60 days. Remember, 72 business hours, 60 days. Well, it's up to 90, but the average is about 60, 72 hours. Okay. So, and who pays for that? BSAS pays for it. Sorry. So that's just like, and you're shackled. Let's just remember, you are shackled, and then you're in the back of a cop car and you wait till the end of court, and then they'll take you. Oh, and that warrant's good for 5 days. So if they can't find Robert, it's supposed to be like, the crisis is now. That warrant's good for 5 days. I don't understand how, if it's a crisis now, we're waiting 5 days. All right. So, those are some punitive things. All right. So BSAS is also looking to identify and act at critical points of intersection between criminal and legal public health systems to support persons who use substances. We have a DIV care program, which supports collaboration between public health and public safety and criminal legal systems. And that's to build and strengthen local overdose response strategies and identify gaps across the criminal legal systems where they intercept and engage individuals. We're also working with the Mass Health, our Medicaid and trial courts to deliver a behavioral health system that is going to help people who are legally involved. And finally, the federal landscape. So I don't even know if there's another slide, but Oh, no, there, we'll just do the federal landscape. So finally, all of this work continues against an increasingly volatile federal landscape that has brought funding threats and promoted violence and dehumanizing rhetoric and policies. Federal methadone regulations continue to restrict methadone to opioid treatment programs, preventing the use of innovative approaches like methadone dispensing at pharmacies, hospitals, and other clinics. And recently, as many are here aware, concerning the chaotic and concerning 24 hours that ensued last month when SAMHSA abruptly terminated federal grants supporting substance use and mental health services, representing over $5 million in grants to Massachusetts, all to be reinstated within 24 hours. Funding is also threatened in other ways as well. As more people lose Medicaid coverage, BSAS's cost of payer of last resort are expected to increase, straining our ability to even fund our other crucial services. In 2025, a series of federal executive orders and communications related to SUD disavowed harm reduction policies. We have just been told to stop saying things like, don't use alone. Even though 80% of our overdose deaths are unattended, we are being told that that is something that encourages drug use. So we have a series of federal executive orders related to that disavow the harm reduction policies and practices. We began to see the impact of this in Massachusetts. Some municipalities have already shied away or stopped offering harm reduction services because they are within a HRSA funded building, or they have blended funding. And there has been increased calls for the use of forced treatment and criminalization against people who use substances and are homeless. But regardless of the federal rhetoric, BSAS and DPH will continue to support access to evidence-based treatment, which includes housing first, harm reduction, trauma-informed care, and policies that uphold human dignity. Thank you.
We have time for a few questions. Do you have any online?
Easy one. For the recovery residences, do you require that your licensed treatment providers only refer to the state certified providers? And what is do those include NAR certified in Oxford House and so forth?
Yeah, we don't have very many Oxford houses in Massachusetts, but we do. So we have our residentials, which are licensed by us, all of them. You have to be a license. But for sober homes, they're called Massachusetts Association of Sober Homes. So it's a contract through us. Mm-hmm. And anybody who's leaving one of our treatment programs, they're the only ones that they can be sent to. But there's hundreds of them that are not certified. And unfortunately, some of them too are had to leave MASH because we had a new law where all of these sober homes had to get sprinkler systems, which in Massachusetts, these houses are very, very old and some of them are historic and it costs a lot of money. And people are like, well, if that's going to become a requirement, I'm going to leave MASH because I can't actually afford a sprinkler system within my sober home.
Right.
Yeah.
And if it's considered a residence, which it isn't under other law, the sprinkler system isn't required.
Yeah, it's almost municipality, city by town, and it's actually dictated by the fire marshal about whether they're going to do it. And so then it gets to stigma. Does that fire marshal appreciate the people that are here or do they not?
I have a question. I don't know if you can hear me. I'm virtually attending.
Yes. Go ahead.
Oh, great. Thank you. You mentioned that for your mandated reporters, you changed the standard to reflect or to incorporate clinical judgment. Can you speak to that more? Is there a law on the books? How did you guys do that? Because that is really interesting. I'm from Maine, so I'm just interested in.
Yeah, this has been a long time coming. So we have data that shows that parenting people who get off their medication for opiate use disorder, who've been stable for years and years, when they got pregnant, because they knew when they delivered, there was going to be an automatic 51A, that's what it's called in Massachusetts, a filing for Child Protective Services. And what happened though is then we saw an increase in deaths and overdose deaths of those women who no longer had the prophylactic and the care from these medications, right? So it didn't matter. And some of the things that CPS was looking for in our state too is like, oh, Did you have children taken away? Well, some of them did 9, 10, 15 years ago, right? They're still counting that. Did they have a Corey? Were they in Child Protective Services themselves as a child? So in 2024, we had a big omnibus SUD bill that was passed, and part of it was that we had to create a dual reporting system where for CAPTA, we had to get the numbers, right? How many infants were born? That's one number that can go through one portal. And then there's the ones that maybe actually need some support, right? But before it was everybody. So that was a law. So we actually had to change CPS, our Department of Children's Services, had to change their actual policy where they had stated substance use was abuse, right? And substance use by a parent was abuse. So they've changed their language. That's being promulgated right now. And we have built up this dual reporting system, which will go through the Department of Public Health. And I'm happy to send that statute to whomever needs it.
All right. Well, thank you so much. This was great. So thanks for joining us this morning. We're going to continue, Shelley Weissman. We're going to continue this afternoon. I'm so pleased to have with us a representative of Major League Baseball, both because of the work that John does for anti-doping, but also in the prevention space. And as those who, have kids understand the importance of baseball, what a central life style piece it is for those of us who have spent many weekends taking our kids to travel baseball. That's a great legacy, but it's also can be part of a prevention effort. And also, I'm going to ask a trivia question before. What's the only Major League team not to win the World Series? Nobody? I know you know. It's the Mariners, the Seattle Mariners, but I know this is the year, right? As a Mariner fan, this is the year. So John is the Senior Vice President of Drug Health and Safety Programs at Major League Baseball. There he oversees drug prevention, treatment, and health initiatives. He facilitates mental health initiatives, anti-doping policy, and player safety, and is the MLB's liaison to domestic and international anti-doping organizations. So he's also an attorney. So with that, I will turn it over to John. Thank you.
Thank you, Regina, and appreciate the opportunity to be here today. I think this is probably the most attractive space I've ever spoken in. Nice brand new cafeteria, but hopefully we can just keep this casual. I know everyone's going to be enjoying their lunch, but please feel free to interrupt. Coming in today, just very honored to have the opportunity to speak to you all today. We have a lot to say. We're very active in this space, but just listening this morning from the first presentation all up to just a few minutes ago, one, I learned a lot, so thank you. But two, there was so much that was said that overlaps with my day-to-day and my job responsibilities at MLB. So hopefully, my unique experience, our industry's kind of involvement in the drug prevention and treatment space will just provide a unique perspective and will be hopefully beneficial for you all to hear. And maybe, my goal is that, something that could be taken away from today will be helpful to whether you're, working in the treatment space or working in your own unique industry, just because we have dedicated so much time, so many resources to this area over the last 20 years. So just a little bit about myself, as Regina mentioned, I am an attorney. I've been at Major League Baseball for almost 20 years. I'm in the Labor Relations Department, so my day-to-day responsibilities are to deal with the Major League Baseball Players Association. We actually have a number of drug programs at Major League Baseball, but today's talk will be focused solely on the most high-profile program, the program that applies to the 1,200 or so Major League Baseball players that are spread throughout our country, including the Seattle Mariners, as well as country in Canada. But outside of that, our influence is much more significant. I oversee a program that covers the 7,500 minor league players that are spread throughout North America and throughout Latin America. We have programs for our coaches. We have programs for our umpires. in essence, we take a very hands-on approach to drug prevention and treatment, which is all born out of the collective bargaining process. And for those law students in the room, it is one where we take the position, as well as our union takes the position, that everything related to the workplace, but specifically for purposes of today, anything related to drug testing or anything that falls under that policy is a mandatory subject of collective bargaining. So that essentially means that we can't unilaterally implement anything. Whether it's a change in the word of our policy or some major shift, we have the obligation to either propose that ourselves, receive that proposal from the other side of the bargaining table, and reach an agreement on that. And that's something that I feel very, very strongly about. I think the main theme of my talk here today will be that rather than just trying to force something or trying to model something after, actually working with the employees that we're looking to protect to try to come up with a program that makes the most sense for their lifestyle is our goal. For those of you that don't go to Major League Baseball games, I'd strongly recommend that you do. Now that the football season is over, I think it's great that I can say that spring training is the next major sporting event that's going to be taking place in a couple of weeks. But the employees that we oversee, the players themselves, are very highly compensated. They, a lot of coverage in the media about the minimum salaries and the contracts that some of our high-profile players are playing. But the reality is they do have a very challenging lifestyle. They report to spring training in mid-February. Some players are already there. They will spend about 2 months there getting ready for the season away from their families. Many of our athletes, about a third of our athletes, come from Latin American or South American countries. So English may not be their first language. They're away from their families. They're very young. And so that's just a period of time that, they may be living in a temporary apartment. They may be living in a hotel. But then the season itself happens. And they will play 162 baseball games in about 180 days. So that's actually more off days than it was in the past. But essentially that means that they are spending a lot of time on the road. They're spending a lot of time in hotels, a lot of times, again, away from their families. And it is a challenging lifestyle. And if your team is lucky enough to make it to the postseason, another month of the season is added on. So there's a lot of opportunity, or risk rather, for injuries, for pain management. And because these guys are the combination of being young and invincible, having a lot of resources on their hands, and are looking to do everything possible to remain on the field and active every single day, the risk of potential drug use is, I would say, slightly higher than the general population. So with that all as background, during your lunch, I'm planning to run through the history of our policy development. Again, I've been in place for pretty much the entire existence of our drug policy. My predecessor, as an individual by the name of Rob Manfred, who's now our commissioner, he was actually responsible for getting this policy up and running. But in 2007, when I got my job, he handed the baton and allowed me to run the program from that point on. We've really changed our focus. Early on, as I'll talk about in a minute, the focus was really on anti-doping, as Regina said, on performance-enhancing drugs. We were dragged to Congress multiple times. We were subject to hearings there right down the road where the focus was on, are we punishing our athletes enough? Is the discipline significant enough? And that was kind of the initial approach to all this, because we were looking to clean up the integrity of the game and focusing on, getting things like anabolic steroids out of our game. But over time, we were quite successful with that, so we're very proud of that. But because at its core, our drug testing program is in itself a traditional employee-based program, that we've really shifted our focus to things like prevention and treatment. Harm reduction came up today, and there's a lot of things that we're doing that I didn't really recognize might be a big deal in private employment, and things that we've been invited to speak about our programs in a lot of unique environments, including today, just because we're always trying to do what's right and what makes the most sense for our employees. And that does serve as a evidence-based, pretty effective model for a lot of different employment settings. So I'll run through the history. I'll talk about what we currently have in place, but very, very proud. And I'll end on, while we haven't figured everything out, we do have challenges that we still need to solve for. We have taken our experience, and we have taken our platform, and we have spoken out. We spend a lot of time in Washington, D.C. Our office, our company does have an office here. We're very, very active in advocating for things that we feel are best practices, advocating for kind of employee health and employee safety-based initiatives in the workplace. And we've aligned with some pretty important organizations that have a very strong message, and we just give them the platform to push that out. So as mentioned, a big kind of focus of today's talk will be on the topic of collective bargaining. And I cannot speak strongly enough about the fact that, in my view, is the most effective way to get good policy in place. We have to listen to the other side. And over the 20 years of building up this relationship of trust and understanding, we have now reached a place where our policies really strikes a nice balance between discipline, for sure, particularly on the integrity or performance-enhancing drug side of things, but also principles of player health and safety and confidentiality and due process. Our model is a joint governance model. What I mean by that is that it is jointly negotiated between the union and the employer. I am here representing the 30 clubs and their owners, but it is one where I have a very good relationship and a daily open line of communication with our union, where we work things out as opposed to taking adversarial positions against one another or getting into things like litigation. But as we learned from the congressional hearings that took place in the early 2000s, as we've learned from our colleagues in the anti-doping space, you can't really have an effective integrity program if you're running that program yourself. So in 2007, we took the unprecedented step of hiring an individual that is our independent program administrator, who is responsible for scheduling all of our random testing, getting all those results. And it is this individual that actually pushes out those results to myself and my counterpart, the Players Union. So we just avoid any sort of impression of covering things up or in any way manipulating the results that we've received. But even though our program is intentionally independent, we do take shared ownership over our policy, the way that it's run, and the outcomes, particularly on the treatment-based side. This is a good place to mention where there's really a bifurcated track that we have under our policy where if you look at this photo here, this is the cover of our current drug testing policy. We don't call it the steroid program. We don't call it the disciplinary program. We call it the prevention and treatment program. And while most of the headlines that you receive in this space, particularly in previous years, the most of our focus is actually on the prevention and treatment space. And it's there that we work together with our union to set up individualized evaluation programs, treatment programs, and try to protect our athletes to the extent possible. And for those that may have substance use problems, we try to jointly support them and get them the help that they need. And this is really unique in professional sports. We've been doing this approach for my entire career. And I'll get into this in a second, but we've remained very steadfast in our approach. And while there may have been some criticism from our counterparts at the other leagues, from our counterparts in the Olympic space that falls under kind of the international or world anti-doping system, there's been a complete shift in that space to the point where now the other leagues and even the Olympic entities are coming to us saying, how do you do this? Is it scalable? What have you learned? And would this work in our space? And if you look at the programs that are currently in place for the Olympics that are going on right now, and certainly the programs that are under collectively bargained organizations like the NFL and the NBA, all of those programs, and not to sound boastful, but they've all essentially taken our model and implemented it into their policies as well. And it is important just to say, there was a lot of talk about kind of new synthetic substances coming out and things that may be coming down the pike and replacing things like fentanyl in the drug landscape in our country. Although we are on the cusp of a big collective bargaining year in Major League Baseball, some of you that are fans may have seen that we may be heading towards a work stoppage in December when our current CBA expires. We carve out the drug policy. Again, we have a very good relationship with the Players Union on this. It's very hard to disagree on things like player health and safety when you're looking out for athletes' best interest. But we update and review our program every single year. And not only is that important, I think, to just make sure that we're continually in the right place, but because new substances may be coming down or becoming available, we need to make sure that we put them on our banned list. We make sure that we have testing methods at our laboratories for these substances. And we don't want to be in a place where we're looking at our banned list and our testing protocols every 5 years. So I mentioned my personal view of joint governance and the collective bargaining process, but it's also really important from the players' perspective. We've heard from them directly. The way that bargaining actually works in Major League Baseball, very similar to other professional sports, is while the lawyers kind of write the policies and the lawyers actually make the proposals at the collective bargaining table, we're both represented by, the entities that we represent. So on the commissioner's office, on quote unquote my side of the table, we may have owners of different sports teams that sit there and just want to be listening and maybe providing commentary. The owner of the Mariners, for example, is the head of our labor policy committee right now, and he's a wonderful man. He's very, very hands-on, very smart, obviously, very successful, but he really feels strongly about the things that I do, even though in an industry like professional sports, aspects of drug health and safety may not be ruling the day. I feel very supported by many, many owners in our sport. But on the other side of the table, you have the athletes themselves. And each team has a representative that is their union representative. And then amongst those 30 union representatives, there are actually elected officials that are very, very bright, very, very sophisticated players that essentially represent the interests of their entire organization. And while when I first started my career, I will tell you that the drug program was actually the last topic that was on the table for negotiation because it was so tense. Now we actually lead with that in the collective bargaining process because we've built up a lot of trust, I think, amongst the players. We're very, very proud of that. But we're in a place now where we're probably just going to be making little tweaks around the edges because we've landed in a good place. So, I think, our kind of consistent approach over years has built up that trust, but is also, we're viewed as a legitimate policy because we do not waver. We're very consistent in our approach, and we're very, very hands-on with respect to not only making sure that the athletes maintain the rules and are complying by the rules, but everyone that's involved in the process, whether it be that independent program administrator, the lawyers that are involved in this program, the people that go out and collect samples for our drug testing, and the lab itself, all operate at the highest level and make sure that there's no deviation from the rules. While most professional sports now have gotten to the place where they've modeled themselves after MLB to a certain extent, we're not that far removed. I don't know if there's any Patriots fans in the room, but I teach a law school class each year, and ironically enough, there's a huge focus. The class I teach is actually on drug testing in sports. And one of the longest discussions we have, we dedicate almost an entire class to it, is actually on the Deflategate, if you can believe it, with Tom Brady and the deflated footballs. And the reason for that is that there's a lot of overlap with the NFL's drug testing program in that decision. And at that point, that was not that long ago. It might still be fresh in certain Patriots fans' minds. But one of the biggest gripes or the biggest complaints in that case was that the commissioner's office was not only the disciplinarian, he was also appointed the arbitrator and made the decision. And so that was that kind of unilateral kind of employer-led policy that did not sit well with the union in that case. And, we've never taken that approach. And I think, that sort of approach has kind of run its time. So we are now in a place where we're running a effective kind of safety-based workplace policy that is intermixed with things like best practices in addiction medicine and addiction science. And a lot of things that were mentioned here today are things that I've learned about in my legal career. I never thought I'd be doing all of this, but we make sure to align ourselves with good clinicians and good physicians who helps make sure that we're operating under kind of evidence-based practices and the current best practice approach to addiction and addiction treatment. Our centralized approach, one of the more common questions that I get is, does each team have their own drug testing policy? And the answer is no. Because we're a unionized environment, we have everything that runs through our central committees and our central treatment boards. On the positive side, that results in clear rules across the board, swift intervention, fully funded resources, and just a consistent approach to treatment and education across the league. That being said, all of our teams are their own little institutions in themselves, and many of them do extremely good jobs, particularly those that are led by strong ownership. And a lot of our clubs have their own resources. Each of our clubs is required to have a mental health clinician on staff, and Nikki Soda's husband is actually one of them and one of the best in our industry. And that just kind of underscores the approach that we take. We need to make sure that we're all aligned on that, but because we are based in New York City and we are just kind of a small centralized entity, it's critical that there's trusted individuals at the club level that can provide information, can provide referrals, and can most importantly provide mental health support for the athletes that are going through our long and somewhat challenging season. So if you carve out down the road of not the PED disciplinary side, but on the more robust clinical side, we actually used to call it the clinical track. That is a joint structure that is run by an entity called our treatment board. That treatment board is just made up of 4 individuals. I serve on that from the league side, and I'm supported by a long-term, very sophisticated, very expert addiction psychiatrist. And on the union side, they have the same structure. So my counterpart on the legal side is someone that we will work out kind of policy discussions and logistics, but actually someone who trained under our addiction expert works for the union. So it's a very, very collaborative approach. We focus on prevention, we focus on treatment, we focus on recovery. And over the years, while sometimes cases are very challenging, it has proved to be effective. And most importantly, we have earned the trust of players. We have earned the trust of player agents. And it's proven to be a best practice model that if you're focused on getting players the help that they need, I think this is the proper way to do it. We defer to the clinicians. Our addiction psychiatrists make all the determinations on what evaluation should occur, who should conduct the evaluation, what type of treatment board or treatment program rather would be most effective for the player involved, and who's going to conduct it. And they get regular updates with that. And this is all based on trying to support the player for whatever challenges that he may be dealing with. It doesn't have anything to do with discipline at all. It's also very, very confidential. And if the player does not sign off on his team finding out about that, we will keep that confidential amongst our treatment board. But it is important, and I know this is a hot topic, so I'd be curious to hear people's take on this. There is a disciplinary component that is structured to actually support compliance and support recovery, not in any way undermine it. And it's a section of our policy that says players' failure to comply or refuse to comply with a treatment program or an evaluation. So in essence, only if a player says, I'm not going to do this, I refuse to do this, could he be subject to discipline. And in my career, there's only been one case where a player's actually been disciplined. So I think we've been very, very effective at convincing players that we're there for the right reasons. We don't want you to be suspended, but that option is there if we need to at least allude to it to try to get a player on board with a treatment program. So I mentioned, early on with the congressional hearings, some of you might not even been born yet, some of the law students in the room, but we are talking in like the 2003, 2005 timeframe. I was in New York City at the time, and every single day that you opened up the New York Times or the Daily News or the New York Post, there was a picture of a player and in a syringe and, some reference to anabolic steroids. Players like, Barry Bonds, or back with the Mark McGuire situation or the Sammy Sosa situation, a lot of public scandals, a lot of media pressure, and a lot of fans threatening to say that they're not going to baseball games anymore. And we even had a number of congressional hearings, like I said, where our commissioner, former players were brought in, and this was a focus of multiple discussions trying to clean up the sport of baseball. But it was only when 2 things happened. 1, when the bargaining parties actually came together to say, we need to solve for this. And 2, when the player frustration bubbled up. Because when you think about it, there are 1,200 Major League Baseball players, and 10 of them are cheating. There's over 1,900 or 1,100 of them that are very, very frustrated and worry about losing their jobs or not performing at a level that these players that are cheating may go on. So when those things came together, we're actually able to make a difference. But there was one point in history that was, in my view, the most important step that we took to try to clean up our game. And that was an independent investigation by an individual by the name of Senator George Mitchell. That was a full-scale, fully funded by the Commissioner's Office investigation where we attempted to find the root causes of why players were using these drugs, where they were getting them, and how we could stop it. And this is a cover of the Mitchell report that actually came out on my birthday in 2007. So I always remember it. That was just something that implemented a number of recommendations, including that independent administration, including, yes.
Did Senator Mitchell have any conflicts of interest in that? Like any ownership stake in any teams?
He was loosely affiliated with the Boston Red Sox at the time, but it was one where I think the reputation for Senator George Mitchell or former Senator Mitchell kind of precedes itself. He's been able to work out a number of kind of international conflicts. And so having seen all of the, actually, quick backstory, I got my job because of that investigation. So I came out of law school. took a risk, gave up the big firm job and went down to New York City and worked for free for 6 months, going through every single document that made up the Mitchell report. And if there's a recommendation for the students in the room, even in a tough industry like Major League Baseball, even in a big city like New York City, working hard, putting in the extra time, and just getting the job done regardless of how onerous it is, can even go a long way in an industry like that one. So I can attest from kind of personal view that there was no direct conflict. That being said, I know it was something where the conflict he actually did experience was that no active players were willing to meet with him. So all of the interviews he conducted were either of non-playing personnel or of former players that were willing to speak up. But the recommendations that came out of that lengthy report are still in place today. And so it's something that, we would not be in this confident spot within Major League Baseball if it hadn't been for that report. But, that was all about PEDs. That was all about anabolic steroids. And there has been that shift from integrity to treatment and prevention. That's going to be the focus of the rest of the talk here today. In addition to the Mitchell report, there were a number of high-profile cases and investigations. I could talk all day on these if I had the time, but I'll focus on two because, especially early on in our programs, the arbitration process, which is our kind of conflict resolution option, resulted in a lot of precedent that really kind of formulate the baseline for our not only our proposals but also the policy itself. And the fact that we take the approach of the player gets full due process, everything remains confidential, and everything remains under wraps until the full arbitration decision is reached, is something that we feel very, very confident about and feels very important. And I think that's one of the sole reasons, if not the sole reasons, that we've been able to gain that player trust, is that we're not looking to railroad anyone. We're not looking to get a name out there in the media. We are going to wait for the process to fully play out before we, make anything public. But that case that I mentioned, which was one of the more significant ones from a compliance perspective, there was a very high profile athlete by the name of Josh Hamilton, who's written multiple books about his personal demons and the challenges that he had with substance use. His case was so challenging that was actually one that ultimately went to hearing. And he was found that because of the challenging nature of addiction, he was actually found to not be in violation of his treatment plan because he was actually trying to comply. And I think that was, very, very eye-opening for myself, eye-opening for our team. And, that was something that really kind of led us or guided us going forward, because we really recognized how significant these issues can be, even for someone who's trying his hardest and we're testing him on a daily basis. But the most impactful case that we've had in my career, and definitely the most difficult day that I've had on my job, was in 2019. We did have an overdose situation. There was a young player by the name of Tyler Skaggs who played for the LA Angels, who was on the road in Texas, in Dallas, in a hotel, and he was drinking and he was hanging out with some staff and some friends. He took a fake pill. It was laced with fentanyl. He was found dead in his hotel room the next day. And while that was incredibly challenging to deal with, I got the phone call from the security person at the hotel, and something that really kind of impacted me in a significant way. It was also one where, to credit our union, within hours of that happening, we were sitting in a conference room talking about how can we prevent this from happening again. And we made a number of proposals, we shifted the way that we view marijuana, but it was with the goal of making sure that a horrible outcome and protecting our athletes from kind of lethal exposures would never happen again. And so we reacted in a very quick way. And from that point on, we were very, very focused on the harm reduction, but also the prevention and treatment aspects of our program, and just kind of allowing the PED side of things to run on its own without a lot of oversight. So our current program does include prevention for sure, includes a lot of testing. I know, hopefully there's some takeaways from today that will be interesting and helpful to you all. The one thing that's probably not realistic is the fact that we have about a $20 million budget annually to do drug testing, which is nice. But it's one where most of that is dedicated to the BET side of things. We're running about 12,000 tests a year, both blood and urine, on our major league athletes. All in, we're doing about 35 to 40,000 drug tests a year. And that's all being done for a deterrent perspective. And it's really interesting, though, because after the Tyler Skaggs situation came in, all of those samples are not just looked for PEDs, but they're also looking for all the substances of abuse. So we have a very robust and significant surveillance program where we're able to intervene very quickly. But as our athletes continue on, whether they're on a treatment board or not, they're very closely monitored. I mean, because there's 12,000 tests and there's 1,200 players, our athletes are getting at least 10 random tests per year, which is much more significant than a lot of other professional sports leagues. But, throughout the process, we're constantly trying to get better. We are very, very focused on things like due process and confidentiality, but we're also very, very focused on making sure that we're using the best testing protocols in the world. We use 2 laboratories. They are World Anti-Doping Agency accredited, one at UCLA and one in Salt Lake City. And although we're doing a lot of testing, we're not taking the approach of, let's try to catch players. Let's view it as surveillance. Let's try to deter behavior to the extent possible. And I think our experience over the last few years in particular is that testing works as a deterrent model, especially when you go in with a little bit of smart testing as well, where whenever there is a potential violation or a violation that results in discipline, we're following up that athlete throughout the rest of his career. And when we do see situations, high-risk situations like a player that goes through surgery and he's placed on the injured list for a period of time, and he may be taking a pain medication or self-medicating because of the issues that he's dealing with, we make sure to hyper-focus on them as well. But the program is split, like I mentioned. For all of the test results that go on the PED side, they run through that independent process. Every single test, though, for a drug of abuse runs through our treatment program. And that's where whenever we have anything, whether it's caused by a valid, legitimately appropriate medical prescription or something that could be a potential addiction issue, we will confidentially reach out to the player and put that through the process if a triggering event like a positive test result ever occurs. So I talked about our addiction psychiatrists. Yes.
I was just going to say, it sounds like you have a pretty broad panel of drugs for which you test and that you can adjust it as needed. So it's not like your typical standard panel of 4 or 5 substances. Would that be? I'm not talking about the steroids.
No, that's very, very, very true. At its core, at the very beginning of our program, we were linked up to the Controlled Substance Act, so Schedule 1, Schedule 2. Yeah. But just on the drugs of abuse alone, we do take a look at that annually. It's grown pretty significantly, and we're now kind of at an inflection point. I would say, like a lot of the substances that Dr. Einstein was talking about and the things that we just need to try to be as proactive as possible on. We do try to stay in front of that to the extent possible, and that's where being guided like addiction psychiatrists can be incredibly helpful because they are kind of on the front lines with a lot of this. But that's where that not waiting every 5 years is really, really important. On the PED side, we're looking for about 400 different substances, so it's pretty significant. And that's why drug testing is so expensive, because every sample is being screened for all of these. On the drug of abuse front, it was kind of pretty standard for a while, but over the last 3 or 5 years or so, we've had to take a look at that annually. And whether it's different cannabinoids, when we were looking for that, we still do ban synthetic cannabinoids, so we've carved out natural, and that's a different conversation. But even with the different analogs of fentanyl and other things that may be popping up in the drug landscape, we want to make sure that we ban them first and foremost, raise awareness and educate about the risks associated with them, but also work with our laboratories to develop methods for testing for them as well. But this approach of having a centralized treatment board, a model works when you model yourself after it. And so this was born out of the drug program, but right now we are taking this approach to things like domestic violence. We're taking this approach to sports betting and any kind of addiction or conduct relates issues that come out of that. Topic near and dear to my heart on tobacco. Same thing. If a player wants assistance and is looking to quit using, we'll help him centrally. And I talked about marijuana. I know we're somewhat pressed for time, but we had a pre-existing alcohol program. We understand the amount of use that may be going on with professional athletes. And when we made the labor exchange for taking a stronger approach to opioids and fentanyl, we didn't give up on marijuana. We just transferred it over to our alcohol policy, which actually gives us more rights. And at any given moment, we've got quite a few players on marijuana treatment programs that actually allows us to help them more than we used to. But it's kind of this centralized model that's independent, that the players are very supportive of. And so, my job and my influence, my team's influence has really grown throughout our industry because we are now managing all these different conduct issues. And, again, not to come across as boastful, but because we've been dragged through the coals a little bit, because we've been dragged into Congress, a lot of the other leagues are looking to us for guidance in this space, just like we look to them for, guidance and assistance on non-drug related issues. So, during my career, we've seen every single major professional sports league reach out to us, meet with us, and adopt our model on the prevention and treatment front. And, very proud of the fact that, just 4 or maybe 8 years ago, if you were an Olympic athlete that tested positive for cocaine, even unintentionally, you either got a 4-year ban or an 8-year ban. And that was without any sort of treatment option whatsoever. And so working with people like Marilyn Hustis and others that are involved in kind of the WADA, substance front, we've been able to lobby to the extent that we have influence to try to get them to offer these treatments-based models. And we're very, very proud. It's public now, but there is a new world anti-doping code that's coming out in 2027. And within that, if you lined it up against the MLB policy, it's almost word for word. And so that's kind of a really fulfilling, thing for me, just because I feel very, very strongly about Olympic sport and also our approach to supporting athletes. And it integrates, even though the Olympic athletes are not unionized and are not represented from a labor perspective, we're seeing all different policies integrate labor law principles, working with the athletes themselves to come up with the policy that makes the most sense, and just being ethical and looking out for the best interests of the athletes as opposed to just focusing on unilateral discipline. Our program is relatively significant, but when you think about it from an Olympic perspective, the biggest holdup for them was the size of the Olympic testing pool. And I think the fact that they've adopted the MLB model just shows that this kind of evidence-based effective approach is relatively scalable, and you don't even have to dedicate that significant amount of resources to it. But, the one really, really positive, if not the most positive thing that's come out of all of this is through the post-Congress kind of, Major League Baseball anti-doping anabolic steroid issues, we've tried to learn from the best, and we've tried to align with others. And that has resulted in one organization that I'm the chair of the board of currently, called the Partnership for Clean Competition. It's made up of MLB, the NFL, the U.S. Anti-Doping Agency, and the U.S. Olympic Committee. We work together to pool our resources just to try to make the sports drug testing and the anti-doping landscape in the United States better. So we will fund research. We funded about $45 million worth of research over the last 15 years. We try to make drug testing cheaper. We've developed testing methods like dried blood spot testing as opposed to syringe testing, just because it's faster, easier, and less invasive. And so it's through these efforts of this PCC that will hopefully allow less funded sports entities to do some of the things that we're doing and to set up the policies that we think are the best practices. And just a quick aside, even though we're spending a lot of time talking about substance use and kind of treatment-based interventions, just want to make sure that everyone does recognize that although we do take a non-disciplinary approach to drugs of abuse and a lot of kind of conduct that can be addictive in nature, we take performance-enhancing drugs incredibly seriously. We've already suspended one player this year, and if it involves an issue of integrity of the game, that is going to be a disciplinary perspective. But, outside of that, we barely see much of this anymore. We had 2 suspensions last year. I think we had 2 the year before. Just not a lot of high frequency of use. But, everything else is focused on rehab, treatment engagement, and compliance. And although I'm a massive proponent of collective bargaining, I'm a massive proponent of testing. Perhaps the most effective model that we have from a treatment and prevention perspective is actually on education. We start very, very early. We actually start before players become professional athletes. So there's a draft every summer, and we meet with the top prospects every year to educate them on things like substances of abuse and performance-enhancing drugs. But we also go down to Latin America. You may not be aware that each of our teams, particularly the Mariners, who have probably the nicest academy in baseball, they run an academy for young Latin American athletes where they will have them train all day. and get them ready for their baseball career, but they'll also take them in the classroom. And so we make it a point. I have a couple of staff members that are based in Santo Domingo, where they will get in front of these kids multiple times a year just to start that baseline of information and education. And we have some data on this, that by the time these young Latin American athletes in particular come to the United States, they've received drug prevention education at least a dozen times. Our education certainly focuses on prevention. It also focuses on the overlap between kind of health and performance. These are athletes at the end of the day, and the best message for them sometimes, particularly at an early age, is not that they could be risking their health, but actually that they could impact their ability to be a top baseball player. And over the last few years, particularly after the SCAG situation, we've been very, very focused on the mental health resources that our clubs offer and the risks of overdose that are out there. We regularly update our educational messaging to make sure that we're capturing those emerging risks or new substances that are out there. And whole other presentation on this, so I know we don't have a lot of time, but for those players that come up through our academy system that English may not be their first language, incredibly high risk when they come to the United States. But there are, even prior to that, there's a lot of substance use risks that occur in Venezuela, in Colombia, in Panama, in the Dominican Republic, that we make sure that they're aware of, because the last thing we want to see is an athlete getting caught up in one of our drug program violation situations where he doesn't understand why it's happening. Quick aside, but I know there was some talk this morning about prescription drugs, particularly things like Adderall. Anytime you run a quality drug testing program, you need to have an exemption process for medications that are legitimately prescribed. The number one substance that we deal with in this space is Adderall or ADHD medications. And it's one where, because of the nature of baseball, the fact that there's a lot of time on the road, because the season is long, and some people think baseball's boring, stimulant medications are very interesting to athletes. And going back about 15 years ago, we were seeing a troubling increase of applications for Adderall use in the latter part of the season. A little bit of a chin or a head scratcher, but through the collective bargaining process that following year, we put together a gold standard independent process where we created a channel for if a player has a legitimate diagnosis for ADHD and he needs to take Adderall or Ritalin, he will be permitted to do that, but only after he goes through an independent evaluation by what we refer to as a certified clinician. And that application is reviewed by one of the top ADHD experts in the country at Harvard, NYU, or Columbia. And we've stayed the course throughout the past 15 years. And it's really fascinating. When that policy was put in place, about 10.1% of our players were approved for a TUE for an ADHD medication. And without changing anything, that rate last year was under 4%. And that's lower than the general adult male population, at least according to our experts. And it's just really, really interesting how that has become kind of a self-policing type thing, which again, I think kind of that clinician-based medical independent process is kind of a baseline approach for everything that we do in this area. So shifting away from our internal policy, I never miss an opportunity to quote our former commissioner, Bud Selig, where from his office in Milwaukee, he used to say regularly and proudly that baseball is not just a professional sport, but baseball, particularly Major League Baseball, is a social institution. And we have an obligation to our fans and to the general public to use our platform for good. And that has led us, particularly since 2019, to engage with a lot of different national public health initiatives. Certainly happened in COVID, where we were using Nationals Park for the largest scale vaccine clinic in the country. And we were using our platform and aligning with the other professional sports leagues to put out important messages on things that aligned with our values. And we've also engaged with a lot of strategic partners to not only try to protect the interest of our athletes themselves, but also their families and also the fans. And we're very proud of the fact that we've been invited to some very important events, including an event about 2 years, invitation from the White House to talk about our approach with naloxone. I didn't think it was that big of a deal, but one of the other areas of my job is we make sure that all of our players have an emergency action plan, or all of our stadiums rather have an emergency action plan in place where there's AEDs and there's CPR. We just added on naloxone to that, and we thought it made sense. And that apparently, was a very important message from a private employer perspective. So we've been able to, get out there and speak on that. And we've also just, spoken about our other efforts on raising awareness on overdose and how to prevent it. And in particular, through the naloxone efforts, but also going back to when we were trying to make some changes on the opioid fentanyl testing front. Representatives from ONDCP under multiple administrations have been incredibly helpful to us from a public messaging standpoint and in the background in making sure that we're following best practices. And another very, very important partnership that we've forged coming out of the negotiations that occurred after the Tyler Skaggs tragedy was that not only were we making changes on testing, but we also had an obligation, both bargaining parties had an obligation to raise awareness amongst our fans. And while Major League Baseball has millions of followers on social media and tens of millions of fans come to our games each year, we are not experts in overdose prevention, stigma reduction, or even in fentanyl generally. And so we needed to align with some important partners to make sure that our messaging and our content was good. And the organization Song for Charlie is the group that we chose to align with. They are an incredible content factory, and kudos to the people that established that organization, particularly Ed and Mary Ternan, Marshall Lee Taylor, who many of you know, and Dr. Gina Malagold, who's become our Spanish-speaking educator for all of our athletes. And, their messaging is so sophisticated and so smart and so on point that we essentially just have offered our platform to them to, reach a broad audience. And while, we will have PSAs playing on MLB.com, we have, filmed videos that have played in places like National Park. One of the programs that I'm most proud of is we run an event at every single Major League Baseball park each year in person for kids, and we call it the Play Program. And it's a great program where kids will run the bases and do something athletic, but then they'll sit in the stands and listen about good nutrition. Well, over the last 2 years, we've made sure to have a fake pill and fentanyl education session at those Play programs as well. So while the volume is not massive, we are reaching kids in every single community where we play, and we feel that's very, very important. And last year, we're very proud of the fact that one of the initiatives that Song for Charlie supports is National Fentanyl Awareness Day. And Major League Baseball, through our PR and communications programs, put out a lot of important messaging on that day to just raise awareness and do our part to highlight this important initiative. Also, this morning, just to kind of, cue up what we discussed, a lot of integration with mental health. This is something that we feel very, very strongly about. In addition to physical health and orthopedic injuries and arm health, we understand that mental health is kind of a baseline of all of that, and certainly inseparable from all of these treatment-based and addiction policies that we have. We have a number of league-wide campaigns, including our MLB Together initiative, where we're putting out messages to our fans and to our young fans in particular, where it's okay to not be okay. Our athletes are speaking out on this. And we've worked with an initiative with the crisis text line that if any athlete or any fan rather needs assistance, both, they can text this line and have access to someone that can help them. So, that's something that we feel very, very strongly about internally and externally. And we make sure that our former athletes also receive these resources as well. So as far as going forward, we've talked a little bit about, new substances and how that's a challenge. We actually just recently published a paper on this topic where myself, a colleague at the U.S. Anti-Doping Agency, is actually someone from the Department of Defense we have a lot of overlap with, talks about these evolving risks of new synthetic, unregulated compounds that exist out there, both on the substance of abuse side, as well as the performance-enhancing drug side. Massive challenges from a deterrence perspective, because you don't always know where they're coming from, and even more significant challenges from a detection perspective, because these things seem to be changing every single day. And while, my core job, my responsibility is to look out for our drug-tested athletes, we use this paper to try to sound the alarm for the general public as well, and just to underscore the importance of surveillance to the extent that you can have it, better regulation in this area, and certainly more research. So going forward in 2026, it's going to be a very challenging year for Major League Baseball. We will be starting a collective bargaining process with our union in the next couple of days. And even though there's going to be a lot of focus on economics and player salaries and revenue sharing and things like that, we plan to continue to collaborate with public health entities and regulatory authorities to make sure that we're in the best possible place from an athlete health and safety perspective. We are going to remain diligent and focused on protecting the integrity of our game on the one track, but also looking out for player well-being as well. We understand that responsibility. We also understand that our athletes can serve as role models for our fans. And if they are, speaking out on mental health or supportive of mental health initiatives or substance use initiatives, we understand the power and the value of that. And to the extent that we can remain here, I think it's a good thing that we will try to maintain our leadership role in sports drug testing going forward. So just to wrap it all up, we do feel that our program demonstrates an effective way to conduct kind of a joint-based treatment-focused policy, integrating labor law principles along with player health and also kind of clinical perspective is the best practice from our perspective. We think through our surveillance testing and through our experience over the last 20 years that there may be lessons for addiction policy, addiction medicine, and also legal frameworks or regulatory frameworks as well. And I'll just say it one more time. I think it's very, very important, even if you take the sports out of it. If you are in an employment-based setting or a labor-based setting, that the role of collective bargaining and actually working with the employees that you're looking to protect directly to make sure that the policy makes sense and can be effective is a very, very important approach. And hopefully for you all listening here today, that some of the elements of that collectively bargained model that I think certainly has evidence and certainly has data, has proven to be effective for at least the cohort that we're responsible for, could be potentially transferable to other employment settings as well. Thank you.
We have one question over here.
Yes.
Another question. Thank you. I come from Colombia, and I'm a huge sports fan. Specifically, most of the soccer. I've seen many young players totally destroy their careers just because they become okay. They think they can go party, have fun, and end up having great alcohol. I think it would be great if eventually you could do international partnership with our leagues, not only like what you have with the kids in Puerto Rico or Venezuela with baseball, but partner up with other sports. We really do need it.
Yeah, I mean, if that problem exists there, I mean, we would love to take the opportunity to speak with them. We have a very close relationship with Major League Soccer as well as the National Women's Soccer League in our country. But, we're very aligned. We're actually business partners with the U.S. Anti-Doping Agency, who is going to be responsible for the World Cup next year. And so there may be an opportunity to engage on that. But I will tell you, again, not to sound overconfident, but our alcohol policy has proven to be pretty effective as well, and to the point where it is based in principles of confidentiality and privacy. But when you approach a player and say, we want to help you and try to make you a better athlete, but to keep you on the field and to keep you out of jail if you're engaging in DUI or something along those lines, there is not a case that I can remember, and there's a lot of them, particularly in the minor leagues where players have a little bit more time on their hands and maybe driving in spring training under the influence. There's not a case that I can remember where a player said, I'm not going to, Dean, we can talk further about this if you're interested. While on the drug front, because of the policy that underscores all of it, if a player doesn't go through his evaluation, doesn't comply with his treatment program, individualized treatment program, he could be subject to a sanction. On the alcohol or now the marijuana front, while any sort of treatment is fully voluntary, and that's the far as we've been able to get our union to go on that topic, as far as the actual initial meeting, that initial evaluation, the player has to do that in our cohort. And I think that that's the hook, because if you can get him or her, in the context of female soccer, to understand that you have you may have a substance use issue here, we're just looking to work with you and to help you. The buy-in has almost been 100%, which is great.
We have two other questions over here, Rich, and then Lee.
Formerly of ONDCP, I left at the end of last year, but during the 5 years where I was staff lead for anti-doping, I want to thank you and your colleagues at Major League Baseball for always being there to advise and support us throughout different administrations. So thanks for that and for a great presentation. Just one comment on what you said. These programs you do in the Dominican Republic and elsewhere are really critical because the stakes for these young men trying to make it in baseball are so high to be able to get a big contract and support their families. It's a lot of pressure on them, and getting them to know early that it's not going to help them to
try and cheat with steroids or other drugs to try and make it is really important for their health and development. I wanted to ask you, you mentioned WADA and the World Anti-Doping Code, and we've been back and forth a bit. I gotta be careful here, but yeah.
But I thought it would be useful for you just to explain to the audience here why it is that the United States professional sports leagues does not fully adopt the World Anti-Doping Code. It's been something that WADA has quite publicly and explicitly criticized the United States for not having our professional leagues adopt the code. And I know there's a strong logic behind that, but that's all we'd like to share.
Yeah. No, that's probably the most important question you can ask on the anti-doping front, because it is one that I don't think there's a lot of understanding outside of the United States on why we have gone down that path. And, the short answer is that we are obligated to collectively bargain with our union. And look, if our union said we want to become a signatory of the World Anti-Doping Agency Code, we would entertain that. But, short of that, U.S. federal law requires us to negotiate. And for those of you that are not aware, in the Olympic world, athletes have no representation. They are subject to a consistent set of rules, which is called the World Anti-Doping Code and its associated procedures. But that's the rules. And not only do they have no kind of right to negotiate it, well, there's some athlete involvement now, but they also don't have a specific set of rules for their sport. So the same set of rules that applies to a figure skater would apply in the Winter Games, would apply to a badminton player in the Summer Games. And so, I'm a very strong proponent, and I've spoken on this at international conferences on having a specifically tailored program in the Major League Baseball is not unique in the fact that any U.S. professional sports league that is subject to U.S. federal labor provisions and labor law is required to negotiate with a union. And, there is no professional sport in the United States that has signed up to become subject to the WADA code. There's a lot of other kind of, important points to raise about the fact that, we're very proud of the fact that we proceed swiftly. To give you one example, on the disciplinary front, I was involved with the Manny Ramirez case. For any Boston Red Sox fans in the room, Manny Ramirez 1, Manny Ramirez 2. There may have been a Manny Ramirez 3, but we'll keep that confidential. From the time the sample was collected in Florida, it was a spring training test, to getting it reported from the lab and imposing a full suspension was 10 days. And that was going out to Los Angeles and having an arbitration hearing where Manny decided to not come in the room. To compare that to one of the long-standing figure skating cases that happened at the last Olympics, that young woman didn't even get her day in court at the Court of Arbitration for Sport for 3.5 years. And so, there's a lot of evidence in the deterrence world that swift resolution, swift intervention can be the most effective tool that you have. But at the end of the day, I am very proud that I had formed a very strong relationship with WADA. I go up to Montreal a couple times a year to exchange best practices. There's a lot of mutual respect there. We are very, very aligned with the U.S. wing of them. Their CEO, Travis Tigert, is an incredibly close friend and colleague of mine, someone that I look up to a great deal, someone I've learned from a lot. We've actually gone into business with USADA from a drug testing equipment perspective. We built up things to protect athletes better. And so at the end of the day, we are subject to different rules, and there are legal reasons why we have to do that. But there's also a lot of really important best practices within the World Anti-Doping Code where if something makes sense, particularly from a due process standpoint or from a scientific perspective, we're going to adopt that.
Okay, we have time for 2 quick questions. Elise, Kelly, and then Tom.
Hi, Elise Grossman. Great presentation. It was really, really interesting. I thought the advocacy and awareness part was really important. As you stated, it's not just for the players, it's for the public. And my question leads me to many years ago, I worked with CSPI, Center for Science and Public Interest, and they had a campaign for a family-friendly national stadium, asking for not having alcohol ads on the field or on the scoreboard, because we know that marketing has a big effect on youth. Do you guys have a role to play with what the stadiums put up?
The answer is yes. And if you see the bags under my eyes, that's where it comes from. Alcohol is a permitted category, so we do allow that, but every single ad that plays in a stadium, in print media, on any MLB website, or anything during one of our broadcasts is, myself and my team have to approve it now. And so while it's a very challenging undertaking, just because of the amount of sponsorships and partnerships that are coming through, it is something that I've always wanted to be involved with, because I do think it's very important to set kind of a family-friendly kind of setting, particularly in stadium, but also one where, I hope it comes across. I wake up every single day. I've been in baseball for 19 years now, and I still think, the stars every day that I get to have a job that I really am motivated about and enjoy. But I also feel very strongly about this mark. And it's something that, it stands for a lot of history. It is an institution in our country. And if you start going down the path of bad advertisements or things that send the wrong message, for example, we're never going to allow a cannabis dispensary, for example, to promote at our stadium. We don't approve any sort of dietary supplement that could have a risk to a young kid. We don't want to see that sort of advertisement next to one of our team marks or one of our marks. And so, some of them, there's a little bit of discomfort, I will admit. And so, I think the alcohol one is probably the most challenging one, just because that is a permissible category, if you will. But there are a lot of impermissible categories where we use that hook to make sure that they don't play. So that's something where we need to hire more people, because that's become more and more of our job. But it's really great. I've been wanting to be involved in that space for a long time. And it wasn't until really my boss became our deputy commissioner and our chief legal officer, and kind of allowed me to kind of be involved in almost like this ethical police, if you will, which is not a bad spot to be in.
Hi, thank you again for having me here. I was a softball player for 8 years of my life in college, and I saw a lot of good athletes using substances, alcohol, mostly smoking, and just kind of team environments. And you mentioned a lot about youth prevention and other things that the MLB is doing. Have you worked at all with any colleges or even college baseball using role to kind of get more education and prevention about substance use at a college level?
Yes and no. The collegiate space is probably the most challenging space for these sort of initiatives, because there's just so many universities. And not only is there a large volume of athletes, as you know, there's also just multiple kind of levels and categories of regulation, right? You've got the NCAA, which may or may not be a thing in a couple of years. You've got the colleges themselves, and then you've got conferences. And ironically enough, all of those different entities have their own drug testing program as well. So you've got schools that have their own system that look for one thing. You've got the conferences, at least the big ones, that do their own testing. And then you've got the NCAA program, which I'll say it is not very effective, just because it's just such a big undertaking. But that being said, I'll respond to your question in two ways. We do have a pre-draft program that we try to reach as many athletes as we can. So at least for baseball players currently, before they come into the Major League Baseball system, which is pretty stringent, we make sure to give them written materials and online materials and in-person presentations, because we want to make sure, and it's all translated. We want to make sure that we try to reach as many athletes as we can to set them up for success, as opposed to setting them up for failure. But I think we'll end on a positive note. We're very, very excited about the fact that we've underwritten and supported a professional softball league in our country. And it's got a long way to go, but my former wall mate, an individual by the name of Kim Ang, who is probably the most impressive sports executive that I know, is the commissioner of that league. And while really early on, and they just did meetings, and we actually got one on the books for this month about having that system kind of mirror the MLB system, at least from a education and probably a drug testing perspective. And so hopefully if we go down that path and start building that up, we can then open up opportunities to talk to college softball players as well.
What does recovery look like in MLB? And by that I mean, how do you be able to shift from this common view of a commodity who has more value on the field than a human that has the promise of recovery and wellness during his career and even on
Yeah, good question. And I thought a lot about that when I was listening to the presentations this morning. And again, just thank you for those. I'm still learning, right? And I'm a lawyer by trade, but want to continue to surround myself with people that are really, really experts in this area. I think the most important thing from our perspective, at least from a clinical treatment board perspective, is to take the baseball completely out. And while sometimes, you have to consider logistics, like it's really hard to set up a treatment plan for a player that's going to be playing in 30 different locations throughout the entire season. It's really hard. But you take the baseball out of it. That's just a job. You support him as a human. And it is interesting, when you talked about kind of when there's focus on abstinence and things like that this morning. Well, I think our policy, the language of our policy supports that abstinence is not the goal, because there's actually more of a nuanced approach to that. If a player tests positive on a treatment plan, for example, it's not a clear violation. There has to be the positive test plus a complete disregard for that. It's the language that we use. So I think that that's the right approach. But it is interesting that throughout the rest of a player's career, whether it be at a major league level, minor league level, or he shifts over into a coaching role where he's not a player anymore, he's going to continue to be monitored and subject to all of these options and resources. And so, even if he's graduated from his treatment plan, which is the goal, and many of you in the room will know more about that than I would, there's still going to be surveillance testing. And so if an issue comes up again, it will come up. And so, that's one where it's happened many times, as you can imagine, where a player graduates from a program, is no longer subject to the clinical aspects, but then he gets, brought back into the system. And that's where we have to keep trying to support him. But, it's one where I think it's very important to underscore that there have been players, Josh Hamilton being one of them, where, we supported him into his retirement for a couple of years. But, you can't help everyone, particularly when the cycle of players come in and out. But we can set up resources for former players. And so there's an online system, we call it the Player Resource Center, everything from, substance use concerns, mental health support, financial support, job seeking. We have resources out there for the cohorts of former players that I will tell you, and it happens about once a week, where a family member or a spouse or someone for a former athlete says, I need help. If it's a player that was just removed, we might just be able to kind of continue on the support that we offer our current players. But if it's not, we also have another program called the Baseball Assistance Team. And it's a very well-funded resource for a variety of challenges that may exist out there. And as long as you spent one day in baseball, you're eligible for these resources. And so some of them may be substance use related, but it may also be you're having trouble with your medical bills, or you need mental health support, or you're looking for a physician, or you're dealing with kind of end of life planning. Whatever the situation may be, we do kind of take a family-based approach, I think. It's interesting. Baseball is a, multi-billion-dollar industry, but it's really like a family focus on a lot of things that we do. And so, it's one where, we host an event every December at our winter meetings where we highlight some of the success stories of this. And I'm not directly involved with the baseball assistance team, but it is one where the executive director of that, a couple times a year, he will either reach out to me and say, this former athlete is looking for a clinician. Can you help him on behalf of BAT, or vice versa? Someone will contact me, or, my name's out there in the public domain, or, our addiction psychiatrist name is out there. They will come to us. We'll connect him with BAT. We hopefully get him the assistance that he or she may need.
Thank you so much. Okay, so you have like a 5-minute break until 1:30, when we're going from the baseball diamond to the international realm. You're going to really love these two presenters, and we'll see you at 1:30. Thanks. And was a former counselor to the Secretary of Defense. So she not only brings expertise as a law professor, but also as someone who's been there and worked for the Department of Defense in various administrations. So with that, Rich is going to start us off, and I will leave it to you. Thanks.
Great. Thanks, Regina, and thanks everyone for being here. I'm going to walk around. I do this with my students, helps them focus, it helps me focus. I might pop over and ask some of my former students or a current student a question. So I'm gonna go through some side issues, and I really want to encourage folks to
during the presentation or after to ask questions. There's been, I think, a lot of skepticism and criticism among the some experts, academics, advocates about supply side. And I'm of the belief, I've worked on supply and demand side, that supply side programs should be subject to scrutiny. So, and questioning and some kind of thinking about, are these investments, do they have a return on their costs and their consequences? So I would encourage you, try and stump me, ask a tough question. I am not coming here as a defender of everything that's ever been done on the supply side, but I am coming talking about what I see as their value, especially if they perform and are involved and focused on what are the greatest threats. Can I ask, sorry if I ask you to flip slides for me? You go to the next one, please. So I'm going to start. There's an agenda planned today, a little bit about the conventions, the tools, the cons and pros of supply reduction that I'm going to flag and not so much try to refute, but I want to raise the cons and then I want to discuss them and try and get to a balanced point because I think that some of the cons that I'm going to discuss, they raise fair points, fair questions. Talk about the supply tools, because I think that folks who don't really focus on supply might think of just a couple of things they've heard, border enforcement, maybe a COCA or opium eradication, and don't know all the tools that are available. Some conclusions, and I defer to our host on how they want to handle the further discussion and questions, but always welcome that. Next slide, please. Keep going. So, in order to sort of facilitate dialogue and thinking, I thought I would try to raise some of the tough questions myself. I think these are good questions. I'm going to try and respond to them and ask you to think about them. And if you think that somehow I've missed some of the tough questions or I skated by, you can feel free to come back and ask me again. Next slide.
I do think you missed one question.
What's that?
Why is the focus on the supply side and not the demand side when it's the US and the Europeans doing the cocaine and us providing it? But if you have less demand, you have less supply. Wouldn't that be problem solved?
Well, I'm going to take that question right now because I love tough questions and I'm glad you weren't shot. The demand and supply is a dynamic relationship. Demand can drive supply, which I think is the reference to your the underlying point of your question. Absolutely, it can happen, but supply can drive demand. And I remember having this debate with a Colombian minister a few years back when I raised my concern about the rapid mounting of coca production and cocaine production in Colombia. And he said to me, this was 5-6 years ago, said, "Why do you care? Your cocaine consumption is plateaued and going down." And I said, not for long, because as more cocaine comes into the US, low price, high purity, that leads to more demand. And I think that we need to, all of us need to realize there's a back and forth. It's not just one causes the other. People like cocaine. If there is cocaine available on college campuses, in communities, available for parties, discos, whatever, people consume it, and they are, and they have. Both sides, both supply and demand are important. Hope that was a start to answer your question. We could talk more after class. So I wanted to highlight this slide and also express for myself, longtime expert, I'm supposed to know, drug policy. I've been working it for my whole career, but things keep changing. And so even those of us who work in it have to stay current and recognize things are evolving. I highlight, of course, opium, coca, cannabis, they've been around forever. But in the last 150 years or so, there's been a lot of change as these substances have been synthesized, as the alkaloid has been pulled out and concentrated. So, I'm not don't have a big freak out over a coca leaf. People make tea, it's a mild stimulant, it's not much different than caffeine. There are reasons why it's illegal. It complicates interdiction and tracking of the various substances. If someone has a shipment of coca, they don't know what it's necessarily for. But people aren't overdosing and dying in Colombia when they have coca tea. And cannabis, different. It's a complicated story. I'm going to make a brief comment on that in a second. It's funny, in my class, I show a photo of what an early hypodermic needle looked like. Someone had to invent it, right? We didn't have injection drug use before we had hypodermic needles. That happened right before the Civil War, and morphine was used, injected, but not more really after the Civil War as it became more common. But that was the painkiller that was used. People rubbed the morphine salts in wounds, of course, all the amputations and horrible wounds and crime and suffering. I tell you, to be honest, with cannabis and marijuana, I felt over 10 years ago that, oh my God, we got opioids, we got cocaine, we got methamphetamine. It's a lot. It's a lot for us to be making drug policy on those drugs that people were most concerned about, and then also being involved in a debate over legalization. But, over the last 10 years, as the country is legalized, the products have changed, the use patterns has changed, the potency changed, and even the New York Times changed and started reporting more on the drug consequences. I think some New York Times reporters are listening in, so that's why I dropped that line. But there's been great reporting on New York Times. And if you're not sure, Google New York Times health consequences of marijuana and see what they've been writing. Some very good articles about it. So I'm just making the point. The drug problem evolves. It's a difficult problem. It's one that's impossible to ignore, but hard to solve. Next slide, please. So probably you all seen this slide, and I won't belabor it, but just to highlight the point that the drug problem evolves. And at the start of the prescription, oxycodone came out in '96. Use started elevating of prescription drugs around 2000. And for that time, we were focused on, as it became apparent, what was happening, which didn't happen right away, unfortunately. We were focused on a prescription drug epidemic. And then later, the drug problem changed, moving to heroin and then fentanyl. And now we're in this wave where this polydrug use combined with stimulants and other dangerous substances, other speakers have already mentioned. So it's quite complicated. Next slide, please. I understand some of the response to the rhetoric of the United States about blaming other countries, blaming Mexico, when there's the issue of the currency and the proceeds, illicit proceeds going back to Mexico, weapons. There was just a story in the paper about these high caliber bullets that were coming across from the US. Absolutely, those issues are fair game and important ones. But, my point of view is there's just no easy solution. You can't just, look at the complications that we've had just with marijuana legalization, right? And imagine them with fentanyl or methamphetamine or these harder drugs. And again, I'm happy to talk about it. I'm not saying it's beyond conversation. I'm just saying I don't see a feasible, pragmatic pathway, let alone a political pathway, if we wanted to do to change it. But again, fair game. Next slide, please. Okay, keep going, please. So a couple slides on the treaties. I think sometimes people forget that we have this well-established global multilateral system that's really important. There's a lot the U.S. can do bilaterally. We have the DEA and a lot of great folks in State Department, Treasury, ONDCP, but we can't do everything unilaterally. We need a system that allows us to help schedule and ban drugs internationally. Remember, I know you all know this, but the precursor chemical controls, the precursor chemicals used to produce fentanyl are produced primarily in China, also in India. They're either smuggled or they're imported towards the Western Hemisphere, up into Mexico. And that transaction, that's the key supplier for synthetic drugs, for methamphetamine and fentanyl, and also for other drugs. That transaction, that trade in precursor chemicals, the US isn't a party in that trade. We don't get the information that we could get. We don't have information about these shipments because they're not coming to the US. We need a global system to help monitor them. We get that through the UN, through the International Narcotics Control Board. And we need a system to globally schedule these drugs. There's an annual system through comes out of the treaty system, where every year people vote at the Commission on Narcotic Drugs, which I'll say a word about later, on a sort of vetted list of new drugs and chemicals to be scheduled. And a lot of countries, big countries like the US, we're not like everyone else. We have this very elaborate system of reviewing and banning things ourselves. Congress can schedule and make drugs illegal, but most countries rely on the UN. They won't ban something until the UN acts on it. So that's an important factor. So I'm just trying to make the point, we need the UN. There's sometimes China will ban something because they've engaged with DEA or the US, but often they'll wait for the UN to act. There's a scheduling system that's not unlike the one we have in the US. There's a picture of a coca plant, and here's just an image of it's a little hard to see because of the white background, but with the heroin, fentanyl, and carfentanil being concentrated. Let's go to the next slide, please. So this should say 1914, so off by 100 years. Just very briefly, the whole global drug supply control effort started in the Philippines, because in the Philippines, it became a US territory. The US, in the Philippines, there was a tradition of opium use, and the missionaries there, as the US took over, wanted that to change. They lobbied President Roosevelt, and he agreed, and they called on, and Roosevelt called for a global conference. So the first global conference was in Shanghai. I got to visit. I went it was an anti-doping and sports meeting, and I went to the site of where it occurred. And it's kind of ironic that the whole global drug control system, and maybe it would have happened anyway, but it was started through US leadership. Although there was one problem, we helped encourage the world to ban all these illicit drugs, but we had no federal domestic law controlling drugs ourselves. So that had to happen. So when the folks who helped put together this initial opium commission, including some of the folks who are working in the Philippines, missionaries, they came back and they lobbied to create the Harrison Act, which banned illegal drug use, made drug use illegal in the US. You guys, as attorneys in the room, understand that 100 years ago, federal law was less clear about what was the role of states and federal. States had a very strong role in governing health issues. Let me keep going. So, tried to simplify the different treaties and put them all on one slide just to summarize them. I won't read all this, but basically three treaties. The Single Convention, which combined all the earlier treaties and put them all together in one place, which was so all the original agreements and understandings. In 71, the Psychotropic Convention, and in 88, the Trafficking Convention, which expanded law enforcement cooperation, financial records, mutual legal assistance, money laundering, and continue to evolve and support cooperation. And it's interesting, because a lot has changed since 1988, and we live in a world now much different. back then, there wasn't really a need to so frequently assess and look at the various drugs because things move more slowly. Now we live in a world where when China, say, bans a chemical used to manufacture synthetic opioids like fentanyl, and I think you know this, but like we say fentanyl, but really it's a whole class of related drugs, not just fentanyl. So there are nitazines and other substances that act similarly on the body. But the chemical manufacturers change one molecule and they have a new precursor chemical. And then that chemical has to be banned. Now, sometimes there's been broader bans, but it's still a problem. And also there's a problem with designer precursor chemicals that are sort of made to order, again, that are not illegal under the current system. So I argue in my book that's coming out in 10 days from today, I have 32 recommendations of the book. Most of the book is really on domestic policy, but I do have one recommendation that I wanted to mention today for the first time. I'm calling for a new convention. Almost 40 years, when now all we have is a once-a-year opportunity to ban substances. When new ones come out, not just opioids, new psychoactive substances of all kind. And I think we just need a much more faster system. I mean, I've loved going to Vienna for 12 years to go to the Commission on Narcotic Drugs and being a part of the US delegation there and the US votes on these drugs. But they need some system to either designate people to take temporary action or to vote remotely or to otherwise move faster because they have a system that's built for a world we no longer live in. So I would argue and recommend that State Department work with colleagues and start the process for drafting a new convention. There are workarounds to that problem that I pointed out, but I think looking at how we might have a system that was based on today's problem and not cobbled together based on stuff 40 years ago or 100 years ago would make sense. All right, next slide, please. I mentioned the Commission on Narcotic Drugs, and this is the largest annual drug policy, global government drug meeting of the year. And the US often goes, the US always goes, and it's our opportunity to do multiple things, to meet with all the government counterparts, to participate in these side events, panel discussions, where advocacy groups and governments use to highlight their priorities. There's also a legislative committee process. There's something called the Committee of the Whole, where countries that have resolutions that are used to set policy for the UN propose resolutions. The committee works them. They create a negotiating group. I know this is a bit complicated, but these resolutions then are brought up for vote. And while I was working at ONDCP on this, we did the first resolution on recovery and the importance of recovery support. Peter Gaman helped us write that resolution. So Peter, raise your hand, make sure people know you're there too. And we also did resolutions related to prescription opioids, alternatives to incarceration, and precursor chemical control. And, what these resolutions do and what these side events do is they socialize issues that are priorities for countries such as the US. And it's great to have a forum to do that and to be able to meet together. And it is interesting when you go there to see which countries come prepared and how important the US and the EU are in terms of making decisions. Please.
Will there be any changes now that the US is not part of the HOW?
We're still signatories to the convention, so going to the Commission on Narcotic Drug is not affected. And certainly not, I understand that there may be a bit of mood shift based on some global policy focus. So the US delegation will have to go and manage those perspectives. but I'm sure that they'll send some folks to go to represent the US. And I think I'm sure you understand where I'm coming from, which is support a strong US drug policy at home and abroad, including a lot of our own things we can do by ourselves, but we can't do everything by ourselves. We need partners. So I hope they send a strong delegation and meet widely and also listen and hear what other people are saying. Because I guess one really important point I'd make about the CND, because I would always go to side events and meetings that were hosted by people that were critical of US drug policy. And I didn't necessarily agree, but I learned a lot. I learned where they were coming from and realized that some of their criticisms, I mean, I often didn't agree with their diagnosis of what we should do, but when they raised doubts or questions about how we run some of our programs, that's fair game. You know, we shouldn't be hiding, right, from criticism. So it's good not to believe your own propaganda, your own rhetoric. I mean, you know, it's not wrong for the US to put its best foot forward and promote what it does, but it's also important to read the criticism and understand where it's coming from. Next slide, please. Keep going. You have to be careful here because I could go on too long. And I have 9 minutes left. So, you know, in part you can read this, but I really wanted to make the point that we have a lot of tools. You know, these US counter-narcotics programs, I'm really not speaking for the current administration. You know, I'm out on my own and there's new policy-making efforts, which we could talk about, but I would just be speculating. But the way it's always worked is when we have programs and partnerships with countries, there are negotiated agreements and understandings that we have that are signed on what we're going to do with them in their country and what they want from us. These will end up being written documents, signing ceremonies and all that. And then there's usually these at least annual bilateral high-level dialogues. Folks come to Washington, we go to counterparts Capitol, and we discuss policy to manage it. And there's regular contact, us in Washington with our embassy counterparts here and with our embassies downrange. So US Embassy in Mexico City, US Embassy in Bogota, consulates. So there's a lot of action and planning and discussion goes together. And it's assisted a lot by the funding that the US provides to partner countries. And I feel like this bilateral funding, whether it's supply side or demand side, is really a big return on investment for the US. If it's training investigators or people who do interdiction, port inspection, judges, prosecutors, all that is really valuable for countries to build their institutions. And then on the demand side, a bit of money, $1 million here, $1 million there to run or do training for drug prevention alternatives to incarceration. Some of our partner countries have been piloting drug courts and other programs. Really think has benefited the US a lot. And also, if we're paying for running these programs, we're learning a lot about what's happening in those countries. And so I think it's a win-win program. Jacob.
So much of our focus is on the southern border, but we know that we get drugs from the north as well. How cooperative is Canada with the US in like mitigating this?
Well, I mean, both things are true. There is a problem with northern border because it's not nearly as well covered as the southern border. And there's drugs and money move both ways across the northern border. But the Canadian authorities are very cooperative and there are a lot of exchanges and conversations. So it's not at the scale of what we have in Mexico, but it is a concern because certainly if I was a trafficker and I had 100 or say 1,000, let's just say 100 kilos of fentanyl I wanted to get in the US, traffickers are very resourceful. So they will look for whatever works to get their drugs to market. So yes, they can do all these things that the traffickers do, that you might have seen on TV shows or Narcos, of smuggling them across on people in hidden vehicles, trains, cargo containers, tunnels underground, sometimes drones overboard. But also, they could just like send it up to Vancouver in a cargo container and then move it south. So I think it is an important concern. So just looking down my list here, I think I've covered most. Rosa, you gonna talk about economic sanctions?
Only a little tiny bit.
Okay, so I would just say that, U.S. law enforcement, when we know of a major trafficker or major trafficking group, we want to do an indictment. We'd love to bring them to justice to the U.S. We can't always reach them, but economic sanctions on an individual or their company or their organization make things very difficult for organizations or individuals because they can't access the U.S. Financial system. And banks, when they're looking at a potential transfer of money or an agreement, they run individuals and companies through a software system, and they look to see if anyone has a sanction on them, and they won't move the money. And so that can be a powerful way of punishing people who are involved in drugs. And people don't like to come to the U.S. to go to Disney World, Miami, lot to see here. And families like to go, kids like to study here. And so it's just another way to impose consequences on individuals and entities that are harming the U.S. Let's keep going. Okay, again. So here I'm taking what I said in the first slide, I'm narrowing it down a bit. Changes drug markets by increasing drug potency leads to more addiction and death. That's a strong avenue for a lot of critics of drug policy. Harms impoverished drug-producing farmers and developing countries, and it wastes money that could be better spent on health. And next slide. And so, I'm not saying those are ridiculous things to say. I am just trying to put them in context. There is among drug policy academics and people in government, there's a big debate over this phrase, the iron law of prohibition. It says that whenever something's illegal, it makes everything worse. Drugs become more compact, more potent, more dangerous, less expensive over time. And there's some truth to the trend line of drugs. How about let me get through the slide and then I'll turn to you. Okay. So there's some truth to that. And, I know the data. I mean, drugs have gone down in price and have become more potent. But I don't agree with the idea that the primary driver or the only driver is the fact that they're illegal. Traffickers innovate. Traffickers are in business, right? They're in business to make money, and they're looking for substances and drugs that they can make more money on. And so look at what's happened with marijuana, and look at the variety of alcohol. I mean, where marijuana is legal and where alcohol is legal. The private sector unleashes powerful financial motivation. So I just think that's an oversimplification. And the fact that drugs are illegal imposes consequences and costs. And if drugs were legal, their prices would go down a lot further than they have. I'd say, like some of us in drug policy, maybe we've overpromised and underdelivered on what we're going to do to control drugs, and we've built in the expectations like, hey, you said you were going to increase price and reduce potency, and you haven't done it. And so that is a fair criticism, but I don't think that necessarily translates that if drugs were legal, somehow it would be better.
Yeah, I think you're actually right. Like we've seen it with marijuana. It's legal and it's a lot more potent now than it was 10 years ago. So like legal private finance people are also interested in making drugs more potent and getting the business is getting people to do drugs, whether I'm a legal or an illegal seller.
Yeah. I should have let you talk earlier because you did a really good job explaining it. Let's keep going. Next slide, please. Well, eradication, interdiction, aggressive drug policy programs abroad, they have consequences. I mean, I think the sort of the easiest example to discuss is opium or coca eradication, right? You're taking a product, I mean, these farmers in Colombia, Bolivia, Peru, or Mexico grows opium. They're not like millionaires with their giant estates, right? They're small subsistence farmers. Maybe they're making a bit more money than they would be if they're growing whatever, a corn or pineapple or papaya or something. But they're not, cartels. It's the cartels and drug organizations are buying the product from them. And there's a cruelty of when you go and you eradicate their product and you create hardship on folks. That's reality. I would say that the way to mitigate that is to fund alternatives to incarceration, alternative development programs where you help farmers transition to legal crops and you otherwise help them with licit employment so that you're giving them another option. I mean, what we really, if you're a Colombian government or the US government, you're trying to eradicate coca, you want, if the farmers are farming in an area where it's not viable to grow licit crops, we want people to move, right? We want people to leave that area and go into illicit production, illicit activity. We don't want them to starve, right? We want them to move and produce a illicit crop. And I think that our credibility for spraying and eradicating is stronger if we're helping them going forward. There's a lot of debate, and I don't have time to talk about it in detail. I've really got to wrap up. There's a lot of there's so much coca production now in the Andean Ridge. It's at record levels. It's I think it's about UN reports about 3,600 metric tons of cocaine, maybe 1,000 comes to the US a year. The rest goes around the world. And it's a problem, and it's a shared problem of supply and demand. Next slide. You don't need to go back, but that slide on the corner we saw, that was just the fatalities in Mexico, and I was just acknowledging the severe consequences in Mexico from finding drugs. So this is the way I would answer this question, that it doesn't work, that, hey, we've been fighting the supply side for 100 years and we still have drugs. Okay, well, that's true. But the supply side can only do so much. There isn't an easy fix. If you do less supply reduction, you're going to get more drugs. And so I think it's on us to do a thoughtful job and considering how do we limit the negative consequences of the supply programs while trying to moderate and control the supply. I'm a very strong advocate for demand reduction and more public health investment. But I think for me, someone who's been in government for a long time, worked for Congress, you can't just take the budget for a $1 billion Coast Guard national security cutter and dump it into the SAMHSA budget. It's just that's not how we do appropriations in the country. And besides, that Coast Guard cutter does lots of other things besides drugs. And so my view is absolutely, let's advocate in detail for whatever we need on the public health side. And I have very large proposals in my book that I talk about, but it's not really a profitable exercise to try and take it from one partnership to the other. You just make enemies from the supply side, law enforcement side, who you need as partners, because it's much better to get, say, law enforcement to back your proposal to increase treatment, prevention, recovery programs than it is to try and go to war to them, because we'll lose that one. Next slide, please. So I think I've covered most of this. This bullet about the benefits to these countries from supply rates, I'm not saying this is a no-brainer and you have to accept this on face value, but I would say that I'm disappointed that in Colombia, in Bolivia, and in Peru, that there's been a lot of the progress in the past that was achieved has slipped away. But in the process, we have helped these countries build their capacity. Colombia in particular, they have a very sophisticated law enforcement and security system, more sophisticated than they would have had otherwise, and strengthen these countries. And we should keep doing that. We should try and help these countries develop their capacity, their justice systems. And I just don't think there's any other way we can do it. There really isn't a quick fix. We have to help countries develop their ability. I really try hard in my conversations not to talk only politically, because I think it's interesting to talk about what would a good policy be regardless of political reality. But it is also true that there's no appetite for legalizing fentanyl, methamphetamine, heroin, or cocaine. So we have to work on supply and demand side and work with our partner countries. Next slide, please. So here's a nice slide for those who like Colombian coffee. So these are estimates of the price of a kilo of coffee and a kilo of cocaine, right? Prices are lower than they used to be. We in drug policy wish they were higher. But if cocaine was legal, I'm not saying it would become down to $18 a kilo, but it would become much closer. And if you think of the drug problem we have now, could you imagine if instead of being 35,000, this much cocaine was $100, something like that, or $200? So think about that. Next slide. All right, last one. Keep going. Oh, I have one more after this. Here's my summary. Let's all of us keep up to date on changing trends. I believe, and I think some of the recent experience in Canada suggests that there just isn't a safe supply. That is not necessarily my argument for a draconian, crackdown and arresting everybody, but it's just acknowledging that people need treatment, they need engagement, they need access to recovery coaches, they need low threshold care, all these things. But it's hard to make the system, envision how you make the system work by just giving them access to the drugs that they're addicted to. Both excessive supply control and careless liberalization have consequences. So we need to look for a balance and a thoughtful middle ground. Okay, now last slide. So that's my new book coming out 10 days from today. You could reach me by email. That's my website. That's a LinkedIn. That's a link to the book for pre-sale. And I'm happy, my time is up, and I'm happy to talk about all the parts of the book and my recommendations on the public health demand reduction side. So thank you very much.
Okay, hi, everybody. I should start by saying I am not a drug policy person. I have taught international law and constitutional law and criminal law and procedure, but most of what I know about drug and addiction issues, I just learned in the last half hour or so. I'm going to talk about the real shift that we're seeing, a fundamental shift, I think, in how the US is framing drug policy. And it's a shift from this sort of uneasy mix of public health and law enforcement approaches to a much more militarized approach, both domestically and internationally. And we've all heard the phrase of war on drugs a million times. I think what we're living through right now is a shift of that from metaphor to actual policy as a legal matter and in practice. And I'm particularly going to talk a bit about US strikes on alleged drug smuggling boats, US military action in Venezuela, elsewhere. I don't know how many of you remember the day before the 9/11 terrorist attacks in 2001. George W. Bush, actually, you probably remember the famous picture of George W. Bush when he heard about the 9/11 terrorist attacks. He was reading a book to children. He got a lot of flack because he was holding the picture book upside down. But the reason he was reading a pictured book to children is that he had just the previous day launched a program that he was calling a war on illiteracy. particularly a war on childhood illiteracy, and a $5 billion program was going into trying to improve reading skills for little kids. When George W. Bush said we're waging war on illiteracy, obviously nobody thought he was going to do that with the Marine Corps, right? Nobody thought he was going to do that by dropping bombs on teachers who didn't get adequate test scores or anything like that. Everybody assumed that this was metaphor. I think it's fair to say that until a day or two after September 11, 2001, the phrase "the war on terrorism" was also construed as mainly metaphorical, that the US's framework for thinking about terrorism was essentially a crime framework, that we treated terrorism as a very, very serious crime, form of mass murder, et cetera. It was criminalized under US law, it was criminalized under international law, and so forth. Obviously, what we saw shortly after the 9/11 attacks, the Bush administration said, well, we're in a war on terror. And it became very quickly apparent that they didn't mean that as just metaphor in the way that they had meant the war on illiteracy, or we had always meant the war on drugs. That they saw not just as a metaphor for like, we're really serious about this, we really want to oppose it, but that they meant, no, we're going to have a war. And we promptly, not only went to war in Afghanistan, subsequently Iraq, but engaged in the use of targeted lethal missile strikes and special operations raids on alleged terror suspects around the world in multiple countries, not just Afghanistan and Iraq, but Yemen, Syria, Somalia, a variety of other places, Pakistan. I think what we're seeing right now is a similar shift when it comes to the way we talk about the war on drugs that we are seeing just over the course of the last year since the second Trump administration began, a shift from war on drugs as metaphor to we see it through the legal framework of the law of armed conflict. Which is a really different legal framework than the domestic and international legal frameworks governing crime, et cetera. So I'm going to talk a little bit about how that plays out and all the questions that it raises. And I think that shift, and we saw this happen with the shift to the war on terrorism being literal, not figurative. It raises all kinds of questions about, well, how do you ensure accountability when the executive branch is detaining people, targeting people, killing people, et cetera? How do you ensure oversight? How do you ensure accountability? We've been seeing sort of rapid policy changes with not a whole lot of coherence, either in their justification or how they're being rolled out. And that convergence of the sort of crime and war framework, both domestically and internationally, the unprecedented use of military force in drug interdiction operations, has a lot of implications for how we think about rights and how we think about, as I said, oversight of government action. So what I'm going to do is I'm just going to try to run through quickly some of the developments that we've seen domestically and internationally in the last year. And then I'll circle back a little bit, talk again about their implications. So, as Rich was just saying, and you all know this much better than I do, drugs were largely unregulated domestically in the US until early in the 20th century. And for most of the 20th century, US efforts to counter illicit drugs and addiction involved a mix of efforts to control the supply side through tariffs, through sanctions, through diplomacy, through working cooperatively with law enforcement in other countries. Domestically, we had a mixture of criminalization and more public health-oriented approaches to drugs. By the 1970s, that rhetoric of the war on drugs had become common. I think the first use came in a speech by Nixon, I think in the late 60s. And it was still metaphor, but as I said, this is now seems to be changing. It's very hard to keep track because we've seen rapid changes. But let me run through what has been happening. So right after the Trump administration took office, literally on January 20th, 2025, the president issued executive order 14157, designating cartels and other organizations as foreign terrorist organizations and specially designated global terrorists. That directed the State Department to take appropriate action and said that's the policy of the United States to ensure the total elimination of these organizations' presence in their US and their ability to threaten the territory, safety, and security of the United States. In February, a month later, pursuant to that executive order, the State Department designated 6 Mexican cartels and a couple of transnational cartels as foreign terrorist organizations. What this did in terms of its legal effect triggers the ability of the Justice Department to prosecute alleged cartel members, not just as criminals under some ordinary law for conspiracy and for violation of narcotics, various narcotics statutes, but to actually prosecute people as terrorists and to prosecute those who were in any way connected to alleged cartel members, potentially as people providing material support to terrorism. So suddenly you're a low-level drug smuggler or you're selling drugs on the street. Suddenly we open up the possibility internationally and domestically for saying, okay, you're not just a criminal, you are providing material support to terrorism. And the framework for what we can do, the legal powers of the federal government when we're dealing with terrorism and material support to terrorism are much more open-ended and much more open-ended than sort of normal criminal. I'll come back to that. That designation of cartels as foreign terrorist organizations also allow the imposition of things like secondary economic sanctions, so sanctions against banks that kept money of cartels, et cetera. Companies that do business with companies that do business with cartels, you name it. Also in the late January 2025, the U.S. was offering a $25 million reward for information leading to the arrest of Venezuela's Maduro. And in February 2025, also trying to implement these various executive orders, Attorney General Pam Bondi issued an internal memo to the Justice Department, again framing drug cartels as a direct threat to U.S. sovereignty. And also directing Justice Department personnel to have a preference for low-level alleged cartel affiliates, a preference for immigration removal if they didn't have legal status in the United States, but for high-level suspected cartel members, a preference for aggressive prosecution using enhanced charges, particularly focusing on potential terrorism charges, and also enhanced cooperation with DHS. By August, by the way, that $25 million award for information related to Maduro had gone up to $50 million. And the Attorney General was asserting that Maduro was collaborating with all sorts of foreign terrorist organizations, including various different cartels. Meanwhile, as you know, the Department of Homeland Security, in partnership with the Justice Department, aggressively stepped up immigration enforcement, both at the southwest border but also inside U.S. cities using ICE and Customs and Border Patrol and other federal law enforcement agencies. Some shifting rhetorical justifications for that, but some of the time, one piece of the justification was focusing on cartel affiliates and drug smuggling as a form of international terrorism. We need to get undocumented people who are foreign terrorists because of their association with drug smuggling out of the country. All kinds of constitutional issues, as you know, raised by the stepped up immigration enforcement activities relating to the use of force, search and seizure, habeas, access to counsel, et cetera. But I think the important point here is that stepped up enforcement domestically was also highly militarized. We obviously, the National Guard troops here in DC. We saw them in, Minneapolis. We've seen them in Chicago. We've seen them in Los Angeles. In Los Angeles, National Guard presence was supplemented with active duty Marines, still in the mode, technically speaking, of providing military support to civilian law enforcement, but obviously a much more highly militarized presence when it comes to both immigration and ordinary crime, because in some cases, the militarized support for law enforcement also involved focusing on not only responding to protests that were triggered by the stepped up immigration enforcement, but also focusing on crime in a broader sense, including and especially drug crime. Presence of active duty troops in particular raises a whole other host of domestic issues, including posse comitatus issues, et cetera, which I'm happy to talk about if you're interested in the Q&A. So that's what's been going on domestically. But as you know, we've also seen some pretty big shifts on the international side. Back in February, a year ago, the White House announced, as you know, tariffs on Mexico, Canada, China under IEPA, the International Economic Emergency Powers Act, to, quote, stop poisonous fentanyl and other drugs from flowing into our country. We're currently awaiting a Supreme Court decision on whether the president has the power to impose those tariffs under IEPA. We have no idea. It could be tomorrow. It could be June. So we'll just see when that comes down. By March, we were also imposing secondary tariffs on countries that were importing Venezuelan oil, citing, among other things, the designation of the cartel Tren de Aragua as a foreign terrorist entity. And there had already, I should say, that there had been numerous sanctions targeting the Venezuelan regime that had been imposed under previous presidential administrations. That's why the only new thing was the secondary sanctions, because we already had so many sanctions. I should say that throughout this whole period, we've had ongoing Coast Guard maritime interdiction of boats that were suspected of carrying drugs, of carrying illicit drugs. The Coast Guard, you may already know all of this. Coast Guard normally operates under law enforcement rules during peacetime, and unless there's a designated emergency. They report through the Department of Homeland Security, and their rules concerning the use of lethal force are the same as those of police officers, which is to say, you can't say, I think that guy might be a criminal, I think I'll kill him just in case. You have to wait and see what's happening, and you can use lethal force only when there's an imminent threat to life or threat of serious bodily injury to self or others. And the Coast Guard is the lead federal maritime law enforcement agency. Its activities are governed both, as I said, by domestic US law, the same constitutional standards under things like Tennessee versus Garner that govern the use of lethal force by police officers in the United States, but they're also subject to the law of the sea, although the US never ratified the UN Convention on the Law of the Sea. We accept most of it as binding as matter of customary international law. So typically, even though the Coast Guard itself is not typically viewed as a military entity, and during this period operating under law enforcement rules, period between September 24 and October 2025, the Coast Guard actually interdicted 212 different vessels heading towards the United States, most of them in international waters. They didn't use lethal force in any of those 212 interdictions. It's important to note. I don't have the exact statistics in front of me, but they had a pretty high false positive rate, which is to say about 20% of the boats they interdicted didn't have any illicit narcotics on board. I emphasize that to say, notice that they didn't have to use lethal force, and that there was at least 1 in 5 false positive rate where they interdicted a vessel and then said, oops, never mind, off you go about your business. We thought you were smuggling drugs, you're not, bye-bye, sorry for the inconvenience. Against that backdrop, the US began a significant military buildup near Venezuela starting in August 2025. We deployed a carrier strike group, 12,000 US military personnel. Starting in September of 2025, the US began to use lethal strikes against boats suspected of being drug smuggling boats. This is while these Coast Guard interdictions not involving lethal force are, of course, are ongoing. And many of them are successful. Many of them do, the false positive rate notwithstanding, many of them do result in the seizure of significant amounts of contraband and the transfer of people on those boats to the United States for potential prosecution. But starting in September, the US began to use not just the Coast Guard, but other military forces. They've been a little unwilling to provide information about exactly what forces have been involved, but it seems to involve Navy and Air Force assets and Marine assets used for lethal strikes against suspected drug smuggling boats. We don't know a whole lot of details about this. We do know that as of the beginning of January, the US boat strikes had killed at least 115 people, including 2 men who were killed by that notorious second strike off the coast of Venezuela on September 1st. That's the one where got a lot of attention in the press because the first strike destroyed the boat. There were 2 guys who were clinging to the wreckage and waving their arms, and a second strike killed them too. I'll come back to the legality of this in a minute. But the boat strikes involved vessels that were coming from multiple different countries. The dead included nationals of multiple different countries. Trump's justification for this was that the cartels are actually, and you see a sort of escalation of the kind of the language in the presidential proclamations, now defining cartels as non-state armed groups involved in an armed attack against the United States. And in fact, back in October, this didn't get a lot of press at the time because it was leaked only later. The the White House submitted a notification to Congress under the War Powers Act, saying drug cartels have grown more armed, well-organized, and violent. They illegally and directly cause the death of tens of thousands of American citizens each year. Therefore, the president has determined that the cartels are non-state armed groups. We have designated them terrorist organizations. We've determined that their actions constitute an armed attack against the United States based on the cumulative effect of their actions, and that we are declaring that the U.S. is in a non-international armed conflict with these designated terrorist organizations. We must use force in self-defense against these ongoing attacks. That's a huge move, both rhetorically and legally, right? To shift from saying, hey, these are organized crime on an international level, to saying these are terrorists, to saying we're in an armed conflict against them. We view them as having used force against the United States, and therefore, as a matter of self-defense, we are now obligated to use force against them. Again, I'll come back, I'll talk a little bit more about how to assess those claims in a minute. And then, of course, in January, just last month, the U.S. Special Operations Forces raid, which inside the borders of Venezuela, killed an unknown number of people, but at least 80 or so people, and resulted in the capture of Maduro, who was brought to the United States with his wife for trial. Let me just note a few of the sort of disconnects in all of this. One, of course, is the sort of disconnect between Venezuela and the flow of fentanyl into the United States. Most U.S. overdoses are related to fentanyl these days, but according to U.S. intelligence sources, as I understand it, most fentanyl does not come to the United States by boat. Most of it comes by land across the southwest border, with the source chemicals originating in China. Venezuela doesn't seem to have much of anything to do with that. Venezuela is not a major drug source primarily associated with fentanyl. My understanding is that it's been a transit point for cocaine and marijuana, and Rich, you should chime in if I'm wrong about any of that. And in fact, most of the vessels carrying illicit drugs were not, in fact, even headed to the United States. They were headed to different markets in the Caribbean in particular, according to U.S. intelligence sources. With regard to Maduro himself, no doubt he's a bad guy, but also not much evidence that he has either that he has control over any cartels or even significant links to cartels that bring fentanyl into the United States. So we've seen shifting justifications coming from the White House for these lethal strikes on boats and on Venezuela, ranging from we have to stop the flow of illicit drugs, it's killing Americans, to we need to bring democracy because Maduro is just a bad guy, to more recently, well, we just actually kind of wanted their oil. So never mind the other stuff. Given all this, it's a little hard to see just as a policy matter, the argument for why do we need to use lethal force either against these alleged drug smuggling boats or in Venezuela at all. So all kinds of policy issues here, as you can see, from like, why are we doing this? What does this actually have to do with supply side drug interdiction efforts? We already had the Coast Guard successfully interdicting vessels without using lethal force. We know they get it wrong some of the time. And now if you're killing people with no process, that means that pretty much by definition, some of the time you probably are killing people who are just fishermen, as they claim to do. Let me now shift to that's kind of the backdrop to what's been happening, to shifting to how do we evaluate all of this from a legal perspective. And that core tension, again, is, are we dealing with a form of crime domestically and internationally, or are we dealing with some kind of war? Because the rules, this is a story of two totally different legal regimes, one of which is much more permissive when it comes to the use of force, surveillance, detention, et cetera, and one of which is much less permissive. So the choice of legal frameworks actually makes a huge difference. So talk about the criminal law legal framework. Domestic US law, as I said, generally restricts the use of force by law enforcement to situations where officers are responding, including this applies to Coast Guard, typical maritime law enforcement as well, responding to an imminent threat of death or serious injury. You don't get to say, just as the police don't get to say, well, you might go commit a crime next week or a month from now or a year from now, so we're going to kill you to keep you from doing that because you might hurt somebody in a year. It's got to be, self-defense has got to be, you're coming at me with a gun pointed at me, I can shoot you in self-defense. And that has been that is the framework for use of force for law enforcement when it comes to crime. Under the criminal framework, you can't target people based on their status, meaning you can't say, well, because you're a criminal, we get to kill you. You actually have to go through a whole series of processes, and you can only use force based on somebody's actions at the moment. Under domestic criminal law, obviously if a police officer or a member of the military kills somebody without immediate self-defense justification, it's murder. It's murder under the Uniform Code of Military Justice as well. Internationally, if we're not dealing with armed conflict, the international legal framework governing use of force is actually international human rights law, which parallels US domestic law in terms of allowing the use of lethal force only in self-defense and when there's an imminent threat. So under the sort of law enforcement paradigm, if we're not in a war, those various boat strikes prior to the use of force in Venezuela against Maduro are governed by both domestic US law enforcement rules and by international human rights law, which is parallel. And they would just frankly constitute extrajudicial killings. There was a lot of debate with that second strike on the two guys who were clinging to the wreckage about, well, is that a war crime because the military personnel carried it out? It's not a war crime because it wasn't a war. War crime is irrelevant if there's no war. If a member of the military kills somebody and there's no war, it's just plain murder. It's just plain murder. Yeah, question.
But isn't it an act of war? Like, aren't we, by killing innocent citizens of another country, is that not an act of a declaration of war?
No.
Like, wouldn't that justify them coming back at us and be like, you're shooting and killing, you're murdering our citizens, and now we have a right to defend ourselves too?
So I mean, great question.
Right?
But not, and I'll actually circle back to that a little bit. So not every use of force is an armed attack that triggers an armed conflict. Whether it triggers an armed I mean, think about it like this. States use force against citizens of other states all the time in minor ways. Not all of those are typically construed as triggering a state of armed conflict between the states. And the victim states, the states of nationality of the people killed, didn't say, oh, you've attacked us, we're at war with you, which potentially would trigger an armed conflict framework. These are just, so not every crime, crimes and war.
Around, we might find out.
Well, yeah, so, yes, exactly. So, I mean, this is the tricky part, right? What turns into an armed conflict sufficient to trigger armed conflict rules. But basically, if the US just goes around committing crimes and killing a bunch of people, murdering a bunch of people, that doesn't automatically mean that because we decide to kill people, we've created a war and now we get to say, oh, good news, we're not subject to criminal law anymore because we've announced it as war. This is exactly where, I mean, you've identified exactly the nub of the matter here. So here's the thing, an armed conflict is fact-based, but definitionally a little bit squishy. But typically, as a matter of international law, for an armed conflict to exist, it has to be above some threshold level of violence. And it has to be organized, typically for a political purpose. Examples, right? A barroom brawl. That's not a war. It's not organized. It's not sustained. Typically organized crime, we don't think of as a war. It may be organized. It may have a dual criminal, financial, political purpose, but we don't view typically organized crime as war, even when it is transnational. We never have, even though people may die in the process and law enforcement agents on both sides may be involved in killing people. It doesn't reach that threshold level. This is part of the reason that after 9/11, there was a big debate. Do you consider this crime or war? And there you could actually see arguments on both sides. And there were a lot of people at the time who said, this is a horrific crime. It's a level of crime against humanity, but it's not a war, because it's non-state actors. They weren't using traditional weapons, it was civilian airplanes. On the other side, you could say, well, the scale of death and destruction exceeded that of Pearl Harbor. If that's not enough to trigger an armed conflict, what is when you have 3,000 people dead and so on? I think that was actually a closer case, right? You've got 3,000 dead, and Al-Qaeda was clearly an organized group with an intent to create an armed conflict. But even that was debated pretty hotly at the time. Think of now go to sort of that question of like, well, how many acts of violence equals an armed conflict? And the answer again is it's a fact-based sort of functional determination, but typically it's got to be organized groups engaging in sustained acts of violence against each other above a certain threshold. So it's not just the occasional border skirmish, et cetera. It typically involves, what you think of in your mind as a war, right? US invasion of Iraq, war, for sure. But okay, the trend in the last few decades since 9/11 has been a convergence of the crime and war frameworks. Here's the international law governing war, right? It's typically divided into so-called jus ad bellum, the law about going to war, and jus in bello, the law of what happens once you're in a war. And the UN Charter, Article 2.4, this is the sort of paradigmatic law, international law concerning the use of force. The UN Charter prohibits the use of force to change the political independence or alter the sovereignty or territory of another sovereign state. Typically to go to war, states are supposed to either have the Security Council's blessing or be acting in self-defense. Typically, historically, as an international law matter and the way that international courts have construed it, that also means imminent self-defense. Like, they're going to invade us. We're declaring war. We're in an armed conflict with them. It does not typically mean, well, they might invade us someday in 10 years, or, well, there have been isolated and sporadic armed attacks. And certainly it has never, ever before been construed as your country is not doing enough to stop the illicit flow of drugs into my country, which are leading eventually to the deaths of Americans. And we think you might be profiting from that. We've never construed that as an armed attack of the type that would trigger an international legal right to self-defense. As a matter of international law, the use of force by the US against Maduro inside Venezuela is pretty crystal clear case of illegality as an international law matter. It didn't satisfy UN Charter criteria, et cetera. It was just an illegal act. However, even an illegal act can create an armed conflict. The fact that the US invasion was unlawful as an international law matter, totally different from domestic law, doesn't mean that, now we're in an armed conflict with Venezuela, which in turn means that subsequent strikes after that, now, if the US strikes boats that can have Venezuelan nationals or are Venezuelan boats, now they are part of an armed conflict. Now they are governed by the jus in bello rules concerning how you can use force. Now, if we target boat strikes that turn out to contain civilians, and almost all of them will, it would be a war crime. So it's bad either way, right? It's just a question of, it's only a war crime if there's war. If it's not a war, it's just regular old murder, which is just as bad. Calling it a war crime doesn't actually make it worse. It just means it's governed by a slightly different legal framework. But during armed conflicts, the government can target people based on their status. You can say, well, you're a member of the German army. We can target you, drop a bomb on you while you're sleeping. It's legal. You don't have to wait for them to be running towards you with a gun. And during an armed conflict, you do not need search warrants. You do not get judicial review, typically, et cetera. Law of armed conflict allows status-based targeting. It allows enemy combatants to be detained for the duration of the conflict. You don't get habeas if you're an enemy combatant, typically, if you're uniformed personnel. So it changes the rules pretty substantially, the use, including over things like surveillance as well. Surveillance, censorship, detention, targeting, all of those are different. And when you're in a law of armed conflict situation, they're much more permissive, and we typically do not have any judicial review. So by starting now an armed conflict, even if we weren't in one before, right? Now we're in one for sure. One of the legal consequences of that for the Trump administration potentially is much less potential for judicial oversight of any of these actions. And I think what we need to, and here's the point, sort of, what does all this mean, right, for us domestically as well? I mean, internationally, it's a mess. It's changing every moment. Some boat strikes have occurred since the Venezuela raid. If we're in an armed conflict, by the way, with Venezuela, then Maduro technically ought to be given prisoner of war status, and his wife would be treated as a protected person, as a civilian, which also affects what we can charge them with. I have no idea how this is all going to shake out in the courts in New York, where the indictment has taken place. But the current legal landscape is just, frankly, a total mess. This is really unprecedented. We don't know what legal framework the administration views as governing its drug interdiction activities more broadly, and there have been kind of shifting between. We still have these ongoing Coast Guard operations under standard law enforcement rules. At the same time, we're continuing to carry out lethal strikes. It's not completely clear how many of them are against Venezuelan flagships or Venezuelan nationals. If they are, those would be governed by the law of armed conflict at this point. If we're still targeting people who've got nothing to do with Venezuela, even if we think they're connected to some other cartel, those should still be governed by the law enforcement framework, which says, no, you don't get to just use lethal force. This is a long-winded way of saying that almost all of those boat strikes are unlawful. Most of them are unlawful because there is no armed conflict. There was no armed conflict. You don't get to just, you're not supposed to, at least. You turns out you do get to. You run around the world just killing people because you think they're doing bad stuff. Some of them now probably are governed by the law of armed conflict, but if there's no particular evidence that the people you're targeting in these lethal strikes are in fact members of an organized armed group that is in that armed conflict, then they're civilians and then they're war crimes, right? So again, you pick your legal regime, it's either murder or it's war crimes. But I think what I worry about most is the potential sort of spillover of the war framework into domestic law. And we're seeing that already. And I think, as I said, the sort of the broader trend is towards a kind of a militarization of immigration enforcement and military, which is not unrelated to the justification for, designating drug-related cartels as foreign terrorist organizations and armed groups. So that leads to a more militarized approach to immigration enforcement, a more militarized approach to drug interdiction outside of U.S. borders, more prosecution of suspected drug smugglers or even drug dealers as terrorists or people providing material support to terrorism. It's very, very hard to know what to say about any of all this, except that it's changing so fast. I mean, Rich gave us a slide on all of the types of international supply side reduction effort the U.S. traditionally engages in. Some of those are still going on right this minute. There are hardworking lawyers and Justice Department and elsewhere who are beavering away at all of that. But meanwhile, the administration has literally and metaphorically kind of blown this all up by sort of saying, well, except when we feel like it, we're just going to decide that if we suspect you of being involved in drugs smuggling into the United States, we might decide that we're at war with you and we're going to use force. Even when it is manifestly unlawful under international law, that doesn't automatically translate into any consequence. The U.S. is still a superpower. The international criminal legal framework is very weak when it comes to enforcement. So despite a lot of global outcry, it's not particularly clear what the consequences are going to be. I do worry also, as I said, domestically, the courts are traditionally much more deferential to the executive branch when national security is at stake or when the president says there is an armed conflict. We're seeing that all playing out in real time right now, right? And we're also seeing the president talking about potentially invoking the Insurrection Act, which would be an additional basis to step up the use of active duty military troops inside the United States, whether for immigration related purposes or for ordinary crime control by calling something an insurrection. So what we're seeing over and over is a sort of, the administration says it's a war and they're doing that because it triggers this much more permissive legal framework. How all of this plays out in the next few years, I have no idea. What all of this is going to mean for drug policy specifically, I have no idea. But keep in mind, and I don't know all of your all backgrounds and the kind of work that you each do as individually, that this is just a big question mark hovering over everything, because the impact of this remains to be seen whether this has any impact whatsoever on actual flow of illicit narcotics, given that disconnect between where are the drugs actually coming from and what we've been doing. But I do think it is going to lead to more aggressive but highly selective and probably fairly incoherent enforcement using terrorism charges, using extended detention that will not be subject to sort of ordinary criminals suspect detention because people will be alleged to be enemy combatants, et cetera, and probably a continued but sporadic and selective use of lethal military force to target suspected drug smugglers. So we'll see what happens. And in any case, happy to answer any questions or continue any part of that conversation that's of interest to all of you.
Any questions?
What, we're here.
Realistically, though, if someone says the US made a war crime, whatever. Who indicts them? Like, who goes like, yeah, like the UN exists, the criminal courts, the international courts exist, but you have all the power. So if a judge says, yeah, you committed a war crime, then who's gonna bring you to justice?
Yeah. Very fair question. I mean, some countries have under theories of universal jurisdiction for certain kinds of, if any of you remember international law, if you took use Kogan's violations, genocide, torture, et cetera, some countries using universal jurisdiction statutes have at times attempted to hold even foreign government officials accountable. Very, very hard to do given the realities of political power in the world that we live in. Might there be under some future US administration some form of legal accountability? Maybe. But I think this is part of a broader story of just the breakdown and fragmentation and legitimacy crisis of international law and institutions. As we see the US, I mean, the US has always been a little bit of a international law for thee, but not for me power. And I think the shift now with this administration, previous administrations at least pretended that they cared about international law. They didn't always abide by it. In fact, they frequently didn't. E.g., invasion of Iraq was pretty unlawful as a matter of international law governing the use of force. But they at least made a sort of strenuous effort to justify their actions as a matter of international law and domestic law. I think the difference with the Trump administration is they really aren't bothering. And we see that both domestically and internationally. They're just saying, this is what we're doing. Good luck to you.
That's depressing.
Yeah, it is depressing, isn't it?
Yeah, I have a question. It's a little bit theoretical, but a bit naive on my part. So what is the motor or the drive behind the current administration to approach the fentanyl epidemic in this way? Is it the constituents and the amount of loss of life? Is there an economic number that's being, tossed around behind closed doors? Do we have any sort of like a legal understanding as to how it got to this point, and in addition to the obvious loss of American life?
You want me to take that?
I was gonna say, you're asking us to try to understand what goes on inside the minds of people who I.
Not literally, that's why it's a bit naive, but I wanted to put it out there. You know, do we have any thoughts on that?
I tell you, since I'm outside of government, I can say whatever I want. I don't view it actually as anything but a way to get at strategic concerns over Venezuela. I mean, you're all referencing correctly the misstatement by President Trump that there was bags of fentanyl floating in the water after attacking some boats, and that was soon corrected. And everyone knows that, right? There isn't that, as was mentioned, that it's not where the fentanyl comes from. There is cocaine moving through Venezuela. But the way I view it is just they wanted to change this regime, which admittedly is a very terrible regime. And they focused on the narcotics as a way of getting at it. So I think that maybe we're doing ourselves a disservice to try and figure out like a coherent drug policy aspect of it. I think it was a strategic policy that we've had this just very bad regime, the Western Hemisphere, that's hurt a lot of people, sent a lot of people leaving the country because of economic problems. Chavez and Maduro destroyed the Venezuelan economy, and so it is a real problem. And I think this was the Trump administration's effort to address it.
Generous response.
Yeah, that actually led right into what one of my concerns is the Trump administration using the war on drugs as a guise to carry out his other, alternative political agendas abroad without any consequence or accountability. And I was going to ask, what checks and balances do we have left to curb that kind of, I want to say tyranny, that kind of unchecked power? And
well, I mean, this is something that in normal times, Congress would do investigations and do hearings, and maybe that'll be possible in the future. I mean, that is the normal way Washington works when something's controversial happens. Congress has that authority, and we'll see what happens in the future.
I think it's pretty likely that on the tariffs, the Supreme Court is going to say, no, you can't do that under IEPA. I don't know that that's going to matter a whole lot, because I think there are one of the trend lines in the past, 50 plus years has been a steady accretion of power in the executive branch relative to Congress. And a steady increase in the amount of legislation with emergency powers that are triggered at the discretion of the president, where there's nothing in the language of the legislation that sort of says, well, and this can be suspended if there's a national emergency as declared by the president, and nothing in the language that says, well, how do you know if there's really an emergency? And that's, I think, a problem that legal scholars and others have been trying to draw attention to for many, many decades, that if you have a whole edifice where prevention of abuse is dependent on kind of the good faith and self-restraint of the executive branch, and then you get someone who is not acting with restraint or potentially not acting in good faith, you don't have a lot of mechanisms to do anything about that. I do think it's important, should we get through this period, which I hope we will, to start thinking about, well, what should Congress do in the future to restrain some of those emergency powers? None of this is impossible, but it requires a sort of cultural and behavioral shift. I mean, I worked in the Obama administration at the Defense Department, but I was very distressed by the Obama administration's use of targeted killings around the globe for exactly this reason, because once you have the president saying, I can kill people anywhere, anytime, based on information that is secret, and I don't have to reveal that information to anybody, and there is no judicial review, because can't trust courts. These are battlefield commander-in-chief decisions. Once you have that, I did actually trust the Obama administration not to be just misusing that to kill political dissidents or, I trusted them to be acting in good faith, which doesn't mean you can act in good faith and still make mistakes, right? And that bothered me very much, that there was no external review mechanism to try to minimize mistakes. But what bothered me even more is that you're creating this claim of power, you're creating a set of precedents that are wide open for abuse. I mean, this is, of course, the exact same argument that Vladimir Putin has used to assassinate dissidents around the world has been, well, they were terrorists, and it's secret. The information that proves that they were terrorists is classified, but it was completely justified for me. It's not illegal, it's not murder, it was a justified strike against an enemy combatant. We've seen foreign powers use that argument, and we usually don't like it when they do it. And now it's wide open for abuse. So I think the challenge for the future is how do we make sure that future American executive branches do not have that open-ended power that is so easily abused.
We need to restore the balance of power. We need to restore the balance of power.
You talked about the spillover into domestic affairs of what's happening internationally. How do you assess the fact that we've had the Director of National Intelligence now in Fulton County for an FBI raid on the election
Does not make me
facility
happy. Does not make me happy. Yeah, I mean, and
is that a manifestation, do you see, of exactly what you're talking about?
I do. I mean, that sort of spillover, some of this is understandable, right? That we live in a globalized world where national borders do not stop the flow of pollution, disease, disinformation, illicit funds, drugs, you name it. And so I do think that it is completely reasonable to say a legal framework that is premised on these extremely sharp distinctions between what you're allowed to do extraterritorially and what you're allowed to do domestically make less and less sense. That being said, to me, that is not an argument for, okay, then anything goes. We can label anything a national security threat. We can label anyone a terrorist. We can enable anything that hurts people an armed attack, no matter how indirect, and therefore all domestic rules fly out the window. I think you could have a legal framework that recognizes that many, many threats are transnational, including disinformation threats to voting integrity and so on, but that then says, therefore, we need an even more robust checks and balances. We need even more robust forms of judicial review, precisely because at the moment we're vulnerable to these two legal frameworks. Once you invoke national security or war, you get this very permissive framework. That doesn't make sense. If we're in a world where it's harder and harder to draw those distinctions, then you need to have more robust forms of oversight and checks, whether we're talking about strictly domestic, strictly international, or some complicated mix of the two. And we've seen, I don't think President Trump is the first president to take advantage of that fuzzy area where you could sort of make the argument that national security and emergency rules or war rules apply, but you could sort of make the argument that they don't. I think we've seen every president since 9/11 take advantage of that gray area in some way or another, Democratic and Republican alike. I think we're seeing the Trump administration do it in a much more egregious and unrule-bound way than we've seen any previous administration do it, though, and really highlighting the potential for abuse much more blatantly. Or I shouldn't say potential for abuse.
Great. Well, thank you so much. Please join me in thanking them. Great thoughts. We have snacks outside if you want to talk. We don't have anything else. You're our final panel. Tomorrow morning we kick off at 9 with Shelley Weissman and Sazula Wadan to talk about legal parameters and recovery. And we look forward to seeing you all tomorrow.